Testing, testing. Testing.
Good morning, everyone. All right, we're going to start this. I'm so glad everybody's here. I wanted to introduce myself to you. Many of you know me. Pat Telungan. I'm the co-founder of the Children's Neuroblastoma Cancer Foundation. We started the foundation in 2000. I lost my son, Nick, to neuroblastoma back in 1999, and stage 4. Went through treatment for the 4 years, but unfortunately, he didn't make it. But what it was a true inspiration to me, because we didn't have a whole lot of information available to us, because I'm old and this is pre-internet. So I had one piece of paper that gave me information about neuroblastoma. And so that really bothered me, that there just was not enough information. And so that became, one of the main premises of starting CNCF, was to provide the families, with the necessary resources and information that they need, to make informed choices, because everything is different, everything is evolving, and, everything has to change. And so we're hoping what this conference does, for you is to provide, the resources and everything so you can make these decisions. And again, this was back in 1995, and so much has changed, since then. So what we hope is, again, you walk away, from this conference with some knowledge maybe you didn't have before, or maybe you're hearing a word, you heard it before, but you didn't really know what it is, and now you know what it is. So again, everything is an evolving process, and so it's important for us to continue to keep having these conferences. We encourage you to please keep coming back, again, because everybody's situation, could change today, could change tomorrow. We do try to take care of all aspects of neuroblastoma if we can, because so many families are brand new families. There are families here whose children have relapsed or have refractory disease. We have parents who have lost their children. and we have long-term survivors. So our goal is to make sure that, we have a program available for everybody. Sometimes it works and sometimes it doesn't. We do our best to make sure that, we address as many issues as possible. So that's who we are, that's what we've done, that's the premise of these conferences. We've awarded almost $3 million in research at hospitals across the country. So, we do CHOP, we do Sloan, we do CHLA, NANT, so we do try to determine, we have a medical advisory board that reviews our grant applications. And so, again, try to, fund as much research as we possibly can in various areas. I don't know if all of you have seen, but we have a parent handbook online that, again, is constantly changing and evolving. So that's another thing that we hope you find, valuable. We, again, trying to update it as much as we can. We have a medical advisory board, Dr. Daryl Yamashiro from Columbia, Dr. Chung from Sloan, Dr. Patrick Reynolds from Texas Tech, Dr. Bagatelle from CHOP, Dr. Julie Park at St. Jude now, and Sue Cohn and John Maris are our consultants. So the way we work this conference is each doctor will give a 30-minute presentation, and we'll have a 15 to 20-minute question and answer session after each presentation. We do ask that, I know it's hard, but we do ask if you're going to ask questions that you do them as general as possible and not make it about your child and specific things, just so that we can, again, get a very broad spectrum of questions and some good answers for you. So if you could keep that in mind. We have 2 microphones set up, one over there, one over there. So, and we are live streaming it. So, and what we would like is to come up, ask your questions, and make sure that, we do talk to each other. And I know people are going to start talking amongst each other, but if we could keep it at the microphones, that would be good, because we want to make sure the people who are watching get the full value, of what's being said here. Let's see, to have that. And 2, if you have any questions, or if you're afraid to stand up and talk, write them down, and we'll go ahead and present it to the speaker either now or afterwards. Okay, this conference too it's meant for education, and I know you're going to want to talk to all the doctors and everything. We do ask, though, that this not be like a session where you're getting like a second opinion. Again, I hate to say, speak in generalities if you can, and if you do want a second opinion, please ask for the information as to how you get, a second opinion for your child. We have a kids room, so for those of you who brought your children, they should have a good time in there. I saw a painting. We do have a balloon maker who's fantastic. We have a face painter who's really good. They will be here in the afternoon with the kids, having a good time. So there's plenty of arts and crafts. They have movies. They have Xbox. Is that the current one? I don't know. I'm not into that. Nintendo Switch and all that. So the other thing is we'll have lunch together. So at lunchtime, you can go grab your kids and then bring them back into this room over here. But when we have a break, you will not be bringing your kids, because it's only a very short 15-minute break. The other thing is, too, is because when they see you, they're not going to want to let you go. So if you can, avoid it, great. If you can't, let us know, and you can talk with Sherry and her daughter Cassie in the kids' room. Let's see. If anybody's sick, the kids are sick, again, we ask you not to have them in the kids' room. Friday night, tonight, I think it's 6 or 6:30, we have a really nice dinner. We have a DJ coming. I anticipate everyone will be up on the dance floor dancing. I don't want to see anybody in a chair. You're all going to get up. We're going to do a conga line like we always do. So start getting your muscles all loose and everything. So, and I wanted to thank my assistant, Nikki DiBenedetto. I don't know if she's here or not. for making all the travel arrangements for the families who needed them, for updating our Facebook, our website, anything and everything. She coordinates and helps out that way. She's, you know, a wonderful person to have with us. I wanted to thank Sherry and Cassie for running the kids' room for us. Again, Mike Mothy, our balloon maker, will be here with his wife. They donate their time. They're wonderful people. Have Hannah. People were here last year. Our DJ is Hannah. She will be here again. I have Mike Applebaum helping us with the video. We have Elvaro, who's helping us with the video and live streaming, so I wanted to thank them for their assistance here. And I do want to acknowledge our supporters for this conference, because without them, this conference, we wouldn't be able to have it. It's just, you know, it's a very costly event, but what our goal is to make sure that none of you have to put out hundreds and hundreds and hundreds of dollars, because everybody needs an equal opportunity to learn. So if you have the money, great, you know, you can pay, but if you don't, we want to make sure that you have the capability and the ability to be here. So we do subsidize the hotel rooms. Almost all your meals are free. So I just wanted to thank the wonderful people who have supported it, and that's YMABS, Therapeutics, Jubilant, Radiopharma, U.S. World Meds, the Thank Foundation, Dr. Chung and his wife Irene, the Frock Foundation, the Friends of Catherine, A.J. Nafso family, and the Fagan Family Foundation, and the Nick Foundation of Northwest Indiana. And like I said, this just is extremely, you know, costly for us, but I wouldn't have it any other way. I mean, to see all your faces and to you people making, you know, lifelong friendships, because as we talked, you can't always talk to your friend, your neighbor, because they don't get it. So to be able to look in each other's eyes and know exactly what's going on, to me is priceless, and we continue to keep having these as long as we possibly can. So that's it for my part of it. And we're going to go ahead and begin our introduction. Ami, what did I do with your sheet? Here it is. It's like I'm trying to add stuff to it here. Our first presenter is Dr. Ami Desai. She's an attending physician at Comer Children's Hospital at the University of Chicago. She is an associate professor at the University of Chicago, Comer Children's. She received her MD at Robert Wood Johnson Medical School and completed her residency at Yale New Haven Hospital and her fellowship at Children's Hospital Philadelphia. Her area of expertise is neuroblastoma and other solid tumor cancers, as well as developmental therapeutics and adolescent and young adult cancer care. She is a member of numerous associations, and she's a program leader for solid tumor and an active member of COG in the neuroblastoma community. She will be talking today on neuroblastoma basics. Dr. Ami Desai.
All right, good morning, everyone. It is a pleasure to be here today and see some familiar faces and old colleagues, people who trained me along the way, and other friends as well, too. So today, my talk is going to be neuroblastoma basics, and I hope this sets the foundation for the other talks that you'll hear during the course of these 2 days. These are my disclosures. All right, so as all of you know in this room, neuroblastoma is the most common solid extracranial malignancy in children, so outside of the brain. It originates from neural crest tissue, and most commonly in the adrenal glands, or the organs that sit right above the kidneys, as well as the sympathetic ganglia, so it could present as a mass anywhere from the neck into the pelvis. And it is classified as a small round blue cell tumor based on the way it looks under the microscope. There are about 750 to 800 new cases per year in the US, and it makes up about 7% of all childhood cancers. And of all the patients diagnosed in the US, about half of these children will have high-risk disease. And we know that there is a higher prevalence of high-risk disease in Blacks and Native Americans. And if you look at this plot on the right, in the red are the incidence of patients with neuroblastoma by age. And as you can see, it's really a malignancy of infancy and younger childhood. And as you get into older childhood and adolescence, the incidence of this really drops. Neuroblastoma is very much known for its broad spectrum of clinical behavior, which is really reflective of the biology of the tumor, where there are certain tumors that may spontaneously regress on their own, or patients who may just need surgery as part of their therapy. Others will need chemotherapy or really intensive multimodality therapy, including chemotherapy, surgery, transplant, and immunotherapy. So there's really no consistent environmental factor identified in the etiology of neuroblastoma, and this is just a question we get a lot from families when they're first diagnosed. There is a small percentage of patients who may have a family history or presentation that may be consistent with having a germline mutation leading to neuroblastoma, and Dr. Sokol will go over this in more detail in her talk. There are certain syndromes that may predispose one to develop neuroblastoma, such as Costello syndrome, Noonan syndrome, Beckwith-Wiedemann syndrome, and Li-Fraumeni syndrome. And another question comes up, especially based on all the screening that we do in the adult population. Is there a role for screening in the general population? So in the past, there were population-based studies completed where urine catecholamines, urine HVA, VMA were measured in infants less than a year of age in Japan, Canada, and Germany. And in these studies, they saw that there were increased rates of diagnosis, but these were really early-stage tumors that were mostly those of favorable biology and may have regressed on their own. And identifying these patients actually did not decrease mortality. So the conclusion really was that tumors diagnosed in infants by mass screening are unlikely to progress to life-threatening advanced stage disease, and many are likely to spontaneously regress. So more patients were being identified, but however, with interventions, there may actually be more morbidity than help for these children. As for the clinical presentation, it can present as, neuroblastoma can present as an asymptomatic mass, again, anywhere from the neck into the pelvis, given the location of the sympathetic chain. Horner syndrome, or if you have compression of the stellate ganglion or one of the sympathetic ganglia. Spinal cord compression, as it can be paraspinal and encroach into the spinal space. Big liver or hepatomegaly, pallor, skin lesions. Or you could have systemic symptoms such as weight loss, irritability, fever, hypertension. This we tend to see more with disseminated disease or stage 4 disease. Patients may present with VIP syndrome or this intractable diarrhea on rare occurrences, and may also present with opsoclonus myoclonus syndrome or dancing eyes, dancing feet. And this is usually associated with more favorable type tumors, the opsoclonus myoclonus. As for, we can also see bone pain or patients with a limp or refusal to walk, and again, this is often seen in patients with disseminated disease. And patients can also present with raccoon eyes. I just briefly wanted to touch on the adolescent young adult population. I mentioned that neuroblastoma tends to happen in younger children, and it's really a very different type of disease in older patients, and it's rare for it to occur in this population as well. And they tend to have more of an indolent disease course and may not be as responsive to some of our conventional therapies. And they do tend to have inferior outcomes compared to younger patients. And they do tend to have a unique tumor biology. Their tumors may have segmental chromosomal aberrations or ATRX mutations. And there is a need for novel therapies for this group of patients. So as for evaluations and tests, of course, we start with a full history and physical exam. We will start by drawing blood counts or a CBC to see if any transfusions are needed or if any blood counts are low that might indicate marrow disease, blood chemistries, LDH ferritin, urine catecholamine metabolites, HVA and VMA. And we will then proceed with tumor imaging as well, and this can include a CAT scan or MRI. And we will also, if we are suspicious of neuroblastoma, have patients undergo an MIBG scan, which I'll talk about a bit more in the next few slides, versus a PET scan. About 90% of neuroblastomas are MIBG avid at diagnosis. And then, of course, to confirm the diagnosis, we will proceed with a biopsy to look at the tissue under the microscope and also look in the bone marrows to assess for disease in that location. So neuroblastoma is diagnosed by unequivocal pathologic examination of tumor tissue, again by a biopsy, or unequivocal tumor cells in the bone marrow combined with a detection of elevated urinary catecholamines, and that may happen in patients who might not be able to undergo a tissue diagnosis or biopsy of their tumor. So I mentioned MIBG scans, which I'm sure everyone in this room is familiar with, but MIBG is an analog of norepinephrine and is labeled with radioactive iodine and taken up by neuroblastoma cells. And essentially, the tracer is attached to a small amount of radioactive iodine that makes the neuroblastoma light up on the scans. And then we try to quantify how much disease is there by something called a Curie score, which I'll go into in the next slide. And to note, there is normal uptake in the salivary glands, bladder, and liver, so we are aware of that. And we'll prescribe our patients thyroid protection with SSKI drops or Lugol's, as you may have heard, the potassium iodine helping to protect the thyroid from the MIBG uptake. So this is someone we fondly call Curie Man, and as you can see, he's broken up into multiple sections, and based on this, we come up with a bone score and a soft tissue score, and that helps us quantify how much disease may be present at diagnosis and then present along the way as patients go through therapy. So as for neuroblastoma prognostic markers, there have been many markers that have been investigated over the years, and 5 important markers that really help us risk stratify our patients are the stage of disease, age of the patient, MICN status, ploidy of the tumor, and histology, or how it looks under the microscope. And then more recently, other things are being added to help further risk classify patients, and this includes things such as segmental chromosomal aberrations. So again, this is just to focus on the 5 major prognostic factors, again being age, stage, MICN status of the tumor, histology, and tumor cell ploidy, with age being broken up at about 18 months. Stage of the tumor, we used to use the International Neuroblastoma staging system, where we stage things 1 to 4S, and now there's a newer staging system that I'll go into, which is the INRG staging system, L1, L2, M, and MS. Whether the tumor is MICN amplified or non-amplified, whether there's favorable or unfavorable histology under the microscope, and how much DNA content is within the tumor as well. And putting all of these 5 things together helps us, you can see this chart, risk stratify our patients. And I just wanted to focus on one thing. For patients who are greater than or equal to 18 months of age, who do have stage 4 disease, these patients are automatically high risk despite other markers of their tumor biology. And I briefly wanted to touch on the INRG task force, and Dr. Applebaum will go through the INRG database as part of his talk. But the International Neuroblastoma Risk Group Task Force convened in 2005, and it was really put together to help address the problem of non-uniformly defined risk groups in neuroblastomas. You know, in the US and in Europe, we tend to risk stratify patients a little bit differently. And they also helped develop a pre-treatment staging system, the INRG staging system that I will go into. And this now includes image-defined risk factors, or the identification of tumor wrapping around important blood vessels or critical structures that may make it more difficult for a surgeon to take out the tumor or may represent a more biologically aggressive tumor. And this is not dependent on the degree of surgical resection like the previous classification system. So there was a proposed new risk classification system that came out of this task force, and this was derived from 8,800 patients diagnosed between 1990 and 2002 across the world. And out of a bunch of statistical analyses and regression analyses, they saw that prognostic factors within this cohort included INRG stage, age, histologic category, grade of differentiation, MICN status, 11q aberration, and tumor cell ploidy. So to touch briefly on the International Neuroblastoma Risk Group staging system, again, this is a pre-treatment staging system and based on image-defined risk factors. So now, simply put, L1 tumors are localized tumors without these image-defined risk factors. L2 tumors are local regional tumors with 1 or more image-defined risk factors. Stage M represent distant metastatic disease, except the MS group, which again are a unique group of patients less than 18 months of age that may have lower stage tumors with metastatic disease confined to the skin, liver, or bone marrow within 10%. And I'm not going to go through all of these, but these are some examples of image-defined risk factors. So again, tumors wrapping around really important blood vessels or really very close to important structures within the body. And this slide just shows some of the differences between the two staging systems. So stage 1, 2A, 2B, and 3 tumors are now grouped into this L1 and L2 group. Stage M is the same as the previous stage 4, and MS overall is the same as 4S, except with a little bit of change to the definition, including children under 18 months of age. And here is the proposed international risk group classification schema that we're not technically using at this time, but is a way to propose doing global studies for patients with neuroblastoma and having everyone uniformly risk stratified. I'm going to end this section on risk stratification by just touching on our newer COG risk classification system. So given the new staging system, there are a few plots that I'm going to show that starts with what type of tumor. So having an L1 tumor, and then defining the risk group based on age, tumor size, extent of surgical resection, MICN status, helps us stratify patients into low or high risk in this group. And then again, for L2 tumors, we take into account MICN status, age, histology, ploidy, and segmental chromosomal aberrations, which is the newer thing compared to the prior staging system. For stage M, age, MICN status, histology, ploidy, and segmental chromosomal aberrations. And for MS tumors, age, MICN status, symptoms, histology, ploidy, and segmental chromosomal aberrations. And again, this helps us risk stratify our patients and will be used in future studies. So what is our current approach to treating neuroblastoma? And in this section of the talk, I'm going to talk about why we do what we do, how we got to certain treatments that we are administering to our patients, and a little bit of a basics on clinical trials. So our current treatment approach is to tailor treatment according to predicted behavior based on clinical characteristics and tumor biology. And you can see that a lot based on how we risk stratify our patients. And it is not possible to learn what treatment is best if each patient is treated differently. And there are circumstances where we think we may have to take someone off a clinical trial, or maybe they aren't the right patient for a clinical trial, and maybe we have to treat them in a different way based on what their response is. So of course there are those scenarios. A series of clinical trials for children with low, intermediate, and high-risk neuroblastoma have been ongoing for decades to identify treatment strategies with optimal survival rates with minimal toxicity, with the hope of minimal toxicity. So what are clinical trials? They are studies involving people that can make progress in preventing, diagnosing, and treating cancer. And each clinical trial follows a set of rules called a protocol that describes who can participate in the study and how the treatment will be given and monitored. And there's a lot of statistics involved in making sure that the patient safety is taken into account as the protocol moves forward, and to see what we call monitoring rules. If behind the scenes is someone doing better, or one group of patients doing better than another, does this study need to end sooner than its actual timeline? And then governmental and non-governmental organizations may sponsor clinical trials. And clinical trials remain the most reliable and only accepted scientific method to find out if a new treatment works better than the current standard of care. So it's important to learn as much as possible about a clinical trial before participating, and talking with your doctor and the research team can help you understand what to expect from a clinical trial. And I've definitely encountered different conversations with families, and some are very interested and want exposure to a new agent that may potentially improve outcomes, and other families feel much more comfortable sticking with standard of care. And so it's definitely an informed but personal choice that each family makes. So certain questions that come up that are important to ask your provider: what clinical trials are appropriate for me? What is the purpose of this clinical trial? Why does the research team think this treatment, drug, or medical device will work? Why is this specific approach being studied? What are other treatment options that are available to me, including other clinical trials or standard of care or other options? And who or what organization is sponsoring the clinical trial? So who can participate on trial is determined by inclusion and exclusion criteria. These criteria are based on person's age, type of disease, medical history, and current health. Inclusion criteria may help make sure that all patients in the clinical trial are medically similar. For example, all patients having high-risk neuroblastoma on a specific study. And if people have too many medical differences, it's difficult to interpret the results. And exclusion criteria help keep people safe. And this is just a brief overview of clinical trial phases. So clinical trials are made up of distinct parts called phases. And a phase 1 study is where clinical trials are used to show that a new treatment is safe for a small group of people and find the dose of the drug. A phase 2 trial is now you have the dose and you want to investigate it in a specific population to see how well it works or how responsive the tumor is to the treatment. And phase 3 clinical trials compare the new treatment with the standard treatment in a large group of people. So these phase 3 trials is really what we talk about in the frontline setting. So phase 3 clinical trials, the goal of these trials is to take new treatment that has shown promising results when used for a small group of patients, for example, in a phase 2 study, and compare it with the current standard of care for the specific disease. In this phase, data are gathered from large numbers of patients to find out whether the new treatment is more effective and possibly has fewer side effects than current standard treatment. Phase 3 trials are usually randomized, meaning the patients receive either the investigational treatment or the standard treatment in a non-ordered way. That is, for the most part. There are times where certain phase 3 trials are not randomized. All right, so that's just a little bit of a primer on clinical trials, and I just wanted to highlight a few trials in the low, intermediate, and high-risk groups that have informed how we treat patients currently. So the first study is P9641, which for the low-risk population, the question was to demonstrate, or the objective was to demonstrate that surgery alone would achieve 3-year overall survival, or greater than 95%, for patients with asymptomatic INSS stage 2A or B neuroblastoma. And in this study, they had patients who were asymptomatic receive surgery alone and not chemotherapy immediately and get the best maximal surgery. And then symptomatic patients got anywhere from 2 to 4 cycles of chemotherapy plus surgery. And what they saw was through this approach, excellent outcomes were obtained. And when they compared the patients who got surgery alone to those with chemo plus surgery, the outcomes were very similar. So in general, for low-risk patients, we tend to use surgical resection as our primary modality of therapy. Chemotherapy may be used in certain situations, and there are small cohorts of patients that can be observed as well. Moving on to intermediate risk neuroblastoma, I was just going to highlight 2 trials here. One is A3961, which the objective of this study was to determine whether a 3-year estimated overall survival of more than 90% could be maintained with reductions in the duration of therapy and drug doses using a tumor biology-based therapy assignment. And you could see the trend for low and intermediate risk neuroblastoma. Many of these trials where these patients are doing quite well, and how could we further reduce therapy in some groups of patients while maintaining good outcomes? So that's really the goal of these non-high-risk studies. And here, patients with favorable biology tumors had 4 cycles of chemotherapy plus surgery, and those with unfavorable biology had 8 cycles of chemotherapy plus surgery. And again, excellent outcomes were maintained with this approach. And what this study showed was that for intermediate risk therapy, you can reduce therapy while maintaining excellent outcomes. For ANBL 0531, this was a response and biology-based therapy for intermediate risk neuroblastoma. So using an algorithm, could we further reduce therapy in patients based on biology and clinical factors. And here they also used 1p11q allele status to establish what group patients fell into and how much therapy they would receive. And response and the endpoint of the study was based on achieving a partial response for those with local regional tumors, and those with disseminated disease, I believe, had to reach a VGPR. And here, patients received anywhere from 2 to 8 cycles of chemotherapy plus or minus surgery. And again, excellent outcomes were maintained with this algorithm. And our current standard for patients with intermediate risk neuroblastoma is to give 2 to 8 cycles of chemotherapy depending on response, and plus or minus surgery. And the most recent COG non-high-risk study is ANBL 1232, and this study just recently closed to accrual. But the objectives of this study were, again, to further decrease therapy for certain subgroups of patients, one being infants less than 12 months of age with small INRG L1 tumors, and those who were less than 18 months of age with localized neuroblastoma unfavorable biology, and whether some of these groups could receive observational alone as part of their frontline therapy. And finally, for patients with INRG MS disease, to achieve at least or greater than an 81% overall survival for these infants who have symptoms and otherwise may have done unwell on prior studies, and to initiate treatment early for these patients. And then to quickly summarize some of the landmark studies in high-risk neuroblastoma, one was CCG3891, which compared proceeding with myeloablative chemotherapy and autologous stem cell transplant versus continued chemotherapy after undergoing induction therapy for high-risk neuroblastoma. And here, the study led by Dr. Mathey showed that myeloablative chemotherapy plus autologous stem cell transplant improved event-free survival for patients. And then the study conducted by Dr. Alice Yu and others, ANBL0032, then asked if including targeted immunotherapy or an anti-GD2 antibody plus isotretinoin improved outcomes for patients with high-risk neuroblastoma in the post-consolidation setting compared to isotretinoin alone. And here in this study, we saw that event-free survival and overall survivals improved with immunotherapy plus isotretinoin following autologous stem cell transplant. And finally, ANBL0532 investigated single versus tandem autologous stem cell transplant. And in this study by Dr. Park, they showed that tandem autologous stem cell transplant improved event-free survival for patients with high-risk neuroblastoma, especially when followed by immunotherapy in a post-hoc analysis. So this leads us to our current COG standard of care for high-risk neuroblastoma, which again includes 5 cycles of induction chemotherapy, surgery, tandem autologous stem cell transplant, and radiation as part of consolidation, and then immunotherapy in the post-consolidation setting. And through many of these trials and advances in treatment, there has been a successive increase in overall survival for COG patients, as seen here, from 1990 to 2015. But as you can also see, there's a lot of room for further improvement, and that is really the focus of trials and investigations moving forward. And as many of you know, this is our current phase 3 study within the COG, ANBL 1531, which is meeting its accrual. Will probably meet its accrual very shortly. But in this study, patients are, the study arm is investigating the introduction of I-131 MIBG therapy into induction for patients with high-risk neuroblastoma and comparing that to standard of care. And then for patients who do have tumors with an ALK aberration, adding an ALK inhibitor early on and throughout therapy. So next, I'm just going to highlight a few targeted therapies that are present for our patients with high-risk neuroblastoma, and you'll hear more about this throughout the course of the next 2 days as well. So 3 really important modalities of treatment for neuroblastoma are anti-GD2 antibodies, I-131 MIBG therapy or radiopharmaceutical, and ALK inhibitors for patients with tumors that have an ALK aberration. And anti-GD2 antibodies are antibodies that target GD2, which is uniformly expressed on neuroblastoma. And there's multiple types of anti-GD2 antibodies, dinutuximab beta, which is used primarily in Europe, and naxitamab. And the side effect profile really tends to be allergic type reactions, as well as pain, and that's because GD2 is also expressed on the long nerves. And that's why pain management is a big part of our supportive care when administering these antibodies. And we've made great successes in the relapse setting by also combining anti-GD2 antibodies with chemotherapy. So MIBG therapy is really a similar concept to the scan, but with a higher radiation dose. So the MIBG tracer is taken up by the neuroblastoma cells. It's attached to radioactive iodine, again at a higher dose, and essentially is providing localized radiation to patients. This requires either a lead room or shields to protect family and staff from radiation exposure, generally requires stem cell rescue to help counts come back faster. And as I mentioned, is being studied as part of frontline therapy for high-risk neuroblastoma in the current phase 3 study. And here, and I'm sorry, the images did not come out as well, but you could see in the baseline images, here's a patient with multiple bony lesions or really avid MIBG scan with disseminated disease. During admission, this gets actually a little bit brighter, and this sometimes frightens families. We get an MIBG scan right after MIBG therapy to really show that the MIBG uptake has occurred. So we don't really use this for response, but we do want to make sure we get this scan. But then 6 to 8 weeks later, we then assess response, and you could see this patient's bone disease very nicely cleared by MIBG therapy. And this is just an example of another patient with MIBG avid disease. And then this is their scan 7 weeks after therapy. So ALK, so about 10 to 15% of children with high-risk neuroblastoma have a tumor with an ALK aberration, and often this is a mutation or an amplification. And crizotinib is a small molecule inhibitor of ALK, MET, and ROS1, and was one of the first ALK inhibitors to be investigated in neuroblastoma, and was part of the initial ALK arm of ANBL 1531. Now have included lorlatinib, which is a next-generation ALK inhibitor, which is part of the phase 3 study. So we talked a lot about treatment, but with treatment, unfortunately, comes some late effects as well, too. And this goes back to our goal of we really want to optimize outcomes for our patients and find a way to minimize some of the late effects. And I believe you'll be hearing other additional talks regarding late effects during these 2 days, including that regarding fertility. So patients are getting chemotherapy, radiation. This may impact their heart, endocrine system, hearing, may lead to second malignancies, may impact neurocognitive outcomes, and there's a lot of surveillance, again, for any pulmonary toxicity, renal toxicity as well. So again, this is really the focus of every time we develop a new treatment strategy. How can we optimize outcomes and minimize toxicity? So there's a study being run through the Children's Oncology Group called the LEARN study that's being run by Dr. Tara Henderson and Dr. Lisa Diller. And this is really to understand what are the late effects of our current era treatment strategies for high-risk neuroblastoma. And their overall goal is to evaluate the prevalence of adverse events in high-risk patients treated after January 2000 and determine the impact of these events on health-related quality of life. And these are patients who were enrolled on the biology study and greater than or equal to 5 years from diagnosis. And they're collecting treatment exposure data through detailed abstraction of medical records, and then evaluating outcomes through surveys and full-day clinical evaluations. So hopefully that will provide some insight as to what our treatments are doing and how can we do better. So again, how can we continue to improve outcomes for our patients? And this is really through investigating novel therapies, through basic translational research and clinical trials and other clinical research, and to further refine risk stratification and provide more precise treatments to our patients. And many investigators, many that are speaking today, are looking at biomarkers of therapy response and resistance as well, and other ways to identify response and disease. And of course, collaboration, all of us working together to make sure we do what's best for our patients. So I just wanted to thank you guys for your attention. And I really wanted to give a big thank you to Pat and all the organizers for the conference and all the work they put into trying to inform the general community about neuroblastoma. Thank you. I don't know if there's time for questions, Pat. I probably went over a little.
Hi, Dr. Desai. Thank you for the talk, and just a personal thank you to you. You and the team at Comer have been taking care of my son James since he was diagnosed in November and giving him some of the best care we could have ever hoped for. So just a personal thank you to you and the rest of the team at Comer, and thank you for the talk. I'm just curious, can you tell us a little bit about what gets you the most excited when you think about some of the next generation therapies and where you're hoping that we might get in the next 5 and 10 years?
Yeah, that's a really great question. You always ask the best questions. So first of all, thank you. We appreciate it. And, of course, as you know, it's a team effort to care for our patients from both the family side and the provider side, and it's been a pleasure to be part of that. What gets us most excited? I think immunotherapy is really still exciting, and I think we're looking at different ways to integrate immunotherapy in the frontline setting, and Dr. Federico may go into this in a bit more detail today as well, too. Cellular therapies, other novel types of immunotherapies, or even beyond that, other ways of delivering drugs. How can we be better? In the recent past years, we've seen patients with, relapses, and how can we be better at really trying to target certain areas of the body that we're not so great at getting, drug into as well. But I would say a lot of the work that's being done in the lab to look at different types of immunotherapies, personally for me, is exciting, but there's much more even beyond that.
Good morning.
Good morning.
Kimberly Turner from Columbus, Georgia. My question is, you said the catecholamines in the urine, detection it early really didn't help the outcome, but doesn't it help a little when you're trying to detect if it's going to grow or not? Because a lot of the kids are not detected until later on, but they start having small symptoms, maybe like my daughter started to wet the bed, and that was a signal because of the tumor was blocking her bladder and bowels, and a simple urine test could have said, hey, your kid may have cancer, let's check it out more before the tumor got bigger and spread it to other parts.
Yeah. Thank you for the question. You know, I think urine catecholamines are tough, and they're not elevated for every patient at diagnosis. They're helpful when they're elevated to be able to track it over time, in general, for the way we monitor our patients. In the context of screening and that slide that I brought up, I think the point of that is the group of patients that they were screening were really the very young ones that had tumors that may have gone away on their own that we may have not even ever known about, but because they were identified, then interventions were made, and that actually caused more harm than good to certain children. So I think they were, in that population, identifying tumors where children would there wouldn't be a high rate of moving around to different parts of the body, that it would just stay localized or go away on its own. So that is really why the screening went away.
Okay, one more question?
This may be addressed a little bit later, but it's in regards to the MIBG added to the frontline therapy. You had mentioned that, at least on the slides, that it was effective at clearing bony disease. How effective is it against soft tissue disease?
Yeah, that's
compared
also
to
a
bone?
really good question.
Yeah.
In general, I think most of us think that MIBG works better for bony disease than soft tissue disease. And, you know, based on a patient's recurrence and recurrence pattern, we may decide what treatment might be best for a patient, whether they just have a little bit of soft tissue recurrence. Do we want to perhaps proceed with just some external beam radiation rather than MIBG? But could there potentially be micrometastatic disease floating around where MIBG might be helpful? So I think these are all the things that we think about. Or do we follow that external beam radiation with some systemic therapy as well to get rid of any micrometastatic disease? But in general, you know, I think it is a treatment that's known to be a little bit better for bony disease than soft tissue. But that doesn't mean that it does not work for soft tissue.
Okay. Is that it? Yeah, go ahead. Go ahead, one more.
Hi, Kim Travers from North Carolina. Question, my son is MIBG non-avid. Is it an option to get MIBG treatment? Even though they're non-avid?
And I'm sorry I didn't mention that earlier. One of the criteria to be able to get MIBG therapy is to have MIBG avid disease. Yes.
So it's not even an option?
No.
No. Okay, thank you.
Yeah, thank you.
Is that it?
Right. Thank you.
Okay. Thank you, Dr. Desai. I didn't plan this, but as sure everybody knows, the famous Mexican soccer team is here in the hotel. And they play tonight, and I was kind of informed it might be an even crazier night tonight, and especially if the team wins. So they are increasing security and everything, so just so you know, this may be an issue again tonight. And I planned the whole thing, I really did. I made sure you were all here for it. And I had them close the air wall because I know it was getting a little bit crazy. So we're going to have a break in a little while around the corner. Our next speaker is Dr. Sarah Federico. She received her bachelor's degree at Stanford University in California and her MD at Virginia Commonwealth University Medical College. She did her internship and residency at Lucile Packard Children's Hospital at Stanford University and her fellowship at St. Jude. She is author and co-author of numerous publications and articles, and her research interests are clinical investigation of pediatric soft tissue sarcomas, translational research in pediatric solid tumor cancers, and novel drug development for pediatric solid tumor malignancies. She's here today to talk about the trials that are currently going on at St. Jude. Dr. Sarah Federico.
All right, good morning. I'm short, hold on, there we go. Okay, so it's so great to be here. I actually was here a number of years ago and then in San Francisco, but it's really fun to be back here. And so I appreciate the opportunity to share some of the work that we're doing at St. Jude, and then just general through some of the consortiums. So I have no conflicts of interest or no financial disclosures. And so a little bit about me. When I did my fellowship, and this is really a sign of hope, because when I did my fellowship, I started in 2007, and I finished in 2011. And these two kiddos, the fireman and the dancer, were my inspiration. And so they taught me about high-risk neuroblastoma. They gave me passion that we have to advance the field, we have to do better. They deserve it, the families deserve it. And so that really just got me committed to making sure that we advance the field. And it's exciting that, I'm not like 100. It hasn't been that long, but there actually have been improvements in outcome since my fellowship, which is really exciting. We still have a long way to go. And then once we figure things out a little bit better, then we need to be able to dial things back to limit toxicities like Dr. Desai just mentioned. And so Dr. Desai just talked about multimodal therapy for high-risk neuroblastoma, which is what I'm going to focus on. And really, I call your attention to the left hand of the slide to also highlight the fact that everyone's been working on this collectively for a long time. And so even though individually we're going to get up here and present our different research and talk about kind of things that are going on at our institution, this field is really a group of folks that collaborate to try and move things forward. But we obviously ended on the right-hand side with, unfortunately, children who have high-risk neuroblastoma requiring a lot of therapy in order to move that survival and cure rate up. And there has been incremental progress in time. And so as Dr. Desai just mentioned, on the left hand of the slide, the low and intermediate risk group survival curves have moved up significantly, and we've been in a place where we're able to dial back the amount of therapy that's been administered to these patients. But actually, the high-risk survival curve has also been moved up. And so I appreciate Arlene Naranjo actually just updated this slide recently, so it has some of the more modern era treatment. The numbers are a little bit hard to see, but essentially these curves are going up. So when you look at a Kaplan-Meier curve, basically on the y-axis is survival. So what we want is a flat line, 100% across the top, and then the x-axis on the bottom is time. And so you can see that over time, as we've tweaked the medications and the regimen that we give to our patients with high-risk neuroblastoma, we have improved outcome. And as many people know, that one of the biggest jumps in this past decade from when I started my fellowship to where I am now was really the addition of dinutuximab, so that antibody to the end of therapy. And this improved outcome by 20% and event-free survival. And so I'm a visual person, and so like neuroblastoma tumor cell, right, flag, right here, my thumb, GD2. We give antibody, it circulates around the body, it's looking for GD2, it binds it. That does not kill the tumor cell. Then what we need to do is rev up the patient's own immune system, and so now the immune system recognizes that, and now your own immune system can kill the tumor cell. And so the addition of dinutuximab, the antibody, anti-GD2 antibody to the end of therapy, improved outcome. But it's also important that when, as physicians, I'm totally guilty of this as well, when we walk in and we're talking about data and we're giving you information, it's also important to know, what are the different time points and what does that mean? So when we look at this survival curve, and it definitely was better with the addition of dinutuximab, that time point on that trial, Dr. Yu's initial antibody trial, started for the patients who made it through induction and through consolidation and were able to get antibody. And so what it doesn't take into account is that there were patients during induction or during consolidation that may have had progressive disease, may have had to go off therapy for toxicity, or who may have just had not a good enough response to be able to be eligible for the trial. So it's really important to always talk with your physician and ask them, like, when you're giving me numbers, like, what is our time point that we're talking about? And so actually, when we look at that very seminal paper, so this study that added dinutuximab to the end of therapy, when we look at that patient population and try and get an idea of what is their true 3-year EFS, again, we always use too much jargon, so event-free survival, which means when you get to 3 years, have you relapsed or not, or had a second cancer, there are other events, but the big one that we kind of think about is relapse. And so for patients treated on this study, the most recent COG trial, the 3-year event-free survival was 51%, meaning that at 3 years, about half of the patients had had an event, either relapse, they passed away, second malignancy, or they hadn't. And so there are a ton of targets, and I'm not walking through this, I promise you. The bottom line, the reason I bring this up is that there are so many ways that we can attack neuroblastoma, and actually many of the different speakers that are going to talk over the next couple of days are going to kind of focus on their aspect, and so that's what I'm going to focus on today right now is anti-GD2 monoclonal antibody therapy, but recognizing that there are a lot of people that are working very hard at attacking the cancer in different ways. So we're going to focus on the little red box, which is that antibody therapy. And so at St. Jude, we've been doing clinical trials using a different monoclonal antibody. It's called HU1418K322A, which is obnoxious, so I'm just going to call it HU1418K. And what it is it's similar to dinutuximab. Again, the mechanism is the same, right? Tumor cell, antibody, goes around your body, it's looking for this flag, binds to it, and then we rev up your immune system by giving things like GM-CSF, that then your own immune system can fight the tumor cells. So this antibody that we have been using and studying at St. Jude, it's humanized, and so that means it has less mouse in it, so it's less immunogenic, meaning you're not going to probably have as many allergic reactions to it. It does have a single point mutation in the arm of the antibody because we all know that antibody comes and can cause pain, and so scientists were able to figure out, well, what's really triggering that pain, and can we change that but still allow the antibody to bind well? And so it theoretically has less pain. It's produced in a different cell line, which may improve how well it works. And again, may is important. And then ultimately, because patients tolerate it better, we have been able to give higher doses of it. It's really important, though, to disclose, like, nobody knows that, right? So sometimes people will get up and we can talk about the fact that we can give higher doses, but I actually don't, and we can, of this antibody, but I actually don't know if that's more is better. It might be, but it might not. And so there were a couple of studies that were conducted within the past decade. So the first, as Ami was talking about, when you're trying to evaluate a new agent, you need to figure out, can I safely give this to our patients? And what are the side effects, and determine the dose? And so that was a phase 1 study that was published in 2014 that basically said when you give antibody by itself without anything else to patients who have relapsed or refractory neuroblastoma, so relapse meaning it's come back, refractory meaning it never went away, can they tolerate it? And so in that trial, demonstrated that, yeah, patients can tolerate it, again, with appropriate medicines to manage pain and allergic reactions if they had them. And importantly, there were some patients that when they received it by itself had a response. And so a CR means a complete response, meaning all your cancer has gone away. A PR means a partial response, and there's this really complicated system that we all keep changing, but basically means some of your cancer has gone away. And we determined the dose to use. So the follow-up study to that was a pilot study looking at the combination of that antibody, the HU1418K, with different combinations of chemotherapy that are constantly that are frequently administered to patients in the relapse or refractory setting. And again, the goal at that point in time, which we now all know the answer to, but the goal was really to see, can you combine antibody with chemotherapy? Is it tolerated? And then more importantly, does it work? And so this was just a small pilot study to look at the feasibility of giving chemotherapy with antibody therapy. And we were very happy to see that actually it was feasible, so you could do both. And then patients were responding. On this trial, we only gave 6 cycles, though, of the therapy. So there were 3 patients out of 13 that had a complete response, meaning their cancer went away entirely, 1 patient that had a VGPR, meaning most of their cancer went away, and 4 that had a partial response. And when we think about what that means and comparing it to other trials that have come along in the past before chemo-immunotherapy studies, usually, like, many trials would be considered like, oh, that's pretty good if about 15%, unfortunately that's where we're kind of at, 15, not 50%, had responded to therapy. That was kind of preceding this chemo-immunotherapy time point. And then importantly, for the patients that unfortunately had relapse and their cancer came back, there was this prolonged time period before their cancer came back. And so Wendy London, who I don't know if she ever presents here before, but she's a statistical genius in the neuroblastoma field. So she and others, colleagues, wrote a paper, looked at all the different phase 1 studies, and found that the typical time for after a clinical trial, if your cancer's come back, is about 61 days. And so this was longer than that. Again, tiny patient population though, right? And so these are the important things. I love that Dr. Desai brought this up, because when people are talking with you about data, I always point this out. Small group of patients. I don't know, wasn't randomized, but a signal, and you'll oftentimes hear oncologists talk about a signal of activity, and that it should be studied further. And then when we were coming up or seeing those results as well, this was the important AMBL 1221 data of Dr. Modi. I know he's come here a number of times and presented this data that really showed that when you combine irinotecan, temozolomide, so 2 chemotherapies, with dinutuximab, the chimeric antibody that we use in the upfront setting, in patients who have relapsed, their cancer's come back, or refractory never went away disease, that 53% of them had a response. And this was in comparison to a different patient arm, so randomized trial that got same chemotherapy, dinutuximab, irinotecan, but then another chemotherapeutic, temsirolimus. And so that group of patients, only 6% of them responded. And so when clinical trials are designed and they're ongoing, they actually have all these different time points where we stop and take a look. Well, usually, if they should, most of them do. Where the statistician then stops and takes a look, like, is there a home run? Are we causing harm by giving these different treatment combinations? And so at an early time point when they saw this response, 53% compared to 6%, they said, well, we can't let this study keep going on. Everyone now just needs to get the 53%. And so then the trial was expanded to allow patients who continue to enroll in that study to get irinotecan, temozolomide, and dinutuximab. And when they looked at those overall response, they found that patients, the response rate was more like 40% of patients had a CR/PR, and the other another 40% had stable disease, meaning that their cancer had not progressed. And so again, this really moved the bar. And so people will oftentimes refer to this as chemo-immunotherapy, and so that's what I'm talking about. And so around the time that all of this was going on, our goal at St. Jude was always to try and get chemo-immunotherapy into the upfront setting to see if it would work for patients. And this really came out of when Dr. Yu presented her initial work that showed antibody at the end of treatment, improved outcome for patients. Then Dr. Furman, who has since retired, went up to her and was like, well, we got to get this into patients at the time of diagnosis. And so that's what this study was. So this trial was called MB 2012, and it was published last year. And really it was looking at, can you give chemoimmunotherapy during induction, the first part of therapy, and is it safe and tolerable, but does it improve outcomes? So are more patients able to get rid of their cancer and have it not come back? And so in this trial, I want to point out that the recipe was a little bit different than what we typically use in the COG trials. And so in the current COG trials, we actually use 5 cycles during induction instead of 6. This was, at the time it was written, that's kind of what was being done. And so we were using historical control, so that's why we use 6. The consolidation, so that's the transplant. At the time the trial was written, we did not have the results of Dr. Park's trial that showed that tandem, meaning 2 transplants, was better than 1. And so the results that we had, we looked at the results in the US and the results in Cyopin, so that's basically the COG equivalent in Europe. And they had shown that the chemotherapy called Bumel was maybe better than what we were using. So the consolidation was a little bit different, but you still got a transplant. And then at the end of treatment, instead of getting dinutuximab, the patients received the humanized antibody that they also got in the front. And then what we did is we added that humanized antibody, that's the HU, to each cycle of induction therapy. And we knew that, this is toxic treatment, and we need to be able to identify a signal of activity. Again, this is a single institution, just done at one site. We're looking for a signal. We're not trying to prove that it works. We're looking for a signal of activity. And so what we did is we wanted to look at that, see where that arrow is. The arrow is pointing at response after 2 cycles. And the reason we were looking at that time point, looking for an early signal, is that we could compare it to what's called a historical control, which means if you look at prior trials that have been conducted, you're not randomizing the trial, but you're trying to take the best data that you have available. What was that response rate, and can we improve on it? And so there were 2 prior clinical trials. Actually, there was 1 prior clinical trial, and then the tandem transplant trial results came out, which showed the same, which is that after 2 cycles of induction therapy, cyclophosphamide and topotecan, the response rate was 40%, meaning patients had a partial response or better. And so in this clinical trial, what we were looking for is improving on that by 20%. And so we said, well, we don't want to add a bunch of toxic therapy to the patients unless we see a 20% improvement at that time point. And so we set our bar at 60%. And so the first 42 patients were enrolled, again, single institution, and what we found is after those first 2 cycles of therapy, so same chemotherapy as the historical control, cyclophosphamide topotecan, the difference was adding the antibody therapy. Our response rate, meaning partial response or better, that we saw was 76%. And so this really was a signal to us that actually we really need to expand the trial a little bit and be able, if we can determine what the 3-year event-free survival, which a lot of times, and what Dr. Desai was just presenting, that's kind of a mark that a lot of us look at, and we have a lot of data on 3-year event-free survival. So we added some more patients to the study. And what we found is that there was a dramatic response to induction. And so induction is the chemo-immunotherapy. Busy slide, sorry about that, but I'm gonna I think even if you cross your eyes, you can get an idea. So the first one is when we talk about response in high-risk neuroblastoma, like Dr. Desai just mentioned, we're looking at different components of response. So what does your first tumor look like? What does your bone marrow look like? And then what do these metastatic sites of disease look like? And we get response in each of those, and then we put them together and come up with an overall response. And so this slide kind of captures those. So this is after 2 cycles. The bar shows a dramatic decrease in their primary tumor size. Down is good. The very bottom being 100% of your primary tumor is gone. The colors show what your metastatic disease did. And so blue and red are good. That means a CR, VGPR, and actually even the green is a PR. That's also good. And then bone marrow, you can't really see here. It's there, the letters on the bottom. And what we found is after the first 2 cycles that there were we beat that more than 20% improvement. And then really when we got to the end of induction, which we're starting to learn more about, that this might be an important time point when we are thinking about, what do we do with next therapies, that actually many of the patients had a very, very good end of induction response. And so 60 of 62 patients had a PR or better. And actually, Dr. Desai and some of the colleagues in the room looked at metastatic CRs, like did your metastatic disease go away at that time of end of induction, and found that might be a good surrogate marker of how you do overall, but it's not the only thing. And so this was exciting to us and definitely to the field. And so that's where we are. Importantly, about 10% of patients who are treated on high risk historically, who have been treated on high risk neuroblastoma trials, may experience progressive disease at 7 to 10%, depending on which group of patients you look at. And in this group of patients, none of the patients had progressive disease. Their cancer did not get worse during therapy. And so these 3-year event-free survival, so again, when you get to 3 years, has somebody had an event, which includes relapse, passing away, or secondary malignancies, was 73.7%, and the 3-year survival was 86%. And so, again, an important signal that maybe chemo-immunotherapy in the induction setting is something that should be further evaluated. And so our conclusion was that the addition of HE14/18K to induction chemotherapy had improved outcome and should be validated going forward in a randomized clinical trial where you can really treat people at the same time and see, does your treatment do better than the current standard of care? So what does that look like? Again, historical controls are like fraught with issues, and that you just need to know that when people are comparing things. It's not the same as doing a randomized controlled trial, but it's what we have. So again, you can look at things for signals of activity. So in the blue circles, or I should say in the bottom red box is 3-year event-free survival. In the blue circles, those are the 2 most recently completed COG studies where the 3-year event-free survival is 51 or 55%. In the purple boxes, those are in circles, those are the 2 most recently completed SIOPEN trials. So again, kind of like the larger consortium equivalent in Europe that showed that the 3-year event-free survival was 34 to 40%, depending on which study you're in. And then our 3-year event-free survival is 73.7%. But again, single institution, not randomized. So it kind of bugged me, actually it didn't kind of bug me, it really bugged me when I was treating all these patients at St. Jude and seeing responses and was so excited, and then it really bothered me that that antibody wasn't available to patients everywhere. And so in working with colleagues in the Children's Oncology group, the commercially available antibody was dinutuximab, and so we wrote a trial called AMBL17P1, which was a pilot study looking at, can you add dinutuximab to chemotherapy for patients with newly diagnosed high-risk neuroblastoma, and is it tolerated? Again, it's a different schema, though, in that the patients here receive 5 cycles. That's because of some work that was done that showed that 5 versus 6 induction chemotherapy cycles still leads to the same end of induction response. And then we didn't actually give the dinutuximab, the antibody, with all the cycles of chemotherapy. And that was intentional in that at the time this trial was being written, a lot of patients now receive chemo-immunotherapy. A lot of hospitals have experience giving chemo-immunotherapy, and just the expertise, and the bedside nurses are amazing at managing symptoms. But at that time that this was written, there weren't that many patients that were receiving chemo-immunotherapy. So as a cooperative group, we were concerned that if we gave antibody therapy, especially in the first cycle of chemotherapy, that those patients, when they come in, can be so sick, were we going to cause more harm if all of a sudden they had fluid going to places they didn't need to have fluid and having a bad response to antibody, and would we cause harm? So that's why we added it to cycles 3 through 5. The other reason we didn't include cycle 2, I didn't talk about that, is just that we wanted to make sure that we didn't, most of the time at most centers, your stem cells are collected after the second cycle of therapy. And so we didn't know if that would affect it. And so that's why it was in cycles 3 through 5. So these results, or this study was conducted at 9 different centers, both in the US and outside of the US. And the toxicities we saw were expected, kind of normal dinutuximab toxicities. Patients were able to receive the antibody therapy in cycles 3, 4, and 5. And so that was important because it's a feasibility study. Can you do it? And then we're still working on the kind of longer term results. Hopefully the results will be out in the next year or so. So what we concluded on this trial was that you can give dinutuximab safely to patients with newly diagnosed high-risk neuroblastoma in different treatment centers in cycles 3 through 5. And so again, the question is, you're probably already tired of hearing about randomized trials, but I'll keep saying it. The question is, how can we best truly answer whether or not chemo-immunotherapy improves outcome for our patients with high-risk neuroblastoma? And the answer is that you need to assess it in a randomized control study. So meaning that patients will compare it to the standard of care, and other patients will get chemo-immunotherapy. And so this is a trial that's coming. So this is called AMBL 2131. Hopefully, it should open later this fall when the current COG trial closes. And it is asking the question of if you give antibody therapy, so in this case, dinutuximab, with induction cycles 2, 3, 4, and 5, with all the other standard COG backbone, then will more patients be cured of their cancer? And so this is a treatment schema where patients go on study at the top. They all have their tumor sequenced, and while they're getting their tumor sequenced, they receive the first cycle of chemotherapy, and then they are randomized, meaning a computer selects which treatment arm they go to. Treatment arm A is the standard COG backbone. That's the one that does not have a box around it. And then treatment arm B is the experimental arm where we're adding antibody therapy to induction cycles 2, 3, 4, and 5. Now, we didn't want to, some people have asked, like, well, you just presented some results that show when you give chemo-immunotherapy at your institution that you had an improved outcome, and is this equal, and should you be doing this? And so what we decided is that we want to still make sure that patients can receive chemo-immunotherapy on the clinical trial if they are having a poor response during induction therapy, because many patients who have a poor response during induction therapy or may unfortunately have their disease progress during induction therapy oftentimes go on to receive chemo-immunotherapy. And in this case, these patients would stay on study and have the option of receiving chemo-immunotherapy. And then if they had a good response, they would loop back into the rest of the standard treatment. And so again, this trial, this is the study team. So Thomas Cash from CHOA, who some of you probably know, he and I are co-chairing it. And then our vice chairs are Naveen Pinto, who will be in Colorado in like a week, and Carrie Strebe are the vice co-chairs. And so that's coming. I don't know any results of that because we haven't opened the trial yet. And so as all of this has been going on, one of the things that I wanted to focus on is just, can we build upon this chemo-immunotherapy backbone to try and improve it? And so a few years ago, again, tumor, flag, GD2, antibody, rev up the immune system, the NK cells fight it. And so is there a way that you can rev up that immune system a little bit better so they fight it a little bit better? And so there was some work that was done by a scientist who is at St. Jude now, and she's currently in Washington, D.C. And what she did is she took some natural killer cells, those are the white blood cells, the fighters that make this work, that's on the left, of healthy donors, and then she took some tumor cells, that's the PDXs, put them into a dish together, added some antibody, and then added different things to see if you can make them kill better. And so what she found is that in the first box, that on the top, when you add IL-15 to this chemotherapy, or excuse me, to the natural killer cells and to the antibody, that more of them kill. In that case, kill the tumor cells. Those are the black bars. And that then when you add on the far right, add that in with the IL-15, even more of them are killed. So it was a signal that maybe if we add IL-15 to our treatment backbone, that maybe it would be more effective. So she went on and she actually looked at it in different mouse models and combined different regimens. And so in general, the combination was using chemotherapy, so typically irinotecan temozolomide antibody is what a lot of people go to because it's been proven to be effective in clinical trials. So that's what she studied. So in the first group, in this case, bars going up means that the mice are not doing well, their neuroblastoma is progressing. Bars going down mean that their neuroblastoma is going away. And so in the first group, just chemotherapy, the mice all had progressive disease. And the second group, when she added irinotecan temozolomide antibody and GM-CSF, a few responded, but many didn't. The third group, she added an agent we used to use, which was IL-2, which is kind of the same idea in Alice Hughes' paper to rev up the killing of the tumor cells. And again, some went down, but others went up. But when she combined the chemotherapy with the antibody therapy and IL-15, tumors regressed in the mice. Again, they're mice, right? but it's a signal of activity. And so when we were looking, this is a trial we're currently working on, and we were looking at what is available. There is an IL-15 superagonist called N803. It was previously called ALT-803. And it's been studied in adult patients who have non-Hodgkin lymphoma and a few other types of cancers. And basically, what it does is when you give it, again, this is in the first adult study, it makes the NK cells, the fighters, go up. And then importantly, some of these cells on the bottom, it doesn't really make those go up. And those cells on the bottom are not going to talk about, but sometimes we think that they kind of counteract why the chemotherapy and the antibody don't work as well. And so the patients that were treated on this study and this adult study had a good response. They had few side effects, and the most common just being some redness around the site of injection that wasn't an infection. It's not like cellulitis is the fancy word for calling it a skin infection, but more just kind of redness and those cells going to that spot but not causing an infection and otherwise tolerated. And so recently there was a trial in adults with patients who have non-Hodgkin lymphoma where they combined this with another medication called rituximab. And what they found is that when you give the N803 in combination with rituximab, again, down means response, that patients who had received rituximab previously alone were having a response. So this is kind of the basis of this next study, which is called Honeybee 803. So Honeybee 803 is going to be a new trial that's coming soon, looking at chemo-immunotherapy plus IL-15. So this will be a first in pediatric study, and what we're going to do is initially there's going to be what's called a safety phase, which is where we combine irinotecan, temozolomide, the humanized antibody, and the N803. We're going to make sure that you can safely give these together. If you can, then we're going to go into a phase 2 study in which patients will be randomized to receive either chemo-immunotherapy, so irinotecan, temozolomide, humanized antibody, or the chemo-immunotherapy with the N803. And we'll try to determine if the addition of N803 helps. And so where this trial currently is, the antibody for this study is manufactured at St. Jude, although that was recently acquired by a drug company and announced this week. And so the antibody is manufactured at St. Jude. It will start at St. Jude, but then this trial is going to be conducted through the consortium NANT, which I think a lot of you have probably heard about before, and I know Araz is going to, Dr. Marcellian is going to get up and give a talk about the NANT consortium. It will probably open in the spring, fingers crossed. And so with that, all of this work is really a collaborative effort with colleagues both at St. Jude and then, of course, colleagues all across the world. And so these are just some of the people that really contributed a lot to those trials. And then, of course, funding sources. And then it all comes back to the fireman and the dancer for me. So again, when I think about 2007, when I started my fellowship, and see those Kaplan-Meier, those survival curves coming up, I know that we are doing better for patients like them, but we have to continue to push it. And we need your help, and we are there for you. So with that, I'll take questions.
Thank you, Dr. Federico. Anyone have questions? Okay, got one.
Hi, good morning. Thank you, Dr. Federico, for your amazing overview. With the success of dinutuximab, specifically when paired with chemotherapy, what has the discussion been, and has there been any discussion in the medical community about kind of curating a randomized trial with chemo-immunotherapy versus something like transplant?
Yeah, so this is like the million-dollar question that keeps us up at night. There are a lot of things that keep me up at night. Neuroblastoma is definitely one of them, and this is one of the main things, is that we as a community would love to start eliminating some of the toxic aspects of therapy. The question that was asked earlier, like, what are you excited about? I'm excited about the fact that I do think in this kind of like next phase of my career and our careers, that I think the paradigm's gonna change. But we have to do it through careful studies. Because really, and again, I'm like a big believer in chemo-immunotherapy, mostly because like those 64 patients, like I knew all of them, like I saw them get better. And so I'm a big believer, but it was one institution that also has a lot of supportive care and other things, right? And so I hope, are going to change the treatment paradigm as more progress is being made. The COG, the Children's Oncology Group, is really thinking about what that next trial will look like and how best to evaluate if you can replace, it's not get rid of, it's replace transplant with other therapy, and how would that best be studied. And so there are a couple of investigators who are actually looking at potentially what that next study would look like, Naveen Pinto and Jenny Foster, who are working on that. So very, very important. When I looked at the list of other people that are coming up, though, there's been a lot of progress that's being made in other cellular therapy, and it's going to be a matter of figuring out where you should put some of these treatments, how you should change them up, and then the million-dollar question is, who do we give what therapy to? So the unfortunate thing that really keeps all of us up at night is that we still do not know which patients respond to what therapy. And so unfortunately, we are certain that we are over-treating some patients. Some patients probably don't need the whole cassette that we give. But unfortunately, we just don't know who those patients are. There's no way to identify it. And so, one of the biggest, an important aspect of these clinical trials is really trying to learn more about the biology. And there are a lot of correlative studies, fancy word for trying to figure out like how the body is responding to these different treatments that are built into these clinical trials, so that hopefully in the future, we're not quite there, but hopefully in the future we know which patients should, okay, you're responding great to chemo-immunotherapy, that's great, carry on, let's do that, maybe we can eliminate or replace it with, or replace transplant with some more of something else, but you are not, and so you should get this other therapy. And in some ways we know some of that, or there's more progress that's been made, like with ALK inhibitors and the exciting data that Dr. Goldsmith will talk about tomorrow. But for many we don't. And so my hope is that in the near future we can answer that question. And there are a lot of people working really hard at how we can answer that question in a randomized trial, so that when we get to the end, we can feel confident that whatever the results are the results.
Another question?
Hi, we go to CHOA. Dr. Cash is our doctor.
He's the best.
Yes, you probably mentioned my name, he'd be like, oh, yeah, I know them. But I don't know what he would say, but we did have the immunotherapy, and it was kind of rough. We only could get it while she was in the ICU because they had to monitor her blood pressure, because at one point it made the blood pressure extremely high, and then all of a sudden it made it extremely low. And so, like, one of the side effects was now that she has extremely low blood pressure all the time. And I was wondering, was that one of the side effects? Because it has never normalized after that. It's always extremely low.
Yeah, so you are 100% correct in that there are a lot of side effects associated with these therapies, and certainly blood pressure shifts and fluid shifts can be related to antibody therapy. It's also hard, though, to know when our patients have received so much other therapy previously to be able to tease out, like, oh, this is definitely related to this specific drug, because sometimes I think it's actually a combination of the therapies that you have received. So in this case, yes, you can have swings in your blood pressure, but I don't know your child's specific situation, so I wouldn't be able to comment on that, but there are definitely side effects, and it's also why it's important to be at centers that can evaluate and safely administer the medications. Not all patients are in the ICU, but definitely there are some that in order to safely receive it, need to be in the ICU. Other questions?
Another question?
First question, first question is more for clarification, but the trial that had the antibody on the induction stage, all those chemos looked familiar, but were those the same chemos that are at the COG?
Yeah.
And same doses and all that?
Yeah, so I didn't get into that in detail. So that 6-cycle regimen was what was used in a COG trial that was conducted in the early 2000s called AMBO2P1 that added the first 2 cycles, cyclophosphamide, topotecan, as the first 2 cycles. And then the same backbone, same doses was also administered on the next study, AMBO532, which looked at single transplant versus tandem transplant. Since that time, subsequently, the COG has gone to a 5-cycle induction based on work that was conducted by Megan Granger, where she gave the 5 cycles of induction, dropped the 6th cycle, and then looked at the response, so PR or better at that time point, and compared them to historical controls, and they were the same. And the idea and the rationale behind that was, well, if we're thinking about adding tandem transplant, do we really need all the same 6 cycles of induction? So now the subsequent COG trials do a 5-cycle induction. It's also why I pointed out differences, though, and I think as parents, this is so important for you to ask, again, when people are presenting data to you, like, well, were there differences in that study? It doesn't mean that they're a bad study, right? But like, what were the differences, and kind of what were the rationales, and really get a sense of, are we comparing like apples to apples, apples to oranges, or like apples to broccoli, right? Like, because it's not always clear, to be honest.
Yeah, and then the next question was just kind of what the logistics of that looks like. I know that, I think of induction, you have like chemo, then you have a few weeks off, and then chemo again, how that logistics works with the antibody part.
Yeah, so in the COG trial, so how it worked on NB 2012, the humanized antibody being added, is similar to how it will work on 2131. And so the patients start their chemotherapy on day 1. It's still a 21-day cycle-ish. And the patients will then start the antibody treatment concurrently on days 2, 3, 4, and 5. So they'll get it for those 4 days. The plan is always to run it over the 10 hours, which is the common way that dinutuximab is administered. But then, of course, depending on different clinical situations, if someone has a virus or maybe their blood pressures are a little bit more sensitive, of course, sometimes it can be extended out to run over 20 hours. The other difference there is that the injection that normally patients will receive pegfilgrastim or G shots to boost their counts after they get chemotherapy. The injection when you give chemo-immunotherapy is a little bit different. It's what we use with antibody therapy in general, so GM-CSF, which I'm sure many of you are familiar with.
Okay, you had a question here, and then we'll go to the one further.
Thanks. My question is, early in your presentation when you were speaking about the adding Dynatux and the 3-year event-free survival rate, did that include or not include children that were on a clinical trial after the standard COG protocol? For example, like my daughter did the traditional COG protocol from 2017 to 2019, but then went on DFMO. She didn't make it to the 3-year event-free. So am I saying, I don't know if I'm saying that clearly, but
I think there are a lot of different questions.
Okay.
There.
The 3-year event, adding the Dynatux looked like a positive. So it was like, I think it was 53% had got to the 3-year mark event-free. So were those 50?
Adding dinutuximab to the end of therapy.
Right.
Okay.
Sorry. So
No, that's totally fine.
if you added the Dynatux at the end of their COG treatment, standard treatment, and the 53% went on to have 3-year event-free survival, did those children participate? Were you including any children that participated in a clinical trial? Does that make more sense?
Oh, so it's a great question.
Okay,
I
sorry.
just wanted to make sure, no, it's perfect. I just want to make sure I was following it. I think there are 2 things that I can say about this. So number 1 is about when we add other therapies after treatment, like DFMO, vaccine. There's lots of data about those things. And so if I'm understanding your question correctly, it's when we look at numbers, did some of those patients get vaccine? Did some of them get DFMO? The hard part is that we don't always know. So, it's a little bit difficult when you're collecting data. It centers around the country, and people have to put in their information, but sometimes if a patient has gone on to another center, you might not have all the information. Maybe it didn't always get uploaded. So it's a little bit hard to know like what that percentage of patients that may have been included on that. I think you do also, though, bring up an important point, and this is 100% my bias, okay, so I want to own my own biases, that I would love to see, it would be great to see some sort of trial that looked at, well, what if those therapies that go on after the completion of treatment, to really be able to learn and randomize them and tease out the effectiveness of them, because we still just don't know. Yeah.
One more question?
Yes, thanks. So I kind of wanted to tail off of his question earlier with the human 1418 adding the antibody, and like my understanding, it was like all 5 cycles that the human 1418 was added. Yet later on, when you were talking about the CH 1418, the first 2 induction cycles were, standard induction, and then adding the Dynatux for the latter 3. So. And maybe you explained this already. I mean, is it like, I guess like the side effects between human and chimeric versus like, will there at some point be a comparison of, 5 cycles of human 1418 versus chimeric? And
yeah, so there are a couple of questions there. There are points I want to address. So you are right. You 100% got it. So at our single institution, where we just were able to control a lot more because you're there, we did give it with all 6 cycles, and it was a different antibody. In the COG pilot study, 17P1, it was just given in cycles 3, 4, and 5. And again, that was just due to concerns at the time of, can we safely give this at institutions elsewhere, because just people weren't used to giving chemo-immunotherapy. In the upcoming protocol, 2131, the antibody will start in cycle 4. So it'll be, 2. So it'll be 2, 3, 4, and 5. So they'll get it in 4 cycles. And again, the reason for that is just that there's concern with how sick some of these kids when they first arrive, that if we gave them antibody, that maybe we would cause significant harm and they wouldn't be able to tolerate it. So that's why it started in cycles 2, 3, 4, and 5, or done in cycles 2, 3, 4, and 5. The million-dollar question of, can you do a randomized trial and compare antibody to antibody? If you let the investigators in the room write whatever study they wanted to, I think we would all run that trial. But it's complicated, right? Because sometimes people don't want their products like compared head to head, and then it just gets complicated. And so I don't imagine in the near future that would be the case.
okay, thank you so much.
I know you said one last question, but
One quick question, because we get to break.
to piggyback off what I said, okay, you guys knew that the blood pressure thing was a problem. Well, why wasn't I informed? And like, what it does happen after you take this drug and you have those issues? No one follows up and say, okay, this is how we correct the blood pressure problem, because every doctor that we go to with these blood pressure problems, they don't know how to fix it. And it makes her with low energy. She sleeps all the time. She's tired. How do we fix this low blood pressure problem that this therapy caused?
Yeah, so first of all, I'm so sorry that your daughter is having all these side effects related to therapy. I think all you can do is what you're doing, which is reaching out to people and having her seen by people that are trying to understand it. Unfortunately, sometimes we just don't understand the exact mechanisms and even what medication contributed to that. It's also, though, why it's really important for us to, on these clinical trials, collect that, right? So then we learn, even though it doesn't help your daughter right now, we learn about some of these side effects, and it can inform future trials. But I can tell you that I think probably all the physicians have had many experiences where sometimes we just don't know why a specific symptom or specific side effect of therapy is happening, and we're not good at being able to predict that. We may in the future as we get more of these different, blood samples and conduct different correlative studies, be able to tease out some of those patient populations that might have some side effects, but we're just not there yet.
Okay, all right. Thank you, Dr. Federico. Okay. We are pretty much right on time, so if you want to take a 15-minute break, we have some snacks and stuff in the other room. Thank you. All right, can we get everybody seated and we'll go ahead and start the next group? Can I have everyone seated, please? All right, where is Mark? There you are. Okay. Our next speaker is Dr. Mark Applebaum. He's an associate professor in the Department of Pediatrics, section of Hematology, Oncology, and Stem Cell Transplantation at the University of Chicago. He received his BA in Molecular and Cell Biology from the University of California, Berkeley in California. I said that. He received his MD at Northwestern University, Feinberg School of Medicine, and completed his residency at the University of California, San Francisco, and his fellowship back here at the University of Chicago. He is the author and co-author of numerous papers, articles, book chapters, and other works, and a member of various professional societies. I asked Dr. Applebaum to talk a little bit about the INRG database, what it is, what it's used for, and why it does exist. I thought it might be important just for families to know that there's, so much more going on behind the scenes that you may not know of, and I thought maybe a talk on the statistics and the databases and what these things are used for, that you get, again, a little bit better understanding of what's happening, all along the neuroblastoma research line. So CNCF was a funder, initial funder of the INRG database, I think when it first got started. So Dr. Mark Applebaum.
Thank you, Pat, for the introduction, and thank you all for being here. And thank you to the organizers, of course. And so I have the privilege today, while I spend a lot of my time, I see patients, I also run a lab mostly focused on blood biomarkers and cell-free DNA. But I also spend a decent amount of time, I've had the privilege of working with Dr. Susan Cohn and Dr. Samuel Wolchenbaum, both as a member and as a user of the INRG Data Commons, is what it's now called. So, I was asked to give the perspective on how do we think about large databases, large data sets, and helping that move the field forward so that we can, obviously bring that back to the kids. So not to keep anybody in suspense, the INRG Data Commons, well, it's sort of a large database and a large Excel spreadsheet, but don't tell Dr. Wolchenbaum I said that. But to get to the real part of this, right? So no relevant disclosures. And so I don't think anybody in this room is going to disagree with the statement that we need more effective, less toxic treatments for these kids. And to do that, coming from the lab side of things and sort of the translational biology side of things, I, myself, and Dr. Cohen, and many others in the field feel, and I think Dr. Federico touched on this nicely, we need to understand the drivers of neuroblastoma tumors, the microenvironment, the host variables, all the factors that influence a patient's response to treatment, as well as the toxicity that derives from it, and themes that have already been touched on this morning. So I want to take a little trip back in time, just to start with. So this is the front sheet of a biology protocol that, as you can see, was started in 1990, and this is actually a pediatric oncology group study that one of the precursors to COG. This was a study, this was the very first one in neuroblastoma where there was an effort to start collecting data on patients. And many, the parents in the room, you've probably seen consent forms, hey, I'm sorry your children has neuroblastoma, but can you please sign this registry form so we can collect the data? It's always sort of an awkward ask as we're going through that question, but this is why it's important, and this is, I hope, to sort of impress upon you guys why we do that. So this was the very first version of that back in 1990, where it was really started as a way to collect information about things like MIC-N, some clinical characteristics, and really focus on the biology of what can we understand from patients when they're diagnosed. Dr. Cohen, as a young upstart back in, at the time, was then took over this study in the late 90s as a POG representative and said, well, we should link this all to patient outcomes, right? Because how powerful would it be if we can actually say, here's the biology of the tumor, here's the characteristics of the patient, and now let's see how that correlates with how they did in the long run. And that set the precursor for the ANBL-OOB1 study. This is, something that, for patients who are enrolled on clinical trials, they always actually have to enroll on this study, even though it's not perhaps the focus of the family and treating the patient at the time that they're diagnosed. But Dr. Cohen and Dr. Maris actually set this up as once COG was formed in 2000 as a way to continue collecting the information for all the patients we're treating both on study, but also actually really importantly, collecting information on patients who are not being treated on study. And as I'll show you in a little bit, that's actually been a really powerful tool to learn more and more about this devastating disease. And so for, since 1990, we've actually, the Children's Oncology Group and its predecessors have been collecting all of this rich information, but ran into some problems, and we could do studies within North America, and we can, we were able to say, let's look back at the data we've collected in the spreadsheets. But right, neuroblastoma is treated a little bit differently around the world. It's a rare disease, and if we're really going to learn everything we possibly can, we want to collect as many patients and put them in the same, in the same system so that we can understand not just hundreds of patients or thousands of patients, but tens of thousands of patients, and really collect what has become the most, sort of robust and largest, source of information on the widest range of patients with neuroblastoma. So, looking back into the early 2000s, treatment, certainly still risk stratification was a thing. We were treating patients according to the risk group. However, right, it was actually really difficult to compare studies. So comparing studies, across the pond, as it were, between SciUp or SciUp-N and the Children's Oncology Group, comparing studies that were being done in Germany, comparing studies that were being done in Japan, was incredibly difficult, because the definition of who was treated on a high-risk trial just differed, and sort of how people were identifying patients was just different. And so if you're starting with different pools of patients, as Dr. Federico was talking about in terms of comparing apples and broccoli, right, you're sort of, that's the problem. And we're also at the time, the field was learning about different genetic features in clinical trials that were starting to be used towards therapeutic decision. And there's a lack of standardization across cooperative groups to really understand how do we learn more about how to treat patients optimally. And so you'll see a lot of group photos. One of the themes that we've already touched on is this is a team sport. And I think the INRG is actually an embodiment of that. So led by Dr. Cohn, as well as Dr. Andy Pearson in the UK, they basically wrangled all their friends together from both Children's Oncology Group, as well as SciUp-N, as well as the German group and the Japanese, and started the International Neuroblastoma Risk Group, or the INRG Task Force, in 2004. The initial meeting, as you can see here, is about 52 investigators. If you look closely, you'll see a lot of well-known people in the field. I won't go through all the names, but it's always kind of fun to see this group of people 20 years now and then see them at meetings like ANR now, or then versus now. But what happened was they were able to collect this pool of about 8,800 patients to start from these different, from POG registries that I showed you, from Children's Oncology Group registries, from the B1 study, as well as other study information that they had collected in these other cooperative groups. And so taking a step back, right, how did they get this information? Where does this information in the IRG come from? And what happens actually once you sign that consent form as a family and a parent? So as I mentioned, right, when a patient is diagnosed, doctors from around the country will go and say, will you sign this form to allow ARTS to put your child's information into a database? Well, that can happen from B1 as B1 gets phased out in terms of Project Every Child from Children's Oncology Group. We're starting to figure out how to enroll kids on that as well. And that information will be transmitted securely, right, in terms of things like when somebody was diagnosed, how old were they when they were diagnosed, what is their MIC-N status, what is, where is their disease, things like that will get transmitted to a COG database. And that patient will get a COG ID number so that the name and the identifying information will get disassociated from all the rich data that the researchers want to study. And that COG ID will be some sort of a number perhaps. And the beauty behind the INRG is they worked out with COG and other cooperative groups, how can we get data from all of these databases so that, one, we're not interfering with what COG is doing, but also that we can compare select patients across institutions, across studies, track their biology samples over different places that they might go to get different sort of sequencing information, and do it in a way that's going to be unidentifiable to researchers so that we can distribute this freely without the risk of releasing patient information, right? Because we want to make sure that we are maintaining the privacy of all the patients and their families who are contributing to this database. And so there's a system now in place, and this is primarily done by Arlene Naranjo as the COG statistician. She has a key that will have all of the COG IDs for all the patients who have signed the B1 consent or other neuroblastoma consents, and they will get recoded into what's called a universal specimen identifier, or USI number. And this USI number, as you can see, they might go from something like 1, 2, 3, 4, 5 to A, B, C, D, E. So it's a totally different code. It's a totally different nomenclature. And having worked with plenty of USI information, USI data, or USI coded data, I should say, I have no idea how to connect that to a COG number because Dr. Naranjo will never give that information out to anybody. And then, now that all the data has been recoded into USI, the select fields that have been agreed upon between the cooperative group and the INRG has been decided upon. Those specific data will then get transmitted to the INRG, specifically linked to the USI number and decoded from the COG identification number. And this is how the INRG was built and continues to be built to this day. And so from the initial INRG task force, a couple major sort of landmark papers came out in the field. One was, as was mentioned before by Dr. Desai, the criteria for what is an image-defined risk factor. So for those of you who are taking pictures about that, if you want to do some exciting reading, you can go back to this 2009 paper. It was also the development of the INSS that was also touched upon earlier, right? This is the first pre-surgical staging system where it mattered more about what is the biology and the features of the patient and not about what is the sort of the level of your surgeon and their willingness to do a more aggressive operation. And so this was obviously a key for setting up all many of the staging systems and many of the risk grouping that has come since. And then secondly, we said, okay, Dr. Cohn said, okay, there's all this rich information on these 8,800 patients. What are the features that make someone higher risk or lower risk? Beyond just sort of saying what are the classification that we might use, are we actually going to be able to say, now that we've got all these patients from all these studies from across the world, what are really the true features of a high-risk neuroblastoma patient? What are the features of a low-risk neuroblastoma patient, and you know, what might make someone intermediate risk? And from this came the INRG risk classification system, which is, you know, as Dr. was mentioned, being integrated into COG studies moving forward. So, you know, it really was this pretty vast international effort that's leading to these classifications moving forward. And this is the initial INRG database. So as I you know, sort of gave away earlier, right, it was a giant spreadsheet. And this was kept by Wendy London, who, as Dr. Federico mentioned, he was one of the sort of master statisticians within COG. And this was coded out for, you know, 8,800 patients, and really this very rich data set of, you know, 20, 30 different fields of data. And what I think was a major advancement of this group, right, is said, okay, we've got this, let's keep using it. You know, it was a unique resource for this disease that was really unavailable any other way. And I think Dr. Cohn and Dr. Pearson and the rest of the INRG task force really were quite insightful in saying, let's make this available to everyone. And that's essentially what has happened. And they set up a system wherein investigators, such as myself, many, you know, a couple of the MDs in this room, could write an application to the INRG and say, here's the question I want to ask. I'm really interested in a big disease group, or in this case, I'm really interested in looking at a very rare, you know, sort of clinical cohort that might be similar to one of the patients I just saw in clinic, all right? And I want to say, okay, I didn't really know much about this patient because there's not been a lot published about somebody with only nodal disease. Maybe I can go to the INRG database and find hundreds of kids with nodal disease only. And that's what this database facilitates. And so researchers can apply, and they say, here's my idea, here are the statistics I want to run, here's how I want to analyze the data so I can answer this question about you know, rare or common groups within the database. And here's some examples of how that works in practice, right? So, you know, going back to Dr. Bagatel's paper about localized disease and MICA amplification 2009, you know, this ends at, you know, one of our papers that we published looking at second cancers amongst neuroblastoma survivors. But there are many, many more of really sort of narrow cohorts of sometimes 60, sometimes a few hundred patients that we really could not understand anything about otherwise. Because even within Children's Oncology Group or with SciPen, you know, with these small, rare cohorts, the more data you have, the more you're actually able to say. And so this is now the forward-facing website for the INRG. This is, you know, a public, open website. There's lots of things one can do here, so it's inrgdb.org. The picture's since been updated to a recent photo that was taken at ANR earlier this year, but you know, the idea is still the same. And this website is a great resource for both scientists as well as parents and anyone interested in neuroblastoma. There we go. And before I get into the details of what's there and how we use that website and how we think about the database in its current form, and I want to just point out that this is truly a collaborative effort. This is team science, right? So it's led by people like Dr. Cohn and Dr. Pearson, as well as Dr. Schleiermacher and Park. So there's, you know, representation from both COG, SciPen. You can see that the cooperative group chairs across the world, including Dr. Federico and others, are included as part of the, you know, the leadership committee. And then there's various subgroups that are assigned with different missions, right? Things that are of interest to the field, such as, you know, genomics, understanding patterns of metastases, understanding more about what we can learn about relapse data. And so the various subcommittees will think about how we can sort of answer specific questions that we need to answer within the field using this you know, sort of large data set. And so as of May 9th, you know, there's about 25 to 26,000 patients within this database. You know, I mentioned that it started as 8,800, but we are constantly adding, and this is very much a living database. And what I'll point out here is that, you know, our colleagues in Europe and Japan, they never had a biology study, so the only way the patients could get into their registries is actually through clinical trials. What I like to point out on the left here is we've got two different bars here, and, you know, with about 8,000 patients, 8,600 patients. The ones, you know, in the light blue, those are patients treated on clinical trials. Many of the ones you heard about earlier, who got, you know, who we know that kind of information. But we also have, you know, about half the patients from the Children's Oncology Group, which is, you know, good third or so of the data set is patients who were not treated on a clinical trial, and were, just signed that form to say we can be in a registry. But really adds a lot of data, a lot of power, a lot of information that wouldn't have been available without those biology studies I pointed out earlier. And as I mentioned, this is a living database. People are constantly adding new information. The INRG is very excited that they're now collaborating with St. Jude to include patients who are treated there, and de-identify, sort of making sure that there's not overlap, as patients can come and go between COG institutions and that institution. But just in the past year, the INRG has obtained information on probably about 3,000 or 4,000 new patients, as you can see. They get new COG data every 6 months for new patients that have been enrolled on the biology study, or now hopefully APEC, and then outcome data every couple of years. So this is a living thing. So we always make sure when we're doing an analysis that we're using the latest data, because we know things will change. And if you go to that website, you can actually, so with a simple Google account, you can actually start to understand some of this data. So again, as of May, there are about 25,000 patients. And all the data elements that were used in the original INRG classification paper there, more data keeps getting added, and more types of data keep getting added. So information about race and ethnicity have been added. Information about what clinical trial a patient was on was actually just recently added in the past couple of years, which obviously allows us to understand perhaps what treatment the patient received. As more patients are treated with antibody or stem cell transplant or other therapies, right? It's really nice to have a sense of what was the therapy they got, because we know that will inform their outcomes. There's also recently been information out about second cancers, which I mentioned before, as well as some imaging data, and I'll show you an example of how that's being used in a little bit. So if if you get tired of me speaking and you got your laptop out, any one of you could actually log into the INRG Data Commons right now. It's, as I mentioned, open to the public, and all you need is a Google account. Or there's a couple other ways to get in there, but Google tends to be the easiest. And anyone can register. It's free, it's pretty instantaneous, and you can log in and you can actually see exactly what data live in this data commons. And I'll tell you, it's not just neuroblastoma at this point, but mostly neuroblastoma at the moment. And once you log in, you can go to the Data Explorer and you can learn a little bit about who these patients are. So what I'm showing you here is just a screen capture of just the INRG patients. This was taken, a little bit, probably last year when we had, we'd say 24,000 patients. But you can see some basic demographic information in terms of male, female, race and ethnicity data can be displayed, as well as other data are possible to display. And then you can start, if you wanted to, doing cohort searches. And you can say, well, I really have a question. I want to know, how do patients with localized disease do? How many of them are there in this database? And are there enough to answer some question that I have? So in this basic example that I'm walking you through, you can, it's possible for researchers, for interested parties, to go in and say, I want to get all the neuroblastoma patients, and I want to know how many there are with INS stage 1, 2, or 3 disease. And you can save that cohort, and you can learn about, and you can know exactly how many there are. And then let's say you also want to say, well, I want to compare patients with localized disease to those who have metastatic disease, and how do they do? And you can make a cohort of patients who have had metastatic disease or INS stage 4 disease. And there's a tool built in where you can actually take that information and we'll say, well, I actually want to know how they did. What was their outcome of those particular patients that we're able to create this tool for? And so you can say, take the stage 4 patients and say, what is their survival by Kaplan-Meier analysis, and what are the localized patients, and what was their survival by Kaplan-Meier analysis? And the website at this point will actually generate this graph for you. You just say, here's the cohorts I'm interested in, and it will automatically plot these curves. It won't give you statistics. You can see sort of general numbers. The cooperative groups don't want people publishing these data, so you get a nice watermark back there. So a lot of thought has been put into here about data security, p-hacking, people using this for sort of just trying to find random associations that don't make any biologic sense. But like I said, it's a good, for researchers, this is a really nice hypothesis generating tool, and we can go in and say, okay, I'm really interested in this rare disease or rare subset of neuroblastoma. how many of those patients are there, get a sense of what their outcome might be like, and get a sense of, is this something that as a researcher or as a scientist that I want to spend time on? And then it actually turns out that the INRG committee also really likes to see that somebody has done this and thought about it before they approve new projects. And the INRG is putting out, I think, some very interesting projects, some very interesting data. These are some recent examples, but you can also go to that website, inrgdb.org, and you can see everything that the INRG has ever been published, or has ever published. There's a link to that. There's also a link to projects that are ongoing and in process, and you can see the proposals that people are working on, and you can see sort of where it's been presented and what the data are. But it's been a very productive consortium, and we're still learning new things. And these are just a couple of papers that were recently published this year. One from Dr. Campbell and Du Bois looking at INRG stage as a predictor within the database, as well as work led by Dr. Desai looking at race and ethnicity outcomes of patients within the database, following up on work that was done by Dr. Henderson about a decade ago. There's also been several abstracts that have been presented at recent meetings. And the one on the bottom I actually want to point out is a very interesting example of ways the database is actually expanding. So one of I'll call it the limitations of this database is that the Children's Oncology Group and the cooperative groups don't collect specific treatment data. Because the way the studies are designed, they're designed as an intent to treat, or what arm was this person assigned to, regardless of what they actually got. The Children's Oncology Group doesn't have the resources, or hasn't prioritized, and Dr. Federico can correct me if I'm wrong, doesn't always have that information of exactly what somebody got. And so one of the things that Dr. Cohen and Dr. Wolchenbaum and others at the University of Chicago have been doing is actually trying to link the INRG patients from our institution to the EHR, the electronic health records. And they're working on actually extracting that treatment information for those patients and linking them to their INRG numbers through the USI. This is obviously a big project because it has to actually go through COG because we need that key, and COG holds the key. So this is a project that they've been working on. They actually showed that this was possible in proof of concept, and there are efforts that are working now to expand this to other institutions so that we can start getting that rich treatment information to know exactly how much antibody did somebody get, how much topotecan did somebody get, to really link outcomes with hopefully side effect data as well as outcome data. And as I mentioned, there's been a lot of projects published, underway, and recently approved. Many international collaborations are fostered by this. In fact, it's strongly encouraged by the executive committee that there be representatives of multiple cooperative groups on every project so that we are all working as a big team. The other really important facet, I think, of the INRG data commons, is training the next generation of researchers. And I was recently told that I'm no longer allowed to call myself a young investigator. So now I'm looking at how do we build the next generation. I got my start actually in database work and research. So when I was in San Francisco, I met Steve Du Bois, and he actually gave me a database project to work on as my very first research project. I had no interest in research prior to that. But actually, through working with him and through that project, discovered, this is actually something that I enjoy, and really changed the trajectory, such that now that I spend, most of my time thinking about how we can improve, neuroblastoma outcomes through basic science research. So, database projects and projects like, things that can be accomplished with the INRG actually become a really good tool to both interest and educate the next generation of doctors and scientists about about research and research methodology. And realizing this, the INRG has significant efforts in trying to increase the number of new investigators who are looking into neuroblastoma, increase the number of young investigators who are involved in projects at really any level, whether that's driving projects forward or just sort of being involved in the team to really understand how the process works. And because this is an international consortium, right, we're able to pull in mentors and senior faculty from around the world who have expertise on whatever the topic at hand may be, to work with those young investigators to really move the field forward, move the scientists forward, and find new ideas and innovative ideas that might not come from sort of the standard people who think about this and are running the database. Another sort of exciting feature that's coming down the line is that this database, while primarily clinical data, is being linked to other sources of genomic data, as well as sequencing data and other kinds of information that are not currently held within the INRG. The INRG has very much been focused, as I mentioned, on what is the biology of the tumor, what is the patient's, what is the patient's age, clinical characteristics, and tumor characteristics. But because of that USI number, right, when COG has, or any other group has released biospecimens to researchers who do sequencing and then put that sequencing online and make that available to public, it's always tagged with that same USI number. So it's fairly straightforward to link patients from the INRG to another data commons of sequencing data or other information through that USI number. And now the INRG actually has a direct link where if if a researcher or anybody here had a cohort they're really interested in and they wanted to know is there sequencing data, there's a quick search tool, and actually it's able, people are able to download the list of what patients have that data, go to that database and say, here are the patients I want, show me the data. And then they can grab that data from that other sort of genomic data commons. So really facilitating the link between patient information and broader genomic information as well. I'll highlight one other study that I think was pretty cool, but I'm biased. So this was a study where the first study where INRG had worked to get imaging data linked to the INRG data. Primarily spearheaded by Dr. Volchenbaum in getting the data available. But patients who are enrolled on one of the COG protocols, 12P1, there were about 100-something patients who had MIBG scans that were collected centrally by the Children's Oncology Group. And Dr. Volchenbaum worked with the NIH to de-identify those scans and link those to the database through that USI number. And thus, now we had a few hundred MIBG scans, some CT scans, linked to the INRG so that people who are interested in using those data could do it through COG, but could also do it through other mechanisms once more data is added, right? This allows for the opportunity to link MIBG scans in the US with MIBG scans in Europe, for example. This is a very early sort of pilot project based on that, but effectively what we did was we took those MIBG scans and we tried to say, using things like machine learning and artificial intelligence, could we actually try to predict who was going to respond to therapy? And the short version was kinda. So this, there's always a data problem when you're talking about AI in pediatric oncology. But this is, what I'm showing you here is effectively a heat map, or sort of an image of what is the machine learning or the AI looking at when it says, where is neuroblastoma in the body? And all those sort of red spots, the greener spots, were where the algorithm was looking at the MIBG scan to make a prediction of, was this patient going to respond to their therapy or not? I won't get into the details. The sort of utility of this was modest, but I think as a proof of concept, it's a very interesting idea. And as I mentioned, the INRG is constantly evolving and constantly changing. And new data elements are coming, and so that we'll be able to learn new and exciting sort of information that we can use towards thinking about the next clinical trials. So as was mentioned, ALK, obviously very important in understanding neuroblastoma biology and potentially therapy. There's committees, the genomics committee has been working very, very hard to get that data from the cooperative groups so that ALK aberrations, whether they be mutations, translocations, be sort of clearly and readily identifiable within the database. The other variable that obviously has been touched on a couple of times already, but is not currently available, is response data. I learned from Dr. Cohen very early on, if a patient responds to treatment, they're going to do better. That's sort of a mantra we have at University of Chicago, although it's kind of obviously a little bit obvious, hopefully. But anyway, right, response data is super critical to understanding the patients, their outcomes, and give us an idea of what treatments are working and what are not working. And those response criteria, whether they be INRC from 2017 or the Bordeaux criteria or others, are also being collected and hopefully will be making their way to the database soon. So with that, I'll pause. Happy to take questions. These are sponsors of the INRG database or data commons. As Pat mentioned, CNCF was an early contributor to get this up and running, so thank you all for your attention.
Does anyone have any questions? All the math majors in the room.
I'm Allie Springsteen from Illinois. Mine's kind of a general question, maybe not necessarily to you specifically, but as a parent, how do we go about getting our doctors, like we don't have a doctor who specializes in neuroblastoma or knows much about it, so like they don't do urine tests except for at diagnosis. They don't know about the HA test. They didn't realize you could have neuroblastoma without bone pain. Just little things that they don't know. So like as a parent, how do we go about changing that at our hospital? Or who would we like, I don't know, discuss
Yeah, no,
it
that's a great question, and I'm sure many of my colleagues would have their additional thoughts on that. I think dissemination of information and asking good questions is always important. It is, in my experience and the experience of many of my clinical colleagues, right, we're always asking each other questions. People are constantly reaching out, doctors from other institutions who know more or know less, and saying, what should I be thinking about? How should I be thinking about this patient? What test should I be ordering in some cases? And is this the right approach? Our team gets many of those emails, calls, frequently. I'm sure that is happening across the country at some of the major neuroblastoma institutions, right? The clinicians are getting many, many calls from both parents and doctors saying, does this make sense? So from one level, I think that's, sort of the organic way for it to happen. Other ways that are happening, right, there's guideline papers that are, put out by the Children's Oncology Group that are being worked on by the INRG. I'm actually part of a group that's working on, what are the biomarkers that we should be using now and what are the biomarkers that we should be using later. Those papers take time and are few and far between, but those are always, I think, good resources for clinicians who are less familiar with the disease to say, what should I be testing? What should I be thinking about? How should I be doing this? And it's not just for biomarkers, right? It's also for, how do I treat, upfront neuroblastoma, and when should I be getting scans? So, or other kinds of urine tests. So I think those are the two ways, sort of from the bottom and from the top, that I think it tends to happen.
Any other questions?
I have a question. I didn't introduce myself last time. Megan from Los Angeles. Thank you, Dr. Applebaum, for a great and really informative presentation. Earlier in your presentation, you mentioned the decision to recently add race and ethnicity as a marker that can potentially, help us look at outcomes. So were there any indications that would lead you all to add that now? I think it's great, but was there any data to suggest that informs outcome?
Yeah, no, that's a wonderful question, and obviously a critical question that we should be asking, given the disparities that we know exist within our healthcare system. This was actually started by, I think, Dr. Cohen and Dr. Henderson, two of my colleagues at the University of Chicago, who published an initial analysis of this, back in about 2010, I think, was when this was actually published originally. And there was an identification that patients, Black patients, had poor outcomes with high-risk disease. And one of the things that the INRG is very conscientious of, and it's actually, I think, quite interesting that Children's Oncology Group collects that information. In Europe, there are no race or ethnicity data that are collected. So this, was sort of an INRG study of COG patients. And we wanted to ask, how have the disparities changed over time? And Dr. Desai can speak more to this as she was the senior author on this, but I think it was really important for the INRG and for researchers thinking about this to say, how can we think about all of our patients, and all of the groups that we should be thinking about to make sure that everyone is getting the optimal care?
Mind if I add something?
Please.
Okay.
So I think in the original report that Dr. Applebaum is alluding to, we saw that there was a higher incidence of high-risk disease among Blacks and Native Americans, but the treatment actually mitigated the differences so that all high-risk patients, despite race and ethnicity, were doing about the same in that original report. I think in the updated report, when we're looking at a newer cohort that just recently was published, that we're seeing some of those still similar incidents and disparities. And in current era therapy, we're sort of seeing some differences in how in outcomes among the high-risk patients based on race and ethnicity that requires additional investigation. So it's a little bit hypothesis generating and will need to be investigated further. But I'll say beyond that, there are a lot of investigators through the Children's Oncology Group, really work spearheaded by Kira Bona and others that are also looking at, the impact of social determinants of health and things such as poverty and being able to get to your appointments or have healthy groceries or have a good diet and all those things and how that may also. So beyond just treatment, people are looking at other social determinants of health and how can we really optimize the outcomes for all of our patients through, like, all around.
One more question?
Can you see down the road that possible microbiome data be involved?
Yeah, no, that's a great question. I think microbiome data are certainly starting to be collected by various groups for patients with neuroblastoma. I think it would be interesting to include any data, right? I think more data, as somebody who likes to study large data sets, more data, always better data. And so, where does the microbiome data go, though, is the question, right? So I would see it probably more as a linkage kind of thing, but yes.
What institutions are gathering that data right now?
Yeah, so
of
the two that I know of, and I'm not going to say this is any way conclusive. I know some of this work is being done at Sloan Kettering. I know we have a project at the University of Chicago working on this.
I'm sorry.
University of Chicago,
Okay.
Comer. I know Dr. Desai is actually also leading that project as well. So, and I'm sure there are other sites that I'm just not as aware of, but I know there are people looking at that specifically for children with neuroblastoma.
Thank you, Doctor.
Of course.
Okay. All right. Thank you, Dr. Applebaum.
Thank you.
I'm going to stay down here. Our next speaker is Dr. Liz Sokol. She's an assistant professor in the Department of Pediatrics, the section of Pediatric Hematology Oncology and Neuro-Oncology and Stem Cell Transplant at Lurie Children's Hospital here in Chicago. She has received her BA in biochemistry at the University of Pennsylvania and her MD at the University of Illinois at Chicago. She did her residency, fellowship, and postdoctoral fellowship at University of Chicago Comer Children's. She is a member of numerous societies and has co-authored, again, numerous publications and book chapters, and her talk today is on genetic alterations in neuroblastoma. Dr. Liz Sokol.
All right, thank you. So we're going to take a little bit of a step back here with this talk to kind of zoom in a little bit on what people have been talking about in some of the prior talks and give a little bit more background about what we're thinking about when we talk about genetic alterations. What are those? How do we think about those? How do we frame those things? And what are they? Okay, so I have no disclosures for this talk. So genetics is a very broad field that has evolved greatly over time. And really frames a lot of the work that we do in the way that we're treating these patients with neuroblastoma. So zooming in here from the level of the tumor cells that we have inside of all these cells, we have things called chromosomes, kind of those X-shaped structures that are made up of our DNA. That the DNA is comprised of pieces that we call genes. That are all made up of base pairs at the most basic level there, the letters that define the sequence of these things, that define how all of our bodies work and function. At the most basic level, alterations in this can cause all kinds of changes from what color our hair is to how a tumor behaves. When we think about genetics in cancer, we have to make a distinction between changes in the DNA in our whole body, and what we term germline changes, to what happens in just the tumor itself. And there can be alterations and are alterations that are not present in all the cells in our body, but are really present in the tumor. And in the spectrum from normal cells here to the tumor cells, there can be alterations that occur, errors in DNA as they replicate that lead to the development of a tumor. So all cancers have some kind of genetic alterations that cause them to grow out of control. And those are often, certainly not always, related to changes in the whole body. So when we think about these genetic alterations, what are they? What do they mean? Well, we'll use sort of an analogy here, thinking of the DNA as a sentence, where we have a series of words. So in this case, the gray cat ran down the hall. And there can be small changes in that sentence that change what the sentence means. And in the sense of a tumor, it can change the way that a tumor behaves. There can be single base pair changes. Those missense changes, that first example there, where the H becomes a B, single change changes what it means. The gray cat ran down the ball. Maybe that doesn't make any sense. Maybe that's going to lead to a tumor that doesn't, that grows out of control because that word no longer makes sense in the typical way. There can be base pairs added, genes added, that here a gray-green cat. So again, changing the meaning of the sentence. The words can be deleted in the same way, they can be duplicated, or there can just be truncations or things where we just lose genetic material. These are what we call nonsense mutations. So all of these things, in the way that they change the meaning of the sentence here, change the way that a tumor might behave. So those are all different types of mutations. The other thing that I don't have sort of in sentence form here, but we talk about translocations at time, which means you basically take two sentences that you have and they fuse somewhere in the middle, taking part of one, linking with part of another, and again, changing the structure and the meaning of what those things are. So first thinking about the changes in tumors in neuroblastoma, so not talking about the germline whole body changes, but in the tumor, two of the genes that we hear most often about are MYC-N and ALK. We've already heard them in multiple talks already today, but these are well-characterized, well-known changes that alter the way that tumors behave. MYC-N is a gene that was identified early on that we know some proportion of neuroblastoma tumors have what we call amplification, which is not only one extra copy of this gene, but many extra copies of this gene. When we see that MYC-N amplification, that can be associated with poorer prognosis. And about 20% of neuroblastoma cases have this genetic change. As Dr. Desai mentioned, this is something that we use in the base risk stratification because we know that this can predict high-risk behavior in the tumors. ALK can be altered in a number of different ways. There can be amplifications as well, mutations or fusions, all that can happen in this gene in particular. It's altered in a proportion of neuroblastoma cases. I have 6 to 12 here, depending on which publications you look at, that number is a little bit varied. And we know that these patients with ALK aberrations can have higher rates of disease relapse or recurrence, which is why we're really looking at targeting that in our upfront studies, as has been already mentioned as well, especially in our high-risk patients, looking at the addition of ALK inhibitors early on to try to mitigate this increased risk of relapse that we see with these patients. Another set of genetic alterations that we see in our patients, this was alluded to a bit by Dr. Desai talking about our adolescent and young adult patients with neuroblastoma, although not the classic patient, the toddlers that we see, are alterations in telomere maintenance. So telomeres, as pointed out in this image here, are the very ends of our chromosomes. And there are mechanisms that cells have to maintain these telomeres, which can maintain the integrity of the DNA. And as people age, we naturally see shortening of these telomeres. So it's a normal process that happens. Now, some tumor cells have mechanisms to maintain those telomeres, to allow them to replicate over and over again, allowing the cells to grow and not to age, as would normally happen with cells. And so various tumors have alterations in this, including neuroblastoma, that allows those cells to replicate faster and more than would healthy normal cells. And so these genes, TERT and ATRX are genes that alter the function of telomeres. We often see these in our older patients, as we alluded to, that can have these changes and allow the cells to survive longer than they would. And they can be additionally associated with therapy resistance, not responding to our therapies in the same way that we might otherwise. And so these are some genetic changes that can happen that dictate the behavior of our neuroblastoma tumors. Other genetic changes are identified, although globally, when we think about neuroblastoma in general, there are fewer mutations than we see oftentimes in adult malignancies. Important to point that out. So when you're talking about breast cancer or colon cancer or other types of common adult malignancies, there are many, many mutations that build up over time, over the course of those adults' lifetime, and make a complex genome in those patients. We see many fewer alterations and many fewer mutations in neuroblastoma and other pediatric cancers as well. That said, there are some pathways that can be altered. This RAS-MAP kinase pathway, as I have alluded to here, and the gene P53, these are common genes that are affected in a variety of cancer types. They're not specific to neuroblastoma, but they can be altered in a variety of ways to make tumors more aggressive or lead a cell to become cancerous. Some of these genetic alterations have specific drugs that can target those pathways, so we have those potential down the road to utilize, but these are much less common in our neuroblastoma patients compared to other tumor types. These can also potentially be identified more often in the setting of recurrent neuroblastoma, so we don't as often identify these up front if we're looking at the sequence of the DNA in tumors at diagnosis, but may find them later on with tumors that have relapsed. So switching gears a little bit to something that is more common in neuroblastoma tumors, and this is what we call copy number changes, changes in the amount of DNA that we have. So I have two different figures here from work that was published back in 2011 by Dr. Schleiermacher that looks at different ways that the chromosome numbers can be altered. So to orient you to these figures a bit, across the bottom here, we have all the chromosomes that exist in our cells, from chromosome 1 to chromosome 22, and then the X and Y chromosomes. And so what this figure is showing us is a deviation from that midline shows either extra DNA or less DNA than there typically would be. And so in the top figure, if we, for example, look at chromosome 2, see if we're able to see this here. You can see that there is that red bar that rises up over that midline to say there's extra copies of chromosome 2 there. There's more than there would typically be, but it's level across that line, across the whole chromosome 2 time frame there. So in this particular patient, they have extra copies of the whole of chromosome 2. So that would be a whole chromosome gain, we might call that. On the flip side, on the bottom line there, you see there's some extra DNA from chromosome 2 present in this bottom one, but it's just the beginning part of it. It's just that early part of chromosome 2. That would be what we call a segmental chromosomal change. So there's extra DNA there in that case as well, but only part of it. So the DNA is a little bit more broken up, is a little more irregular. And so these are the two main sort of patterns of copy number changes that we can see, either whole chromosome gains and losses or segmental chromosome gains and losses. And these are associated with different prognostic significance. So as mentioned there, more common. So when we see the segmental changes, when there are those pieces of gains and losses, this is often associated with more aggressive disease, inferior survival, as opposed to the whole chromosome gains and losses are often associated with better prognosis. Right now, this is used through the Children's Oncology Group in intermediate risk disease to stratify, making sure, and the study ANBL 0531, as Dr. Desai had alluded to, had utilized this sort of data to say, do they have a favorable biologic profile or a less favorable profile? And would stratify the amount of cycles of chemotherapy those patients received based on that information. In multiple different types of analysis, certain chromosomal changes have come out. So this here, thinking about these segmental changes, where we have the, again, partial gains and losses. Here we have listed what has been termed the thiopin 7, or some common patterns that are seen over and over again, where we may have gains in chromosome 1q, 2p, or 17q, or losses in 1p, 3p, 4p, and 11q. And just to clarify, what does that mean? I show you a copy of a picture of a chromosome here again. The P and Q refers to which arm, which part of that chromosome is changed, the P being the shorter part of it and Q being the longer part. And so again, we may have changes that lead to there being partial chromosome extra or less than there might otherwise be. And when we find these things, it tends to be, again, more aggressive disease. As opposed to here, I show an example of whole chromosome gains. This is often a phenomenon that's seen in infants with neuroblastoma, our youngest patient. But you can see here, for example, chromosome 2, that we've talked about a couple times. In this particular example, there are 4 copies of chromosome 2, whereas in a normal cell, there would be 2. And you can see in other chromosomes here, there are also extra copies. So switching gears a little bit, those are all changes in the tumor itself. But there can be, in certain cases, changes in the whole body, in the germline of the patients as well, that may make them more prone to developing neuroblastoma tumors. This is significantly less common. In most of our patients at this time, we do not identify a predisposition that identifies why they develop their tumor. Although these associations certainly exist, this is relatively more infrequent. So I start here with this saying, germline genetic testing is not always recommended. In most cases, it may not be. But your physician likely asked questions about family history. Are there other cancers that have triggered a concern for a germline alteration, or other clinical features, other symptoms, or other features of the patient that may indicate there may be an underlying predisposition? So we'll go through a couple of the predisposition syndromes that can exist. First, here we mention a group called neurocrestopathies. So this is a series of types of syndromes and patients who may have a number of types of medical concerns even beyond their tumors. The first group have alterations in a gene called FOX2B. They may have a syndrome called congenital central hypoventilation syndrome. These patients have a variety of findings and medical needs. Altered breathing. They may not breathe as readily as they should. The nerves don't trigger their breathing in normal ways. They may have altered nerves within the GI tract, causing something called Hirschsprung's disease. These patients can have altered nerves that feed the heart and have cardiac arrhythmias. And so this is a syndrome that really impacts nerve development, and these patients can have an increased risk for neural crest tumors, including neuroblastoma and ganglioneuroblastomas, et cetera. A semi-related syndrome is called Rowhead syndrome. This one has a much less understood genetic backbone, but can have similar features where there is rapid onset obesity with, again, altered breathing, some endocrine anomalies, and these patients as well can have increased rates of these neural crest tumors. It is fairly unusual in these syndromes to find the neuroblastoma first, whereas many of them will have presented with the breathing changes, the intestinal changes, and then later identify a tumor. So often we're not sort of back testing looking for these things because the clinical presentation of the patient will guide us if these things are a concern. Other predisposition syndromes. So ALK, we talk about it most of the time in the setting of a somatic change, but there are a few families that have been identified that have familial neuroblastoma that is presented in multiple generations of patients and have a germline ALK gene change. And so while this can be altered in as many as maybe 15% of neuroblastoma tumors, it is a much, much, much more rare phenomenon to have ALK altered in the germline of the patients. But this would be testing for this would be driven usually by family history. So for these patients that have these predispositions, whether they have other medical concerns or they have an ALK germline mutation, what do we do? How do we monitor those patients? So those patients would have surveillance done for neuroblastoma. It's different than the surveillance that Dr. Desai mentioned in sort of the general population, where we really found low-risk tumors and did not impact outcomes with our surveillance. In patients who have a known predisposition, we do recommend surveillance with ultrasounds of the abdomen, with x-rays of the chest, and with those urine catecholamines. More often when they're younger, so before age 6, every 3 months, these patients may have surveillance, and in years 6 to 10 with every 6-month surveillance. And because neuroblastoma, as it is in all patients, becomes less common after age 10, we typically do not do surveillance after that time, although we know that it is possible to develop a neuroblastoma after age 10, certainly. Okay, so there are a couple of other syndromes that are not very neuroblastoma specific, but that can increase the likelihood of developing a neuroblastoma as part of it as well. These are patients, again, who may have other findings, may have developmental delays or intellectual disabilities, may have other birth defects and genital anomalies, may have altered growth, may have skin abnormalities, may have hormonal changes. This is a fairly broad list of potential involved signs and symptoms, because these are a variety, a range of diagnoses that can come with a potential increase for neuroblastoma or potentially other types of malignancies as well. Again, these are often identified because of the other findings, the congenital anomalies that present, the other things that may be associated with it. And so the screening that might be recommended really depends on what the syndrome is and how likely that increased risk of a malignancy is. I think these are similar to the slide that Dr. Desai showed you, some of these examples of these syndromes that could be altered and come with an increased risk of neuroblastoma, the Costello syndrome, Noonan syndrome, Fanconi anemia, Beckwith-Wiedemann, and Weaver syndromes as some examples. And then there are some other family cancer syndromes that can come with increased rates of neuroblastomas as well. These may not have other congenital findings, other findings that may point out to these other than sometimes the family history, although anything can develop at any time. So Li-Fraumeni syndrome is sort of the classic prototype of a cancer predisposition syndrome, where there's a germline alteration in this gene P53 that can predispose to the development of lots of different types of malignancies. Neuroblastoma is not one of the classic Li-Fraumeni, which is the name of the syndrome here, diagnoses, but it has been reported in families with Li-Fraumeni syndrome. And here, this next one, this familial paraganglioma or pheochromocytoma syndrome, is neuroblastoma. Again, is not the classic diagnosis associated, but has been reported in these, and these patients are at risk for other adrenal tumors as well. So screening in these patients is not really targeted at neuroblastoma screening, so often does not include things like urinary catecholamines, but the screening that would be done for a variety of cancer types in these patients may pick up things like neuroblastoma when that's done. So circling back a little bit, so when do we do this germline testing? When is this recommended? By and large, most patients with neuroblastoma, they don't need to have germline testing done. Now, in some families, if there's a significant family history of cancer, that may trigger some testing and referral to a cancer predisposition program that has genetic counselors and teams of physicians who specialize in this to look for underlying genetic predisposition. Sometimes the clinical symptoms, the other medical concerns that a patient has may trigger some testing. Or sometimes if someone has done analysis looking at the tumor itself, there may be a finding that may be identified that they say, well, maybe that could be a germline finding and may reflex after doing testing on a tumor that says, let's look in the germline as well. And so most of the time, again, this is not done, but it's something that's often in the back of the minds of pediatric oncologists thinking about patients who are developing cancer and tumors early on in life. and how we can make sure that we're thinking broadly about how to look for other findings that may be related to their neuroblastomas. Typically, these things, the genetic testing, the germline changes that we identify, do not typically impact the treatment that is done. We still need to do everything that is needed to treat and cure the primary cancer. And so, although this information is helpful for us to think about the future and planning for potentially the patient and family, it's not going to change typically the treatment that would be given. So that's all I have. I'd be happy to take any questions at this point.
Thank you, Dr. Sokol. Does anyone have any questions? Nope. Okay. Oh.
Thank you so much for your presentation. My name is Marna Costanza. I'm from South Carolina. Actually, I have two questions for you. The one has to do with the development of drug resistance during neuroblastoma treatment, and the other one has to do with cell-free DNA.
Okay.
So in terms of, well, we all know that frontline treatment for neuroblastoma contains combined drug therapies because that seems to be more effective. In some other systems which are granted, less complex, so, the evolution of drug resistance in bacteria or something like malaria that's, a eukaryotic parasite, they found that the pathway from being completely susceptible to a type of drug treatment to becoming resistant is predictable. So even though conceptually there are, maybe millions of pathways to becoming drug resistant, genetically they only follow a few, right? And so I was wondering if in neuroblastoma that's something that is possible to study, or if it's been observed that you can either predict what type of drug resistance will evolve from treatment, or you can tailor specifically which drugs used together to stop that.
Sure. It's an excellent question. And I think you kind of alluded to the answer to some degree that I would give you, is that neuroblastoma and many tumor systems are just so complex and heterogeneous. And so I think it becomes difficult to predict because you may have part of a tumor that becomes resistant in one way and another part of the tumor that becomes resistant in another way. And so trying to see from the time of diagnosis what may happen, I think is very challenging. We do use multimodal therapy because then if there's resistance to one agent, you may overcome that with other drugs. And in neuroblastoma, certainly in high-risk therapy, we do that in sort of the nth degree with lots of different types of modalities of treatment, from different drug types to radiation to immunotherapies. But I think it's very challenging to know from the outset which part of a tumor may sort of become the part that's going to be problematic, and how to target each part of that tumor specifically. So I don't think we have those answers with current technologies, but certainly in terms of analyses looking at single cells and doing single cell analysis, I think people are working to try to understand that more so, but I don't know that we have the ability currently to really identify those resistance mechanisms up front.
So one more question.
Sure.
Just with most people here who've had kids who've had neuroblastoma, you get the tumor gets sequenced, you get the chromosomal level data. But now that being able to test cell-free or circulating DNA is more accessible, are there any, is there any development in that? Or are there situations where that's helpful?
So there's certainly a lot of work as partially being done by Dr. Applebaum here, looking at the use of cell-free DNA. So if you want to, yes, go for it.
Yeah. So in terms of cell-free DNA, so that's an excellent question. My lab studies a lot of it. So there's a lot of different platforms that are out there to look at cell-free DNA. I know, there's groups looking specifically at very targeted panels for 23 genes, that most likely to be involved in things like ALCA aberrations and RAS-MAP kinase mutations. There's groups that are looking at whole genome sequencing and what can we learn from copy number, and also doing deep dives on that. And there's also trying to look at actually the question of tumor evolution. How do things change over time, as tumors get exposed to different mechanisms? Our lab is looking at epigenetic markers and sort of how things are being utilized. And there's a lot of work being done on samples collected off of AMDL 1531 that's going through this. There's a lot of in-house studies, so there's a lot of work being done on it. The Children's Oncology Group actually also just started a cell-free DNA working group to start thinking about how do we actually incorporate cell-free DNA into clinical trials, and how do we use those as informative biomarkers. That group has met once, so it's very, very early days, but it's something that I think a lot of us are thinking about. Yeah, no, and Dr. Desai is pointing out, right, cell-free DNA isn't a perfect marker of tumor. I think some of us would argue that it's a marker of some of the more aggressive parts, that, if you see a mutation in the cell-free DNA, you're actually more likely, and I think Dr. Mose showed this, you're more likely to catch important mutations that may identify therapy in the cell-free DNA than potentially in the tumor. And I think Dr. Sokol was mentioning, right, tumor heterogeneity. Depending on where you stick that needle, you might get a different answer. Whereas cell-free DNA, we hope, might be a sort of a conglomeration of all the different cells that we can target. So, to be determined.
It's coming.
We have a question over there.
Hi, I'm Ben DeShetler. I'm from Atlanta, Georgia. This is kind of a little more specific of a question in regards to the mutations that you were talking about. You're talking about deletion mutations, and specific like ATRX. Are there any targeted therapies that have been effective either in children or adults that have been developed for deletion mutations?
So I think in certain types, yes. I think not all genetic mutations are easily targetable. It depends potentially what part of the gene is altered. It depends on what sort of the downstream implications of those genes are. Mm-hmm. So yes, I think the idea behind understanding a lot of the genetic alterations, the mutations, is to find specifically targeted therapies that impact those things.
Yeah, it was just a little confusing because if you have something that's missing, it just seems like that would be hard to target something that's not there.
Yeah, and some of it depends on how it impacts the proteins and things that gene encodes too.
Right. Yeah. Okay, thanks.
Okay. Any other questions? Are we done? Sure. Okay, go ahead. We have time.
Thank you. I was actually going to ask Dr. Applebaum, but since you mentioned it as well, I thought I'd ask, MYC amplification, you discussed it, and that affects 1 of 5 families in here. What is the discussion, or has there been newer discussion around using MYC amplification as a prognostic factor? And is there new data that suggests that they may fare better if they respond to treatment?
Sure. So I think of a little bit what you may be alluding to is I think there has been some published data to show that patients who have MYC amplified disease may respond more readily to induction therapy. And there's a paper published by Dr. Pinto that has shown some of this, and that although historically MYC amplification we associate with sort of making you in the high-risk category and more aggressive disease, that amongst patients with high-risk disease, it hasn't necessarily stratified within that cohort, and maybe predicts better response. I think there's a lot of work being done to understand the interplay between all of the various factors, and how does MYC amplification impact different groups? Does it matter, if you have MYC amplification and respond well, that may give you one sort of prognostic significance, but if you don't respond well and you have MYC amplification, that probably means something very different. And so I think while we know a lot about these factors individually, how they all come together is still something that's being worked on, and understanding the best way to combine all these factors.
Any other questions? Okay, we're done? Okay, thank you, Dr. Sokol. We're going to go ahead and, we're a little bit early, actually. We're going to go ahead and break for lunch next door. If your kids are in the kids' room, you can go ahead and bring them into lunch. And we'll be back here at 1:30. Thank you. Oh, and be careful with security. Make sure you have your name tags on, because security at the hotel will stop you. So.
I'll take it. Yeah, I'll take both of them.
like, hey, this is so cool. Everyone's gonna be awesome too. I guess I probably didn't like
My brother and I are a little spicy, you know, and
Oh, no, you're fine. You're fine.
It does take me for myself. No one else can sit here.
Okay, we're going to go ahead and get started. Our next speaker is Dr. Paul Sandel. Dr. Sandel received his bachelor's degree from University of Wisconsin-Madison, along with his PhD in the Department of Genetics. He received his MD at Harvard Medical School. He was a postdoctoral research fellow at Harvard and did his internship at the University of Minnesota Hospitals and his residency at the University of Wisconsin. He has a long career in the research community, focusing on immunology and neuroblastoma and other childhood cancers. He's been on numerous committees, including positions within the NCI. His talk today is entitled Immunotherapy for Neuroblastoma, How It Was Developed, What Its Impact, and What Its Future. Dr. Paul Sandel.
Thanks very much, Pat, and thanks very much to all of you. It's a privilege to be here to talk with you, parents and families of children with neuroblastoma. All of us are looking for hope, for better answers. In 2023, we're doing so much better than we were 10 or 20 or 30 years ago. But all of you here today know that we need more progress, and you're looking for better answers. And I can assure you that the cancer research community is working hard to try and do that, in part because of the incentive that you're all providing us, particularly your children. I want to thank Pat for inviting me. I've known Pat for decades now, and what she's doing with this organization is really remarkable. It's a real service to this community. So thanks, Pat. And this is one of the longest titles in the program today, and I want to thank Pat for that as well. She suggested that I try and cover all of this, so I'll do my best in the time that we've got. First, I want to point out a disclosure, and that is that I am not paid by any drug company. I don't have any financial disclosures of payment, but I am an unpaid advisor for a company in Madison that we've helped to develop an antibody together with, and that company is called Invenra, and they're providing some research support to my laboratory in addition to support we get from a variety of other funding agencies and grants. And I'll be mentioning today some of the work we're doing with that antibody that we're developing. So starting from the ground up, why immunotherapy? It's hard when you're talking about children with cancer to try and take how we're doing and put it in the form of hard, cold facts and statistics. But science needs to take the emotional field of childhood cancer and make it scientific, and look at how we're doing, and look at when we're doing better, and look at when we're not. And so this is a curve that shows the statistics of how children have done diagnosed with all of these different kinds of cancers. Each line is a different kind of childhood cancer. You can see that back in the 1940s and 50s, very few children with cancer were living very long at all. But particularly from 1970 through 1990, we saw through the work of collaborative cancer treatment organizations like the Children's Oncology Group and others, based on strong laboratory work testing multi-drugs together, we made a lot of progress in treating many kinds of childhood cancer, including some progress in neuroblastoma. This is success, but it's not the success we're looking for. We clearly want and need more. Too many children in 2023 still are not being cured. And our improvements using more chemotherapy with surgery and radiation therapy for many diseases seem to have plateaued. And giving higher doses of those drugs isn't getting us the benefit that we necessarily would like, given the toxicities associated with it. And even for those children that are being cured with today's therapies, many of them are undergoing short-term toxicities of nausea, vomiting, other issues, as well as long-term effects on their heart function, their growth, their neurologic and emotional function, as well as some children that are treated with all of these drugs are at slightly higher risk for developing second cancers early on in their adult life. We clearly have to do better. In order to do so, we think we need something in addition that's different. So most children while they can have remission from the drugs that they're getting, namely, you get them to the point where the cancer seems to have gone away. The sad thing is for too many of those children, there's still a microscopic amount of cancer that's left behind that you're not able to see with an X-ray or a clinical exam. But it's still there in small amounts, and because it's still there, it means it's probably resistant to the therapy the child's received already. So we want to try doing something separate in addition to or instead of that in order to try and get at that disease. And the approach that Pat asked me to talk about is one that I actually started studying back when I was a sophomore in college at the University of Wisconsin in 1969. I had the good fortune of starting to work in the laboratory of Dr. Fritz Bach, who was the pioneer who did the world's first successful bone marrow transplants, which ended up becoming a mainstay of treatment for childhood leukemia. And the way they work is the immune cells from the bone marrow attack the leukemia and keep the leukemia from coming back. It's called the graft versus leukemia effect. So the hope was maybe we could use that same sort of effect to have an effect on cancer. So everybody here knows what the immune system is. It protects you from bacterial infection and from viral infection. In the last century, the advances from vaccine immunology has wiped smallpox off the earth for the most part, has made polio a very different kind of thing to think about than it was back in the 1950s. But the immune system can do bad things as well. There are diseases where the immune system is starting to attack normal tissue, diseases like diabetes or multiple sclerosis or rheumatoid arthritis. But if the immune system is doing something that you don't want it to do, it's because it's attacking normal tissue, or for patients that might need a graft of an organ from someone else, like someone who needs a kidney transplant. Their immune system will reject every kidney that you transplant into them unless it's from an identical twin or unless you give them potent drugs to suppress their immune system. So the idea behind immunotherapy is, could that same immune system that can reject a kidney be turned against someone's own cancer? That's the idea. And there's been real progress. We got a long way to go. And I said, I've been working on this since 1969. So here's a picture that one of my patient's parents showed me a couple decades ago that they saw in National Geographic. They were reading an article on immunotherapy, and it's a great picture because what it's showing here are white blood cells sticking to and killing cancer cells. And you can do a lot of things to white blood cells, and there are a lot of different kinds of them, and we won't go into the specifics of which kinds, but those white blood cells can get activated and stick to the cancer and kill it. We can make this happen in a test tube. That's what we're looking at here. You can make it happen in mice, and we can make it happen in patients as well. But the real challenge is, what is it that the white blood cell has to see on the cancer to know that it's cancer, as opposed to know that it's not your normal tissue? Because the cancers that arise in a patient, unlike a foreign kidney transplant, those cancer cells came from their own cells. So they're self cells. And in order for the immune cells to see something different so that they can destroy the cancer, not the normal cells, that's the real challenge of the immunotherapy. So here's a graph showing how poorly patients with advanced melanoma were doing back about 15 years ago. These are patients, adults, that have advanced melanoma. It means that their disease has already metastasized at the time of diagnosis. And you can see when these patients were getting the best first or second line chemotherapy available for them, sadly, it looks like every patient is dying in roughly a year. This is terrible. Clearly, for melanoma, we need to do something better. So nothing was making a difference for those patients. So this is a disease where immunotherapy has made a big difference. So one of the main concepts in immunotherapy is there's a certain kind of an immune cell called a T cell. How many of you have ever heard of a T cell? All right, great. I didn't know what to expect. So if I'm doing this too remedial, wave your hands and I'll make it a bit more scientific. But T cells are able to see foreign cells because they have a molecule on the surface that the T cell can see as a target. It's called an antigen. So T cells can see melanoma cells because of a melanoma antigen, and that should turn this T cell on to kill that cancer cell. The trouble is the cancer cell doesn't want to be killed, and it expresses a separate molecule called PD-L1. That molecule interacts with a separate molecule on the T cell, and it turns the T cell off. It puts the brakes on the T cell. So even though this T cell has the machinery to be able to recognize and kill the melanoma, the tumor has figured out how to put the brakes on that and prevent that from happening. And so in order to stop that, if you put something in that gums up that brake, that blocks that brake, the PD-1 receptor on the T cell, so that it's not getting turned off by this signal, now this T cell can kill the melanoma cell, and it works clinically. And this is a separate clinical trial for adults with melanoma that are getting that kind of take-off-the-brakes therapy that some of you may have heard of. It's called checkpoint blockade, immune checkpoint blockade, like ipilimumab or nivolumab. And these are adult patients with melanoma. And what you're seeing here, this 0 means you measure how much melanoma the patient had at the time they were diagnosed. And you then measure from that time to what happens after you treat them with this checkpoint blockade. And if the tumor grows from baseline, you see growth here in percent. And if the tumor shrinks from baseline, you see it shrinking. And look at how 3/4 of the patients with melanoma have the cancer shrinking. Over half of them have the cancer shrinking more than 75%, and about 1/3 of them have the cancer going away entirely. So this is clearly game-changing, and it's all being done through the immune system. The drug doesn't do anything to the cancer. It only acts on the immune cells so the patient's own immune cells can recognize and destroy the cancer. So here's how different that survival curve looks. Compare this to the one I showed a few slides ago. These are melanoma patients that are getting this combination checkpoint blockade, and at least in some trials, it looks like 40% or more of those patients are having the melanoma go away and not come back. It's a game changer. And based on that, the people who really devised this therapy in the laboratory, Drs. Allison and Hanjo, won the Nobel Prize in 2018 because between 2010 and 2018, it was clear that this approach was making a huge difference for at least some patients with cancer. How does it work in kids? Not well at all. Here's the sad truth. This is a paper that was published by colleagues of many of us that are here today. 55 children with advanced pediatric solid tumors were treated with the same drugs that I just showed you doing so well to treat patients with melanoma. And of those 55 children, none of them had the cancer go away. Only 2 of them had the cancer shrink. All the rest of them had the cancer grow or not shrink at all. So this is so incredibly different from what we see with melanoma. Why? What's so different about childhood cancer? So this is a complicated slide, and I apologize for the complexity. But I want to explain it because it's important. What you see along the bottom here are the names of a variety of different kinds of cancers. This is melanoma. These with the red boxes are the childhood cancers. Above each box where the disease is, you see this line of dots. Each dot is a patient. And what you're looking at is the number of mutations that that patient has in their cancer. Liz talked in the last talk about how mutations are important in cancer. We want to understand the genetics. So this is telling you how many mutations there are in melanoma. This is on a logarithmic scale, so each one of these ticks goes up by 10-fold. So what this is in essence telling us is that melanoma patients have 10 to 100 more fold mutations, 10 to 100 times more mutations than children with cancer. It's because what drives children's cancer to be cancer is different than what makes adult cancers be cancer. And there's many fewer mutations in the childhood cancers, and it's those mutations that let the cancer put something on their surface, the antigens that the T cells can see. So if you don't have very many mutations, you're not going to have antigens that T cells can see, and that's why checkpoint blockade doesn't work. So we need something different. So if there aren't enough antigens and your own immune system isn't going to see something that it can recognize and destroy, what options do we have? And we've got some good options. One is what we call synthetic immunology. What I mean by synthetic is it's not something your body's own immune system is making on its own, but it's something that you have to make in the laboratory with intention. So back in the 1970s and 80s, the first work on this was done taking human cancers, immunizing mice with it, purifying the immune cells from the mice that made the antibodies, growing those up in bioreactors and making something called monoclonal antibodies. How many of you heard of monoclonal antibodies? Okay, so that's the history of monoclonal antibodies. You can make thousands of monoclonal antibodies and then screen them, and looking for a needle in a haystack, find one that might bind to a cancer cell but doesn't bind very well to nerve cells or to other normal cells. And that's how the anti-GD2 antibody was identified, and we can use those kind of antibodies to help make an effect against the cancer. And here's how they work. This is a picture of a cancer cell, and it's got molecules on it that can be seen by an antibody. And if you make an antibody that can see those molecules, antibody will stick to the cancer. That's good, but nothing happens. The antibody just sits there on the cancer cell still lives. In order for the cancer cell to die, you need white blood cells that have these orange things sticking off of them. Those are receptors that let the white blood cell see the antibody, stick to the cancer cell, get really tight and cozy with that cancer cell, and then pour into it molecules that the white blood cells use to destroy tissue and kill the cancer cell. That's called antibody-dependent cell-mediated killing. And that's how virtually all antibodies that act against cancer cells work. Here's a picture of it working. This is from our laboratory. What you see in this picture are all of those cells that look gray. Those are actually white blood cells sitting in a test tube, and that red thing is a spheroid of neuroblastoma cells that is sitting with the white blood cells that aren't doing anything because we didn't put an anti-tumor antibody in. Here's the same thing over on this side, where the same size tumor nodule was put into the white blood cells, but we added the anti-GD2 antibody to it, and you can see the cancer is completely going away because the white blood cells are killing it. So I skipped the slide, but it's just a picture of high-risk neuroblastoma. Let me try backing up. Do I push the bottom button to back up? Works, thanks. Okay, so my anticipation is that many of the families that are here because you've got a family member that has high-risk neuroblastoma. And that high-risk neuroblastoma is the disease that, at least up until 2009, immunotherapy wasn't proven to make a difference, and we were helping many children, but not nearly enough. We've got to do better. And so in order to do better, we've taken what was the standard regimen for neuroblastoma that you're familiar with, many months of multi-agent chemotherapy together with surgery and stem cell harvest, followed by an autologous bone marrow transplant or two, followed by some maintenance therapy using an agent called cis-retinoic acid. And this very complex regimen was being used, and it was getting the kind of results you saw on the last slide. But the next step was to take this anti-GD2 antibody that was identified by the processes I showed a couple slides ago, and a number of researchers around the world were involved in testing and developing anti-GD2 antibodies and determining how to test them and what to give them within patients, and we were working on this in our lab as well. And based on this work, the Children's Oncology Group tested this anti-GD2 antibody we now know as dinutuximab in a randomized trial. Children were given their induction therapy, then they were given their autologous transplant, and if they were in remission, then they were randomized to either get the immunotherapy with the GD2 antibody or not. And you could see that there's a clear difference. The patients that got the immunotherapy had a much greater chance that our statisticians told us was real of staying without any disease as long as they got the antibody. Well, that was good, but too many patients didn't even qualify for this because they weren't in remission. And even those that were in remission and got this therapy, 40% or more of them are still having their disease come back. So here again, we need to do better than this. And what's the next step? So this was our next step as far as the standard of care for neuroblastoma therapy, including the anti-GD2 antibody in this remission maintenance phase. But the next was to take patients that had already relapsed. And at the time that this was done, a COG study led by Raj and Modi, 2 drugs were being contemplated as helpful for neuroblastoma, chemotherapy called irinotecan and one called temozolomide. And so COG did a randomized trial giving patients with relapsed neuroblastoma those 2 drugs, either together with a third chemotherapy called temsirolimus or with the anti-GD2 antibody. And here's the curve. And even though the number of patients put in this was small, you don't need a statistician to tell you that the ones that got the antibody were doing much, much better than the ones that got the third drug instead. For those patients that got the third drug, only 1 out of 18 patients had a transient shrinkage of the cancer. While for the ones that got the antibody, 8 out of 17 had either a partial or a complete shrinkage of their cancer. And this shows that they were maintaining a pretty long event-free survival, and some of these patients have not had their neuroblastoma come back. Well, that was pretty exciting, and based on that concept where the drug was working together with chemotherapy, St. Jude asked, might it make sense to not only give this antibody when the patient's in maintenance after getting the bone marrow transplant, but what if the antibody was used in the beginning together with the chemotherapy, since that seems to help if you give it to patients in remission. So this was a study done at St. Jude, co-led by Sarah Federico, who you heard from this morning, together with Wayne Furman, and the results were really very exciting for the neuroblastoma community. This shows that if you start this anti-GD2 antibody, it's a slightly different antibody called this, and you look at those patients that are alive without any cancer coming back, that's what's being shown in blue, they're doing really well, and this is starting at the very day of diagnosis. Unlike the COG trial that I showed you before that had the drug started. The drug shown here was started only after they'd gone through the induction and the bone marrow transplant. So this St. Jude data is really very exciting, and we're now in the process through the COG asking this question to all COG neuroblastoma patients in a randomized trial, and this is being led in part by Sarah Federico, and she probably went through this earlier this morning. Sorry I didn't get here for it. So in all of these trials that I've talked with you about where the anti-GD2 antibody is making a difference, our laboratory got blood samples from the patients and looked at how much of the antibody was actually circulating in the blood of the patients. And what this graph shows, this shows those patients that had their cancer shrink early in the St. Jude trial after 2 courses. And these are those patients that still ended up doing well, but their cancer wasn't shrinking after the first 2 courses. And each dot is a different patient, and what we're showing is how much of the antibody was in their blood. And even though we gave the same amount of antibody to each patient based on their size, some patients have more antibody circulating than others for reasons that we're not completely sure of, but this says that those patients with more antibody are doing better. So based on that, we've looked at other trials and seen the same thing, and these other trials suggest if we could give more of this antibody, maybe we could get the patients to do even better than what we've got going on now. And one of the best ways to get the antibody level up higher would be to give more antibody. But we don't give very much of this antibody. The amount of this anti-GD2 antibody that we give to neuroblastoma patients is this much. It's 17.5 milligrams per meter squared. That's how we measure it. It works through that antibody-dependent killing process. These are 2 other antibodies you may have heard of that are used to treat lymphomas, or antibody that's used to treat adult head and neck cancers and certain other cancers. They work by the same process, that antibody-dependent cell killing. The doses that we use of those 2 antibodies are 20 times higher than the dose that we use of anti-GD2 antibody. Why? If more drugs should make the antibody work better. And the reason is that we know the anti-GD2 antibody causes this neuropathic pain. It causes pain in children that get it, and I know that many of you have had this experience, and I've had many parents let me know that through the whole course of their child's neuroblastoma therapy, for at least some of those families, the most difficult thing for them was to be watching their child get the GD2 antibody because of the pain associated with it. So why is it that they've got the pain? And the reason is this anti-GD2 antibody has the good anti-tumor effects it does because this antibody sees these red dots, which are the GD2 molecule that's expressed on virtually all neuroblastoma. The trouble is nerve cells have some GD2 on it. Much less, but they still have it. And because of that, This antibody can kill the neuroblastoma, but it sticks to the nerve cells, it irritates them, and in some cases it even kills some of those nerve cells. So we want to try and do something better. And where we're going is an approach to try and decrease that pain that's associated with the anti-GD2 antibody. We want to try and make it more tolerable, be able to give it as an outpatient, and maybe even increase the dose of the antibody that we can give. So Amy Irby in our laboratory has taken an anti-GD2 antibody working with this company Invenra and made it a bispecific antibody. So one end of the antibody needs to see the GD2, and the other end needs to see a separate marker that's on the tumor but not on the nerve. It's called B7H3. So the way this should work is that this antibody will only bind if it sees both things on the same cell. So it should bind to the neuroblastoma and let the cells kill it through that antibody process. But this antibody won't bind to the nerve because it only sees GD2. It doesn't see that other marker. So based on that, we've shown when we test it in the laboratory, this is a complex slide I apologize for, but in essence what we're showing is, just like I showed you with the tumors we were measuring, here we're looking at whether the tumors in the test tube are being killed or not. And if they're being killed, the numbers go down. So here's what happens if we use dinutuximab, and here's what happens if we use the sniper antibody that needs to see both the GD2 and the B7H3. Kills the tumor cells just exactly as well. Next is, how specific is it for cancer? So what we did was take a mouse and put 4 different cancers into it. The one I want you to focus on are the 2 cancers down here. The cancer on the left flank has this GD2 molecule on it that's on neuroblastoma but also on nerves. The one on the right flank has both the GD2 and the B7H3, so it looks just like neuroblastoma but doesn't look like nerves. So we take those tumors, we put them into mice, and then we take the antibody and we put a radioactive molecule on it so that we can look at how well it goes to these tumors in the mice. And what you can see here is when we put the radioactive target tagging onto a control antibody that doesn't bind to any tumor, it shows very low background level on all 4 of these tumors. When we put the radioactive marker on the dinutuximab, it binds to the right and left flank equally well. So this would be neuroblastoma and this would be nerve. But the sniper that needs to see both molecules at the same time only binds to the tumor on the right. It doesn't bind to the tumor on the left. So it looks like it's pretty specific. When we test this as far as how well it helps mice to respond to the immunotherapy, we can take 2 separate kinds of cancers that express the GD2 and the B7H3 in mice, this neuroblastoma or this melanoma. These are mouse tumors, and when we look at how many mice are tumor-free in black after the treatment, we've cured same number of mice with the sniper as with dinutuximab in both of these models. We can then take human tumors and put them into mice that can't reject them, and if we treat them with this sniper molecule, we're also able to get these mice to be tumor-free to the same level as we do with dinutuximab. We then asked a question about pain. It's hard to measure pain in a mouse. It's hard for the mouse to tell you when they're having pain. To save time, I'll just say that mice that are feeling good, if you put them in a cage that has some of their wood shavings beddings in a tunnel, they'll go into the tunnel and they'll want to clean it out and they'll kick all the bedding out. And if the mouse isn't feeling very well, the mouse isn't going to kick most of that bedding out. And so when we do this experiment in a very controlled way and we treat the mouse with either no treatment or an antibody that doesn't bother nerves, like rituximab, they kick out all the bedding. When we treat them with the sniper antibody, they kick out all the bedding. But when we treat them with dinutuximab, they kick out only a fraction of the bedding. So it's clear that the dinutuximab is causing pain that we don't detect when we use the sniper. So here's really the reason why. When we actually look at how these antibodies bind to human neuroblastoma, we take the 2 separate antibodies, the dinutuximab or the sniper, we put them onto the tumor, and then we put a red dye onto the antibody at the exact same concentrations so the conditions are the same. And you can see that the dinutuximab and the sniper bind with pretty equal intensity to the tumor. When we now do the same thing on nerve cells, and I hope you can see the difference, but these are human nerve cells that are binding brightly when you treat them with dinutuximab. And here's how you don't see anything on the exact same nerves when we use a sniper antibody, which is why this antibody shouldn't cause pain, because it's got to get to the nerve in order to cause the pain. So the conclusion from this is that we've got an antibody that seems to be about as effective as dinutuximab. We think it shouldn't cause neuropathic pain. We think we may be able to get higher dosing, and if we can do that, maybe we can even get better efficacy. And our next steps are to do what we need in order to start putting this into the first-in-human clinical testing. We still have some steps to go, but I think we've done all of the lab work that we need to do, and we're excited to be proceeding. So this is where antibody therapy is going. I want to finish with just a couple other slides on other aspects of immunotherapy. So our current and future immunotherapy for relapse disease at this point involves combining the chemotherapy with the anti-GD2 antibody. But there's some other agents that are being used that might help this work better. There's a separate antibody that helps a certain kind of cell called macrophages to stick to the tumor cell and not get turned off. It's kind of like checkpoint blockade that I showed earlier on, but it works on macrophages. There's another drug called anti-CD40 that's being used to help patients with pancreatic cancer and is actually very far along in showing benefits for those patients. Hasn't been approved yet as standard by the FDA, but it's getting there. We're testing that drug that activates macrophages in our mice with cancer, and we're showing that it looks like it's improving the anti-tumor effect when we add it to the chemotherapy with the anti-GD2. This would be something that could go into clinical trials fairly soon. It's an idea that hasn't been tested in patients yet, but we're not far from there. In addition, these approaches may work if we use checkpoint blockade, because the checkpoint blockade might help those cells that make that antibody-dependent killing work better by keeping the natural killer cells from getting turned off. So it keeps the brakes from getting turned off on the natural killer cells. There's a trial available now called the Minivan trial. It's combining that kind of approach together with radiation in the form of MIBG. And MIBG is being combined with vorinostat by NANT. All of these approaches are showing what we think looks like worthwhile future work. And then finally is the concept of CAR T cells. And there's a number of different kinds of CAR T cells that are showing promise for neuroblastoma. And I'll just briefly mention CAR T cells, but Andreas Huxy is going to give the next talk and really focus on this. So the whole idea is you create synthetic immunology this way by creating a receptor in your immune cell that lets that immune cell see a cancer cell it wouldn't ever see on its own, by genetically engineering a receptor that lets it see something on the cancer cell. And if you do that right, that can make a real difference for childhood leukemia. It's a standard of care there. And at least in the setting of neuroblastoma, several trials over the past decade have shown borderline benefit. It wasn't as clear. A very recent study coming out of Italy, of Rome, just this spring, seemed to show a pretty significant impact, that for children with relapsed or refractory neuroblastoma treated there, 63% of them showed at least some shrinkage or partial shrinkage, and 36% of those patients were alive without the cancer coming back at 3 years. So this needs to be reproduced at other centers, but it's exciting, and I think we're going to hear more about this idea with the next talk. So I will stop there. I just want to mention briefly, there's a whole lot of people working in our laboratory, in our cancer center. We're collaborating with many people from COG, from our pediatric cancer dream team, from St. Jude, other people we're working with for this, and we're very fortunate to have grant support from a variety of sources to allow us to proceed with both this laboratory and clinical research.
Thank you, Dr. Sandel. Any questions? Yeah, go ahead.
Great.
She can get out.
Hi,
Hello.
Kim.
Hi, Kim.
A couple of questions. I don't even know if some of them might make sense. Can immunotherapy be used as a maintenance treatment?
That's how it's being used now.
But I
through the
mean
COG.
long term.
The answer is yes, it could be, but is it worth it? There are toxicities associated with the immunotherapy, and if you already think that the treatment has gotten rid of all of the cancer, then to continue going on with more therapy is just causing toxicity. The problem, of course, is we don't yet have as sensitive a way of knowing, is this patient that's in remission and doing well, are they still harboring any cancer that's left that's really at a small level where we should be giving them some more therapy and maintenance, versus can we prove that they're really done and we can stop that?
Okay.
So it's a question of being able to measure that right. If we had maintenance therapy that was less toxic than our current anti-GD2, maybe the new anti-GD2 B783 antibody that hopefully will be less toxic, maybe we could use that longer without the toxicity, or if we had some other agent that wasn't toxic, we'd be more willing to keep going. But we don't want to use something that we think might be accumulating toxicity if we're not sure the patient needs it.
And I guess that's one of my other questions, are the long-term effects and the toxicity of extended use of immunotherapy?
We don't really know because we haven't extended this therapy for a really long period of time. But I would imagine if there is some neuropathic toxicity associated with it, if we gave it longer, we probably would see more of it. We learned back in the 1970s that maintenance chemotherapy that was being given to children with leukemia that were in remission, they were getting maintenance chemotherapy for 10 years. But it was clear that the therapy was worse than the disease for some of those, and once the therapy was stopped, it was clear that most of those children were cured already and didn't need the maintenance.
Didn't need that, okay. One more question. When do you think there might be a trial that mimics the adult nutrition trials, like the fiber response to immunotherapy like they did with the adult melanoma patients?
Can you tell me a little bit more about the trial you're
I don't know if I could
speaking of?
explain it. I don't know if anyone else has heard of it. It's a fiber, it's a fiber response trial that they used with some patients with melanoma, and how the fiber kind of enhanced or helped with those patients.
So it's an interesting concept that we're learning based on really strong immunologic basic science, that the way your immune system works is influenced by the bacteria that you have in your gut, the microbiome. And I would imagine that the people doing that trial, although I can't say for sure, might be doing that because they think that they're somehow influencing the immune response because of an influence on the microbiome. There's a number of trials going on trying to intentionally manipulate the microbiome. And in diseases like melanoma, where we know it's clearly T cells that are having an immune effect, and it's the patient's own T cells that are turned on and ready to go, then if you could do something to help those T cells be more potent, maybe by manipulating the microbiome in the right way, you'd get some benefit. And I suspect that what you're referring to is something along those lines. At this point, we're not as far in our pediatric immunotherapy to be able to say that the microbiome is having an effect, in part because most of the pediatric immunotherapy is that synthetic kind of response we're talking about, where we're doing something in the lab to help the patient's own immune cells do something they couldn't do on their own.
Okay. Thank you.
Any other questions? Okay, go ahead, one more.
Hi, I'm Shay from Utah. So I just had a question with like the B7H3. In one of your slides up here, it says it's overexpressed on most pediatric tumors. So, obviously, it's got the pros of, not having, being expressed on nerve cells. So, cutting down on that pain level. I think all of us in here that have had a child have dinutuximab, naxitamab, would sing all the praises to not have to deal with the pain that our kids go through. Sorry, oh my gosh. But with that, where it's found on most pediatric tumors, is there some way to test for that? Rather than just saying, we're gonna give this whole gamut of children B7H3, but maybe only 30% of them actually have that overexpression on their neuroblastoma cells. So only, of those 30%, how effective is it going to be on even on that 30% where the other 70%, it didn't even have any effect because they don't have that overexpression. So going into a therapy in that regard, is there a way to determine that before we even get that far?
I guess.
Exactly. It's a great question. So we've actually done that. We've just completed a trial of a separate B7H3 antibody. This is a trial that was conducted by the Pediatric Cancer Dream Team, a collaborative group that's shown on the upper right of the slide. The study's not been published yet, but we looked at a large number of patients with pediatric tumors, and virtually every child with a pediatric solid tumor had B7H3 detectable on their tumor if we had a good immunochemistry slide that we could look at. And I don't want to be specific because I'm not sure I remember the exact number, but it was on the order of 85 to 90% of the cancer cells in those patients or more had B7H3 on them. So it wasn't a tiny fraction of patients who were B7H3 positive, and for those patients that are B7H3 positive, the B7H3 is widely expressed on their cancer cells. But what you're saying is something that we do want to build into the trials, and that is if we can test a patient before we're going to use a therapy that might have toxicity and prove that their cancer cells have the marker that the therapy we're proposing is going to be useful for, we want to do that. And so for B7H3, the test is pretty easy to do. For GD2, the test is a little tougher, but one of the speakers that you'll be hearing from tomorrow, Pat Reynolds from Texas, has developed an assay to do this for GD2 expression that we're trying to build into prospectively upcoming clinical trials.
Okay, thank you so much.
Yeah.
Any other questions? No?
Thanks.
Okay, thank you, Dr. Sandel. I'm going to stay down here again. My feet hurt. Our next speaker is Dr. Andres Huxy. He is an associate professor at Baylor College of Medicine in Texas Children's Hospital in Houston. He did his undergraduate studies in Budapest, Hungary, and also doing part of his residency there in infectious diseases. He also completed his residency and internship at Children's Hospital Los Angeles and his fellowship at Texas Children's Hospital. He has received numerous awards for his research and has lectured at various hospitals, institutions, and conferences across the country, including here at the CNCF conference several times. He has authored and co-authored so many publications with national and international collaborators, and his presentation today is on CAR T cells for children with neuroblastoma. Dr. Huxy.
Thank you. Thank you for the kind introduction, and I'm really honored to be here. It's really wonderful to get back. Unfortunately, I couldn't join last year. It's great to see some of those of you who I've met in the past couple of years and meet new families. And just wonderful job, Pat. It's great to have us all together. So, as Pat mentioned, my task would be to review some of the work that's been done in CAR T cells. And obviously the field is really going through an exciting period of growth. So I try to pay attention to some of the nuances and introduce you some of the complexities that come with these CAR T cell therapies, just to give you some ideas that, well, even if the same target is looked for in a certain trial, the cells can be engineered differently. The receptor itself can be engineered differently. So all those complexities can potentially change the efficacy of the product. And that being said, I have some patents related to the technology that are employed, and I was the PI of the GINA-K2 study that I will talk about today, but I will do my best to objectively present all the data. So as Dr. Sandel already alluded to, when we say immunotherapy, it's actually a really, really broad basket term of any therapy that uses the body's immune system to target cancer cells. So for a number of years, we've known that the immune system, in addition to just being able to fight infections, it can actually target cancer cells. And there are some experimental results in animals that show that in any given day, there are cancer cells formed in our bodies, but the immune system is able to eliminate them. Unfortunately, that doesn't always work. And in that case, the cancer cells, grow and you find someone with, for example, neuroblastoma. But now we have a number of strategies to redirect the immune system to go after these cancer cells and in the ideal situation to kill those cancer cells. You've heard a lot about the antibody therapy that's been really pioneering this field in children with neuroblastoma and many other cancers. So I won't go into it, but there are other versions of antibody therapies where you can conjugate, for example, a toxic molecule to these antibodies, which when those are picked up by cancer cells, then the cancer can be killed. There are immune checkpoint molecules as well that will not directly target cancer cells, but will kind of take up the brake from the immune cells and have the immune cells attack the cancer cells better. These therapies don't always work for every cancer type, and as Dr. Sandel mentioned, for example, for melanoma, immune checkpoint blockade is a breakthrough therapy, but for neuroblastoma, at least up until now, it hasn't really been showing that level of efficacy. BiTEs are bispecific T-cell engagers, again, kind of connecting T cells, which are a special white blood cells, to the cancer cells and have these T cells kill the cancer cells. Many of you are familiar with vaccines for infectious diseases, but now there are vaccines that will redirect the immune cells to cancers. And my talk is going to be focused on adoptive cell therapy, which, there are different types. Even in the subset of immunotherapies, there are different versions. And from the type of adoptive cell therapies that I'll be talking about is with chimeric antigen receptors, or CARs, and we'll get to it in just a second what that means. So how does adoptive cell therapy work? In the current form, we use blood cells to generate cancer-redirected, cancer-specific, kind of fighters. And the blood cells, here are the blood and blood-derived cells that we all have. Macrophages are kind of derived from blood monocytes. But what I want to point out is this subset of cells. You have your red cells, your granulocytes, various subset of granulocytes, and you have monocytes and lymphocytes. And lymphocytes are the ones that fight infection and as well as able to fight cancer cells as well. There are different types of lymphocytes, and my talk is going to be focused mostly on T cells and to some degree NKT cells. But what I want you to remember is that, out of the number of white blood cell types that we all have in our blood, there is only a small subset of white blood cells that can be used, at least to our best understanding, for genetic engineering to target cancer cells. And the most commonly used type is lymphocyte, T lymphocytes. So how does this work? Well, in the current setting, what happens is that the patient who is diagnosed with cancer goes under some sort of a collection procedure. Sometimes they have to go through a similar procedure when they get stem cells collected, leukapheresis, where a large number of white blood cells are collected. Sometimes it can be done just from a relatively larger volume peripheral blood draw. But what happens is that if ultimately these cells make it to a GMP facility, a manufacturing facility that specializes in growing cells and genetically engineering these cells outside of the human body. This is tightly regulated and controlled, so there are just a number of centers still in the US that can do this. And then once the product is manufactured, after genetic engineering and additional growth outside of the body, in most cases it's frozen, tested, and then later infused back to the patients. This causes some delay. So in most of the cases, this is about a month from the time a patient comes to a center and is donating the blood to the time of the infusion. And obviously during that time, if someone has actively growing cancer, something needs to be done. So most of these patients will receive some bridge therapy until the products are ready. Okay, so chimeric antigen receptors, and these are kind of fusion protein. These are very interesting molecules that are able to redirect these T lymphocytes, these white blood cells, to recognize and then actually kill the cancer cells. What I want to point out here, I don't know if this pointer is working. Oh, there you go. That this chimeric antigen receptor that you see here is actually derived from two molecules. This is an antibody, kind of schematic of an antibody, that you guys are all familiar with from dinutuximab. What's important is that every antibody has an antigen binding site, so an area where that antibody can recognize a target molecule, in our case, on a target molecule in the cancer cell. And you can take that piece, this binder site, and actually fuse it to other molecules. And here I'm showing the T-cell receptor complex. So this is a molecule that's responsible for the T-cells to be activated under normal circumstances. But obviously, this receptor doesn't recognize cancer cells. So how can you overcome this barrier? And what people have recognized a number of years ago, that you can actually fuse this cancer-specific binding part of an antibody to the signaling molecule, the signaling part of this huge complex. And this resulted in the first generation of chimeric antigen receptors. So, and they are expressed on the T cells, just like a normal molecule would be. They are crossing the cell membrane. And in the ideal world, this will bind the cancer cell, and this part of the molecule will then trigger the killing machinery, at least of the T cells. Well, now we know that these first generation chimeric antigen receptors are just not enough. You need additional molecules, additional signals to enhance the ability of these CAR T cells to kill, and very importantly, for them to actually survive and expand. Keep in mind that we gave a large number of CAR T cells to patients, but that in the context of a constantly growing tumor, it is a small army, and you want to grow that army inside a patient as much as possible and as long as it's safe. And so with the second and third generation receptors, that became possible. And so these are just molecules here, CD28 and 41BB. Those are parts of these molecules that were added to first generation receptors that make these second and third generation receptors more potent. Whether there's a difference between second and third generation as far as potency, that's still debated, but there is clear evidence now, both in patients and in preclinical models, that the inclusion of any of these molecules in second and third generation receptors is much better than in first. Okay, so this is just a schematic that once you made these receptors that can recognize the cancer cells, after genetic engineering, which usually done to this day by viruses, many times these viruses are actually derived from HIV. These genes are going to be inserted into the lymphocytes, and they actually persist there. So once you engineer a lymphocyte, that gene should be there and would encode the chimeric antigen receptor that then gets shuffled and stays on the cell surface of the T cell. Once that's there, then the T cell can go and find the cancer cells and can recognize these molecules that very often is B7H3 or GD2 or L1CAM. And once it recognizes those molecules, it can kill the cancer cells. But as I mentioned, an important aspect is it's not just killing the cancer cells, but then that these receptors then provide additional signal for the CAR T cells to expand and proliferate, so they can continue to kill large number of tumor cells. So do these actually work, you might ask? And we now know very clearly that they work really well in certain hematologic, certain blood cancers. And this was just a number of manuscripts that came out in very high impact scientific journals 10, 15 years ago, showing their incredible efficacy in B-cell leukemias and lymphomas. So that led to the FDA to approve now 6 products all of them with unpronounceable names. I'm not sure why this happened, but good luck pronouncing them and remembering them. Maybe the brand names are easier. But as you can see, so 4 of them are targeting CD19. Again, this is expressed in a certain type of blood cancers, and BCMA, 2 of them, which is also on a certain type of blood cancers. And here are the diseases that they are targeting. So the big question is, okay, this does work really well, and some of these studies showed up to 90% complete response after a single infusion, and about 50% sustained complete remission at 2 to 3 years out for relapsed refractory leukemia patients. So really remarkable. But can they actually work for solid tumors? And obviously for this audience, can they actually work for neuroblastoma, or against neuroblastoma, I should say? So there have been a number of phase 1 clinical studies conducted around the world, mostly in Europe and the US, and they are very different. So I want to point out that it's very hard to compare results study to study because the patient population they enroll tend to be very different. But nevertheless, they still provide a lot of insight on how they work. And here I just wanted to put up a real schematic of what the genes are that are being put into these cells. And you might think, oh, this is too complicated, but actually not. So here, if you look at this segment, just tells your cell to start reading and start expressing the gene from here. Then you express this thing. This just makes that the expression of the gene lasts longer. And then again, for the second gene, the readings start from here. You express it, you make sure that it lasts long. And then those 2 molecules, HYTK, and then the chimeric antigen receptor, here with the clone name for the antibody that binds L1-CAM, is expressed. This first phase 1 study was conducted by the Seattle Children's Group and was looking at CD8 positive, so a subset of a white blood cell, T cells that were expressing an L1-CAM specific chimeric antigen receptor and a suicide gene in case just for toxicities. Have you guys heard of L1-CAM as a target antigen for neuroblastoma? Yeah, so it was quite an exciting target about 20 years ago, and I think maybe there's still something to this target, but this study didn't really show good efficacy. And part of it, as I mentioned, was that expansion was limited. So here they treated 6 patients, and from all of these graphs, what you want to point out, what you want to look at is that all these bars show the number of how well these cells are detected in the blood. But as you see the later time points, they all disappear. And this was a first-generation chimeric antigen receptor. So we certainly learned a lot from this study that although outside of patients in the Petri dish and in animal models, this thing works. In patients, it didn't really show any exciting efficacy. So with that, a lot of focus went on to try to improve the efficacy. And so at Baylor, a group before my time at Baylor conducted another study with a first-generation CAR, this one actually targeting GD2 and using the binder from the dinutuximab antibody. But in this case, they made 2 products. One was in just regular activated T cells, and the other one was in virus-specific T cells. Those T cells, in addition to expressing the receptor, were also specific for Epstein-Barr virus. Probably 95% of us in the room have been infected by Epstein-Barr virus. We all have this virus integrated in some of our cells. And what happens is that these T cells that now express the chimeric antigen receptor get help from the existing viral infection in our body to persist and survive. At least that was the hypothesis. And they infused 11 patients initially, and then a couple more patients later as part of the Nestlis 1 and Nestlis 2 study. When you look at, there were actually some exciting anti-tumor activities. Some of the patients did not have evidence of disease when they came on. They stayed without evidence of disease. Some had, But even some of those who had pretty good amount of disease did have some partial responses. And one of the patients who had a relatively large Calvarian lesion is still alive and doing well. So this suggested that indeed, maybe expansion and persistence is really important. And when you compare the expansion and persistence of CAR T cells, just the ones that are regular T cells, versus the ones that are virus-specific, here marked as CTL, in the same patients, 2 products were infused, and the CTLs were much better persisting longer term. So that led to a number of newer studies, all of them focused on improving the expansion and persistence. And this was a study that I led a number of years ago, but I'll do my best to show you the data reasonably well, where in this case, 3 cohorts were tested. The first cohort was just the cells. You know, the patients came in, 4 patients were infused, and then the safety and efficacy was measured. The next cohort had now lymphodepletion, because there was emerging evidence that lymphodepleting chemotherapy prior to cell therapy actually improves the cell's efficacy. Lymphodepleting chemotherapy is similar to what patients get to target the cancer cells, but in this case, the goal is not to target cancer, rather to eliminate the other white blood cell, other lymphocytes in the patient's body, for lack of a better term, to kind of give room for the infused cells to grow better. And then the third cohort also had the addition of checkpoint inhibitors, pembrolizumab, added after lymphodepletion, and then 3 weeks after the cell infusion, which is marked here as green. So in this case, there is pretty strong evidence that once lymphodepletion was implemented, demonstrated here as the purple group, the expansion and persistence of the CAR T cells was better. And that also corresponded with interleukin-15 concentration in the blood, which is one of the mechanisms how lymphodepletion actually enhances the expansion and persistence of these cells. Nevertheless, unfortunately, the efficacy was still modest. There were patients with growing tumors who got stable disease, but many of the patients progressed through the therapy, unfortunately. So more recently, a British group evaluated a different chimeric antigen receptor. This one was targeting GD2, however, not with the same binder. In this case, they used a different antibody that was fully humanized. One thing is that they used a large spacer. So that is, as I mentioned, there are different components of this receptor, and every component can be changed, and those changes actually do alter the functionality of the receptor. So here the spacer region was actually much larger than, for example, in the trial that I previously shown. And here the costimulatory molecule was CD28. And in addition, they also include a suicide gene just for toxicities. That being said, after a careful dose escalation scheme, when they first gave just the cells, then just cyclophosphamide, then fludarabine, these are the drugs for lymphodepletion. And after that, they started to dose escalate all the way up to 10 to the 9th cell per meter square. They did show some better expansion and persistence in the higher dose levels. And they were able to show some objective responses. Here's a planar imaging of MIBG scan, where, for example, if you look at the vertebrae, there is certainly a decrease in MIBG avidity. But unfortunately, there weren't any durable objective responses in this study. So, okay, now the persistence can be improved, but the efficacy is still not there where we wanted. And I think one of the exciting results came just recently from an Italian group that used a 3rd-generation chimeric antigen receptor targeting GD2. The binder is from the dinutuximab antibody. It actually has a short spacer. It has both the CD28 and 4-1BB costimulatory domain. And it is by far the largest chimeric antigen receptor T cell study to date. And in this case, 3 patients were infused on the first dose level, 3 additional ones on the second dose level, and then 21 on the highest dose level. Here the dosing is kilogram base. So this would be roughly 3 times 10 to the 8 CAR T cells per meter square. And then they did show quite good long-term persistence. So the peak was reasonably good, but then you can detect the cells all the way out close to 2 to 3 years now at a reasonable level. It is not as high as in the leukemia patients, but they are detectable. And what was interesting is that they certainly showed some promising results. This is a swimmer's plot, and let me just walk you through. So on the top level, you see that the color scheme is corresponding to the response itself. So orange is the one that you want to look at that's corresponding to complete response. Purple is partial, stable disease is blue. And you see a number of complete responses there, which is certainly encouraging. I want to highlight, though, that some of these patients came in without evidence of MIBG-avid disease. So it is difficult to know, whether those patients really had active disease or not. And same thing, some of the patients did have MIBG-avid disease, but after therapy, they had partial response that was durable, in this patient's case, up to 3 years, which, we are not sure whether these patients received additional therapies. It was not mentioned in the manuscript, or whether this was already MIBG-avid, but more of a mature kind of ganglioneural disease. Nevertheless, this is really promising because there are some encouraging responses, even in patients that have MIBG-avid active disease. And this is just one example that they included in the manuscript. Here you see this massive tumor that's MIBG-avid that shrinks nicely after infusion. So certainly there is some movement in the field, and I just wanted to quickly show one of the studies that our group runs. In this case now, as opposed to T cells, natural killer T cells are tested. The reason for this is because these NKT cells can effectively infiltrate neuroblastomas and target cancer-supporting tumor-associated macrophages. So another white blood cell type in the tumor that we know is actually bad for the patients. It helps the tumor to grow. And in this case, it's a second-generation receptor that's used. The binder is from the GD2 antibody. And in addition, these cells produce IL-15. As I mentioned, IL-15 is one of the mechanisms how lymphodepletion helps the cells to grow. So in this case, the cells actually produce some of it. Well, we haven't talked about toxicities on the context of CAR T cell therapies, but in general, up until now, the safety of these therapies have actually been really encouraging. And I just wanted to show the safety table for one study because many of the others have basically comparable results. And what you can see is here that the grade 3 and 4 toxicities, so the higher the grade, the more severe, are all dominated by anemia, low white blood cells, low platelet counts. And this is due to the lymphodepleting chemotherapy that these patients get. So this is expected. This is not product related. And one other encouraging aspect is that even in the context of targeting GD2, there isn't really detectable pain-related side effects. You see some here, but these were reported, but actually these were coming from patients who had progressive disease and were usually related to involved sites that became painful. In this study, there were some objective responses again. Here, the color coding is different, just to confuse everyone. So here, you want to look for green and yellow. Those demonstrate anti-tumor activity. And here is an MIBG, and this is the planar scan, and here are the specs, where the red circles show the involved disease and how that disappears after the infusion. Keep in mind that the cardiac muscle can take up MIBG. So this is not disease, but this part is, and so is this area. So that being said, well, if you are interested, and I hope that this short presentation gave you enough insight and perhaps triggered some excitement toward these trials, because I do believe that these can hopefully change the way we treat cancer, and particularly neuroblastoma moving forward. So I wanted to highlight, to my best knowledge, the current investigations in Europe and in the US. And just going over first, this study is testing, evaluating glypican-2 specific CAR T cells. So this is a novel antigen that that was identified by John Maris's group at CHOP, and now there is a phase 1 clinical study evaluating the efficacy of GPC targeting CAR T cells. Another trial that is still ongoing, targeting GD2 using a second generation receptor in T cells that also co-express IL-15 is running at UNC, and I put up actually the contacts here for you all. A third study that you might want to consider is the one that I just mentioned and showed the results for, is the GD2 CAR NKT cell study that's run at Texas Children's, and it is targeting GD2 with the IL-15 and GD2 CAR expressing NKT cells, and Gangwen Tian is running now the study. The trial that I mentioned from the Italian group is now in the phase 2 setting, so they are looking at efficacy, not just safety primarily. It continues to target the GD2, and Franco Locatelli's group is running the trial still in Rome. Another trial that is recently opened at St. Jude's Children's Research Hospital is targeting B7H3. This trial is run by Chris Durenzo primarily. And this is exciting, as similar to GPC2, it's looking at another target antigen. Bilal Omer's group at Baylor at Texas Children's is also targeting GD2, but in this case, they are trying to improve the efficacy and anti-tumor activity and persistence by using a new molecule that's constitutively giving interleukin-7 signaling to the cells to survive better. And then lastly, Crystal Makal's lab developed an approach to target GD2 with a second generation CAR that's expressed in T cells, and they use a unique manufacturing procedure that enables the cells to be less exhausted while they are being grown outside of the body, and this study is now running in a multi-institutional setting. So I hope that these might be interest of you, and I hope that if you are in the situation when some of these might be relevant to you, then feel free to take a picture and spread the word. So that being said, I think thus far we've demonstrated, the field has demonstrated that CAR T cells are safe in children with neuroblastoma. The persistence and expansion seems to be a really critical aspect of anti-tumor activity. Complete remissions now can be achieved in children with neuroblastoma. Some of them can be perhaps even durable. And then there are several studies. It's really, really exciting, and I think we should be very optimistic that some of these studies are going to be finding finally strategies to induce durable complete remission in children. And with that, I just want to thank all the patients, families, and referring physicians who really get these studies enroll efficiently. And this is my lab. Obviously, I benefit a lot from them. And Texas Children's has a neuroblastoma program, and with the leadership of Dr. Foster is really an exciting group to work with. And those are my contacts if you need to get in touch. Thank you.
Does anyone have questions?
Thank you, Doctor. I have two questions. One, is CRS a concern when talking about CAR T cell therapy and neuroblastoma? And two, has there been any translational research done specifically in regards to machine learning to try to predict efficacy and toxicity for patients going through CAR T cell therapy for neuroblastoma, specifically seeing if it can be done in an outpatient setting.
Yeah. So the first question, CRS, cytokine release syndrome, thank you for bringing it up. That's indeed very much a concern still. But nevertheless, I think so the cytokine release syndrome is well described in patients with leukemias and so the blood cancers, and occurs in the majority of patients and is actually associated with good anti-tumor activity. I think, we learned so much about CRS now that we understand how it's mediated with interleukin-1 and interleukin-6 signaling, and there are specific drugs that can disrupt it. So I think unless there's a different mechanism for cytokine release syndrome in the context of neuroblastoma, I would not be necessarily too concerned about it. I'm not saying this is not an important safety aspect, but I think it would be very unlikely that we infuse CAR T cells, nothing happens and the tumor shrinks. I think, if these cells get activated, just like when we get a fever, when we have the flu and these cells are activated and fighting the virus, we should expect some of those, febrile illnesses in patients where the cells are working. Of course, we don't want it to go out of control. So, how to mediate this is certainly going to be an important thing to look at. As far as, AI and machine learning and those, I think that's going to be really exciting to see to evolve. Right now, there's just so few patients, right, that it's very hard to train a machine when you have, an N of 12 to input. But later on, certainly, yes, because the number of analytes that we can measure now is just so many that it will be certainly helpful. I hope so, yeah.
Anyone else? Yep, go ahead.
So yeah, to kind of piggyback a little bit on the CRS, you explained there's a little bit of, there's medication, steroids or whatever that can cut down on that inflammatory response. Are there any other, would you give chemotherapy to maybe help that as well? Or I guess, yeah, are there other ways to help a CRS response calm down
yeah.
to preserve a life, that kind of thing?
So there are a number of drugs out there that can be used to temper CRS if it happens. Tocilizumab and anakinra are the primary ones that people look at, targeting IL-6 and IL-1. Those are two molecules that mediate this primarily. And then if that fails, there are a number of other strategies that can be employed. So tumor necrosis factor alpha inhibition is one of them. Then, giving steroids. And ultimately, one can just give lymphodepletion again and to eliminate the cells. That being said, that's what everyone is trying to avoid, because once we go past the direct immunomodulation of, TNF-alpha or interleukin-6 inhibition, we are going to hit the tumor-specific cells as well. And maybe if they are overactivated, it is fine to temper them. But once we get to chemotherapy, let's say someone gives fludarabine to someone who has CRS, I think that would probably eliminate the anti-tumor activity as well.
Okay.
And then there are some attractive strategies to include, safety switches in these CAR T cells that can ideally dial down, not just turn off the cells, but dial down their efficacy. So for example, the Italian group did have the inducible caspase-9 in their construct. It was only used once in the case of a central nervous system bleed, which was actually not even related to the study. But there are now genetic engineering strategies to help with this. Yeah.
Okay, and sorry, I kind of have two more to build upon.
Yeah, sure.
In your experience with CRS and disease load, is there any correlation with how minor or severe a CRS response would be in regards to a disease load, low versus high disease load?
So I think from neuroblastoma, we don't have strong correlation yet because there's just very few patients who've been treated, and then, of course, very few patients actually had CRS. But in the leukemia world, higher disease burden corresponds with higher risk of CRS.
Okay. And then, sorry, last question. With some of these slides you shared, like there's like a partial response, right? So obviously there's still disease present in the body. You want to still preserve those CAR T cells, right? That have helped, that are doing their job. Are there therapies that should be avoided down the line to help preserve those CAR T cells so that they can still do their job while we're still working on, knocking down more disease?
So before I get there, actually, one thing to consider is that these infusions can be done multiple times. So that's something that I think being evaluated, whether additional infusions are helping at the same dose. And then another interesting aspect is whether one should be able to do safely intrapatient dose escalation. In other words, if someone was infused on dose level 3 and has a partial response and had no major toxicities, can we actually dose escalate to dose level 4 in the same patient and see if now the higher cell dose will eliminate the disease while maintaining safety? So those are all questions that I think the field will try to answer in the next couple of years, hopefully. And then going to the other aspect that you mentioned, what should we avoid? So in general, after CAR T cells, if the patients go back to conventional chemotherapy or high-dose MIBG therapy, that is going to be toxic to the CAR T cells. So those will probably eliminate the cells. That being said, are there other immunomodulatory therapies that could help? For example, PD-1 inhibitor, checkpoint inhibitors, would they be helpful? I don't know. We did try in 3 patients and they didn't make a difference, but again, it's 3 patients. And there are newer and newer checkpoint inhibitors. So there might be something out there. I think that will have to be carefully assessed in the context of a clinical study.
Okay, thank you.
Anyone else? Any other questions? Nope. Okay, thank you, Dr. Huxy. We're actually on time. This is crazy. Anyway, we're going to take a 15-minute break. We have some snacks and stuff in the other room, so come back at 3:15.
That would be good. That works. Yes, that helps. Having efficacy. Yeah, I should be able to do that. That'll be good. Thank you.
here it is. Yeah, they were hiding it on you.
Oh no,
Oh,
is
there's
this
a
it?
different one?
Let me see if this works. Yeah, this is not. It was the stick one.
Oh, let's see, yeah, let's go check that table.
Not the stick.
Okay. Where'd everybody go? They're still eating pretzels. Our next speaker is Dr. Michael Barbato. He works for the Food and Drug Administration in the Division of Oncology. He performs clinical regulatory work, analyzing safety and efficacy of drug trials for the FDA. He's going to go through his bio a little bit more. But what I did, I asked Dr. Barbato to talk about the drug development process at the FDA. Again, more so from background information. So again, you know what's going on. You know, research isn't stagnant. None of this stuff is stagnant. It's constantly changing and moving. So I did ask him, you know, to talk about another arm of the neuroblastoma research process in the landscape and how we get from like point A to point B. So he's going to talk about the drug development process for pediatrics. Thank you.
Thank you, Pat. Hello, everybody. Again, I'm Michael Barbato. I'm a physician with the FDA. And I just kind of want to start kind of by saying we're kind of all here for the same purpose. You can raise your hand if you want. I'll raise mine if you know anybody affected by neuroblastoma. And I think that's pretty much everybody here. And that's an important aspect of what I'm going to talk about today, too. During this session, I hope that you will learn that the FDA's role in pediatric oncology drug development. The key points to understand in this is that the FDA can sometimes take years to evaluate a new drug application. And we often encourage advocates from patients to physicians to other groups to join in those decision projects through meetings such as Accelerate, as well as the Pediatric ODAC subcommittee. And then there are also ways patients can receive some of these drugs on trials, which would be the formal process through the drug development, as well as off trial, which would be individual or expanded access. And then during this meeting, you can feel free to ask a question. If you see something on a slide you want to ask a question about, or you can wait till the end. I think there's like 15 minutes for questions. And then, as we all know, the FDA is a regulatory body, and so I am a regulated body, and so you may see me reading from the slides fairly often because they're some precise language that I'll need to state based on their terms. So if you see me doing that. Okay. This is the disclosure slide. I have no financial disclosures, and I'm not going to be talking about any specific drugs that are on-label or off-label. This is a quick topic overview. We're going to talk about what physicians do at the FDA, the core development process, what expanded access is, and how we address challenges to developing pediatric cancer drugs. I just want to talk about my personal background. So you can see this is a map from Baltimore, where I live, all the way up to here, where we're presenting today. That is a picture of the FDA campus at White Oak, where I work. I work in Building 32. And quickly, a little bit more about my history. I did my pediatric oncology fellowship at Johns Hopkins and NIH, and I'm currently working at the FDA, and I hope to join the rare tumor clinic at NIH in just a couple weeks. So that'll be part of my, my work. And then I wanted to share just a quick thing about some of my patients that I've been seeing with neuroblastoma, which is why we're here. And I want to emphasize 2 points. You know, even though I'm at the FDA, I think all of us think, you know, we're clinicians first and we have the patient in mind. So when we're looking at all these applications to regulate these drug trials, we're thinking about the faces of our patients. And I certainly do. I think about a lot of my patients who have left a huge impact on me. And so that's the other thing. And also, we have to expect the unexpected at the FDA. When we're looking at the toxicity profiles of some of these drugs, we have to see what could possibly come up in our risk-benefit analysis. So this is a sort of a busy slide, but it's just an overview of the different centers at the FDA. There are many cogs in the wheel moving drug development in the United States. The Oncology Center for Excellence is the central gear with several main branches. The Center for Drug Evaluation and Research, CDER, is responsible for evaluating and overseeing many of the drug products for use in oncology. CBER and CDRH drive approvals for biologics and devices. Housed within CDER are several divisions. The relevant division to us here today is the Division of Oncology 2, which is responsible for doing many of the drug products for use in rare pediatric solid tumors, such as neuroblastoma. It's also the division where I work at the FDA. Division of Oncology 3 works with Ewing sarcomas, and Division of Hematologic Malignancies 1 and 2 work with pediatric leukemia lymphoma. Here is a picture of my team my team leaders, as well as my colleagues. This was actually at a baby shower of one of our people who is off on maternity leave right now, but she's right there in the middle. So that's who works on these drug products at the FDA. So these reviews are multidisciplinary, and I want to stress that. So we have quality of the product we have to review, pharmacology, toxicology, clinical pharmacology, clinicians like myself, and we have statistics and project management, such as who organizes all the paperwork. That's a big deal when you're dealing with thousands of pages on many different topics. So what do people like me, physicians at the FDA, do? At FDA, we review and oversee clinical trials, applications to assess efficacy, safety, and overall risk-benefit. We also do stakeholder outreach to patients and other experts, and much more, which I'll get into in a minute. At FDA, we do not regulate practice of medicine. For example, a physician may prescribe a drug or treat a disease or a side effect in different ways in different centers, and we do not regulate the practice of medicine. Another example of that, if a drug is FDA approved for use in adults, but not in pediatric patients, a physician can still prescribe the drug, and patients can receive it through off-label use, and we do not set pricing of drugs in any way. When we review drug products, we have a patient population at the center of our decision-making, because pediatric patients deserve and need more drugs that are specifically for their use and are rigorously studied and determined to be safe and effective. Here are a few articles that highlight the role of patient advocacy in pediatric drug development. The first article highlights how academic sponsors and industry partners have transparent collaboration, and knowledge sharing opens an important pathway for accelerating new treatments into clinical practice for children with cancer. On the first one, the critical role of academic clinical trials, there was a patient advocate who was one of the authors. Her name is Donna Ludwinski, as well as our former head of pediatrics at FDA, Greg Riemann, who is now at the NIH, was also one of the authors on that paper. The second article is by all patient advocates and discusses the importance of pediatric patients in clinical trials for innovative cancer therapies. Also listed here is the agenda for the Pediatric ODAC of 2022, where we met to discuss a novel endpoint response to induction chemotherapy, or therapy, because more than just chemotherapy, that we look at in clinical trials of patients with high-risk neuroblastoma. A patient advocate provided a great perspective about the need for accelerating research in high-risk neuroblastoma during that process. Patient-focused stakeholder engagement occurs in a variety of ways at the FDA. Some of these include conversations and cancer sessions, which will allow public dialogue between experts, patients, and caregivers on specific topics. For instance, I did one last fall on oncofertility, which is an important topic in my life and something I've worked for since fellowship to try and bring awareness and advocacy for oncofertility. So I'm excited for the next talk. Mini symposiums are another more formal way of presenting cancer topics and engaging experts and patients advocates as speakers with specific education goals. FDA fully supports and recommends inclusion of advocate representation at all stages of drug development for pediatric cancers, such as protocol design and FDA meeting participants. FDA fosters openness and encourages suggestions regarding future projects for patients and in the community. So the next section is going to focus on drug development. So you may have heard about phases of drug development. Different phases in practice can sometimes blend or overlap, but the general goals of phases of therapy are to stagger drug exposure in a less to more gradient to gain insight into safety and of efficacy of drug prior to its commercial use. Regulatory standard for FDA approval of new drugs requires substantial evidence of effectiveness derived from adequate and well-controlled investigations. Clinical benefit may be observed by showing an improvement in survival or quality of life, which is a traditional approval. Regarding the use of early endpoints, an effect on an early endpoint that is reasonably likely to predict clinical benefit or on the basis of an effect on a clinical endpoint other than survival or irreversible morbidity. That would be an accelerated approval. So for example, in November of 2020, FDA granted accelerated approval to naxitamab in combination granulocyte macrophage colony stimulating factor for pediatric patients 1 year of age and older with relapsed or refractory high-risk neuroblastoma. This approval was based on the observation of durable response and tumor shrinkage. Generally, the types of cancers in pediatric patients and adults differ in etiology and biology, and organ of origin and natural history, which has sometimes resulted in pediatric trials not being required under the pre-FDARA iteration of PREA. And I'll talk more about those regulations in a moment. The requirements were waived because the drug in question was being developed for cancer that rarely or never occurs in children, thereby making the necessary studies impossible or highly impractical. In patients are generally exempt from PREA assessment requirements under Section 505B, that's an FDA regulation, because they are for indications for which orphan designation has been granted. Sorry, that was a lot of regulatory talk. So a quick question before we get into more pediatric-focused areas. So the number of FDA-approved drugs for pediatric cancer is give you a moment to think about it, but I'll just give you the answer. It's over 50. We've done with 70 indications for treatment of pediatric cancers. So considering all of this in recent years, there have been over 80 pediatric oncology specific approved drugs. Here are some of these approved drugs, and several of them have multiple indications. You can see some of the drugs we just talked about today are on this list, and these have been approved between 2020 and 2023. There are many more prior to that, but these are the most recent ones. So, expanded access. At FDA, we encourage development of promising drugs for pediatric cancers with the goal of approval in pediatric population. However, prior to the approval of expanded access is another important way for pediatric patients to access drugs outside of clinical trials. Expanded access allows the use of investigational drug to treat a patient with a serious disease who has no other satisfactory options, with an intent to treat, also called compassionate use. This is in contrast to using an investigational drug in a clinical trial where the primary intent is research. Expanded access programs focus on three main types: the individual, the intermediate, and also treatment. For individual expanded access programs, a physician must determine probable risk from drug does not exceed that from disease, and take into account other factors that may be risks or benefits. FDA will consider possible harm to the patient and the scientific body of evidence for the drug product as evidence for likelihood of an efficacious response. FDA allows 99% of expanded access programs to proceed. And in order for patients to receive the drug under expanded access, the company must agree to provide their drug for that purpose. So this just has a little bit of information about expanded access and Project Facilitate. So under the Oncology Center of Excellence, Project Facilitate is a single point of contact call and information center created to help oncology healthcare providers or regulatory professionals submit expanded access requests for individual patients with cancer through FDA's expanded access program. If you want to learn more about this program or have an emergency IND request, the contact information is here and listed again at the end of this presentation. Here is the data on Project Facilitate. So this graph is shared directly from the head of Project Facilitate, and the bars indicate the number of applications received by age group and between 2020 and 2023. There have been over 400 applications for patients less than or equal to 17 between this time period. So a lot of people are utilizing this program. And this graph is from Project Facilitate again and displays the time to process an individual application. You can see that the vast majority of applications are reviewed in less than 24 hours and approved. Most applications come from academic centers. And here's some historical data spanning between 2015 and 2020, specifically on single patient INDs granted in the pediatric neuroblastoma population. You can see that each year there's about 1 to 2 dozen patients in the pediatric realm for neuroblastoma receiving these. Here are a few familiar drugs, products as examples of access through these expanded access programs prior to approval. Through expanded access, over 800 patients were able to receive dinutuximab before it was approved. Also Erwinia, over 1,500 patients, and Unituxin, as I said, greater than 800 patients. Addressing the challenges of pediatric drug development. There are many challenges to the pediatric cancer drug development. Some of these include increased financial risk due to the rarity of pediatric cancers. Trial designs may be limited by rarity, making it harder to have a timely and robust randomized trial. Further characterization of cancers based on a tumor biologic characteristics presents accrual challenges. For example, medulloblastoma is subdivided into 4 subtypes, each potentially with its own therapeutic strategy. There is an upside for potentially dramatically increased effectiveness for small subgroups. To address the need for pediatric cancer drug development, FDA has implemented several incentives and requirements for drug developers. Incentives include the Best Pharmaceuticals for Children Act, BPCA, which provides additional marketing exclusivity to sponsors who voluntarily complete pediatric clinical studies outlined in a written request issued by FDA. Another incentive is the Rare Pediatric Disease designation, where a sponsor who receives an approval for a drug for a rare pediatric disease may qualify for a voucher to receive priority review of a subsequent marketing application for a different product. In addition, FDA will award priority review vouchers to sponsors of rare pediatric disease product applications that meet certain criteria. Prior to FDARA, there were no requirements due to orphan exclusion, and because pediatric cancers are generally distinct from adult cancers. Laws addressing pediatric drug development include the Pediatric Research Equity Act, PREA, which I mentioned before, and the amendment by the FDA Reauthorization Act of 2017, FDARA. So PREA requires a pediatric study based on clinical indication, and FDARA requires a pediatric study based on molecular mechanism of action, and this was implemented in 2020. A little history on the written requests. Over 40 written requests have been issued by the Office of Oncology since 2001. Clinical trials included in 23 of the written requests have been concluded as of 2021. There are 29 ped-onc drugs granted exclusivity. For example, a recent use of this program was for dabrafenib and trametinib, which received approval for the treatment of pediatric patients with low-grade glioma in the spring of 2023. And this was completed based on the requests from a written request. In a few ways we can continue to improve are to have early and frequent engagement among stakeholders to prioritize agent investigation and development, assess research strategies and harmonize goals, and increase efficiency. And the Pediatric Oncology Program holds the Pediatric Oncology Product Development and Early Advice meetings with sponsors to discuss pediatric development plans. We also hold various meetings with stakeholders, including the Pediatric Subcommittee of the Oncologic Drugs Advisory Committee, the Oncology Subcommittee of the Pediatric Review Committee, PERC. It's a very long committee, as well as other public outreach meetings. One of the goals of pediatric oncology advocacy is to change the perception of clinical trials in pediatrics from the notion of protecting children from research to protecting children with research. For instance, last year, May in 2022, as part of the ongoing advocacy with FDA, the Pediatric Oncology Subcommittee of Oncologic Drugs Advisory Committee met to discuss the potential utility and steps to validation of an intermediate clinical endpoint, response to induction chemotherapy, and the development of new drugs for the first-line treatment of patients with high-risk neuroblastoma. I mentioned that in the beginning, and this is just to kind of tie it all up. With another subcommittee, meetings have focused on glioma, early endpoints, and drug dosing for pediatrics specifically. As we all know, drug dosing for pediatrics is much different than in adults. At FDA, there is a global and collaborative approach to pediatric cancer drug development and access. One way this is done is through Project Orbis. Project Orbis is a collaboration among international regulators to allow patients with cancer to receive earlier access to products in other countries where there may be significant delays in regulatory submissions, regardless of whether the product has received FDA approval. Accelerate Pediatric Strategy Forum is a multi-stakeholder platform where academic investigators, industry and regulatory agencies, and patient advocates share and discuss information and make recommendations to inform pediatric drug development strategies. The Office of Pediatric Therapeutic Pediatric Cluster meetings involve information exchange and discussion of specific product development safety concerns and general scientific issues with participating countries. These meetings help to avoid duplication of effort, unnecessary expenditure of resources, and design a comprehensive program to fulfill global regulatory requirements. Continued collaborative and effective communication and efforts among global stakeholders is a mandatory to fulfill the fully leverage scientific discoveries and bring new treatments to children with cancer. The Pediatric Oncology Program at FDA encourages open communication with these stakeholders that includes all of us and most importantly, patients as well. Thank you, that is all.
Thank you, Dr. Barbato. Are we allowed to ask questions? Anybody have any questions for Dr. Barbato? Oh, nope, we're leaving.
Oh, yes. There you go. Resources. No worries.
I was just wondering if we can get copies of your slides.
Yes, do you provide copies?
Oh, we can.
Is that-
Yeah,
Yeah,
we
that
can.
would be fine.
Okay,
Mhm.
if that's
So-
okay. Okay, thank you.
Of course.
Okay.
Yes, it was a lot of regulatory talk, so there was a lot to get through.
Anyone else have any questions? Oh, go ahead.
I may have missed the slide, but how long from start to finish does the drug development process take? And how
depends.
can we, or what's your best advice to us as
Sure.
parents on how we can help? Obviously, it's an approach that's going to take all of us stakeholders, but how do we get involved?
So there are a couple different ways. If you have a drug that you're already familiar with and you really like it and it's not approved yet, you can approach the FDA to try and join one of those subcommittees and be one of the guest speakers or write a letter and that type of thing for outreach. As far as the duration of the process, it can take many years. It can take a couple years depending on the trial and accrual and how rare the disease is. If there's only a few patients per year, it may take a very long time to get an adequate safety and toxic profile of that drug before it can be approved. But in that case, you could also get the expanded access to the drug through the Project Facilitate, which I mentioned up there.
Anyone else? And I think there's organizations out there too that do work, advocacy programs and stuff like that that you can contact as well, so.
Okay. All right.
Anyone else? Go ahead, Roz.
So one of the things that we always talk about in pediatrics are endpoints, and I'm glad you sort of brought that up, but
Sure.
Our issues are
Oh, goodness.
fact.
Roz, take it easy.
I
Take
did not
it
touch
easy.
that. How do we deal with these small populations of patients and proving efficacy, or what is our, how do we adjust our endpoints to deal with rare diseases?
So this is actually under a lot of discussion in the FDA currently. Like, how can we look at time to event endpoints versus overall survival, and how can we use that information to best suit these trials and for our patients? And so it's a matter of discussion, and I don't have an answer for you today, but I know we are discussing it too.
Yeah, we need it yesterday. Thanks.
Okay. Anyone else? Come on up.
One of the issues seems to be that some of these trials that are cancer research or research investigators, like in adults and other cancers, will receive federal funding and don't turn in their work for years, or if ever, if I understand it, according to the moonshot. That was a big issue that was discussed there. Is there any possibility that could be, is that FDA, could there be some kind of linking that could help motivate that these reports are getting back to the government in addition to when they're trying to apply for approval?
So as far as getting them to submit documents in a more timely fashion?
Yeah, because sometimes they never turn them in.
So for the trials I'm familiar with, in my personal purview, I'm not sure about the ones that maybe that are delinquent. I'm not sure about that, but we do have various levels of submitting requests for extensions or specific timelines that we have goal dates that we do try to enforce, and we send letters of delinquency and things if they do not meet those standards.
No, I was just thinking of in terms of NIH funding, and they're not reporting to them, if there would be some kind of linking to provide some motivation or
More of like a governing process for that. Yeah, that's a good question. We'll have to look into that.
Okay. Anyone else? Yeah, come on up.
Hi. I was wondering how similar the development process for drugs is between, say, adult cancers and pediatric cancers on a specific point. The reason that we have a conference like this with the parents and the doctors here is because there really is a lot of close cooperation between the doctors and research centers and the community that they're treating, so the parents and the patients. And so I was wondering whether or not that is similar to what you see in more common diseases, and whether or not, because we have such a close collaboration between all the stakeholders, really, maybe, I don't know how it goes up to regulatory bodies, but are there different options to approach regulation because all the stakeholders are already talking so closely?
Okay. Well, I can say one thing that you mentioned that kind of made me think was it is a small world in pediatric oncology. A lot of people know each other and a lot of familiar names today even. And so there's a lot of communication between those experts and the drug companies, and we encourage that so that there's openness and that clear communication, clear guidance for what's going on right now in the treatment setting for those companies to sort of follow those guidances and get that information to them before they even come to us with an application for approval. And that way, everybody's on the same page as to what would be the next step and best for the patient.
So I have one more question.
Sure.
You mentioned the voucher program that is supposed to motivate companies to look at investing in pediatric drugs as well as adult drugs. How well has that gone? How many companies have taken advantage of that and have invested in developing pediatric treatments also?
So I don't have specifics on how many off the top of my head, but the resource for the voucher program is in the resources page. So we can check on that later.
Thank you.
Okay, is that it? Okay. Thank you, Dr. Barbato.
Thank you.
Our last speaker for the day, we all set with slides? Okay. Our next speaker is Kristen Smith. She's the program manager for fertility preservation, consults with all young, newly diagnosed oncology patients at Northwestern's Lurie Cancer Center. She does this to help each patient understand their individual fertility risk associated with treatment, as well as options for fertility preservation. She works extensively with young adult oncology survivors to help each patient explore their unique family building options and reproductive health post-treatment. Helps run the Oncofertility Professional Engagement Network of the Oncofertility Consortium by providing support across the world to providers who participate in the network, and also answers the National Fertility Hotline and email to triage patients for fertility preservation across the United States. That was a long one.
It was really long. As I was up here, I'm like, okay, this needs to be cut a little bit. I need to stop sending this out. Yep, too long. Thank you guys all so much for having me. This is my second year here, so I'm thrilled to be back. I just came out of the Survivorship group where we could just really chat, sort of individually a little bit about treatment and how treatment's impacted fertility, and really have young adults share how they're feeling now about their fertility and kind of where they're at in their fertility journeys. And something that I really stressed there was that it is such an individual process, right? So I'm going to give you a lot of overall general information and things like that, but knowing full well this is such an individual decision to be made. It's such a family decision to be made. And it's not something that happens at one time point either, right? This is something that's going to happen over the continuum of initial diagnosis and then also well into survivorship. So just want to give you sort of some resources, a little bit of general knowledge. You know, you guys are all now helpers to other people when someone's been newly diagnosed as well. So I'm going to tell you kind of what's new about fertility preservation right now, so that as you're meeting other families who are going through this same thing at newly diagnoses, you can help them and you can give them information that they may otherwise not be getting at their institutions. And then I also want to just give you a little bit of information about, you know, what could we do now in terms of fertility. And I'll provide my name and email address and my direct office line. So if, you know, down the line you do have questions, because of this Oncofertility Professional Engagement Network, we do know a lot of the big players in this field. And they mentioned already, you know, pediatric oncology, yeah, is kind of a small field. So is reproductive endocrinology. So we kind of know who does oncology survivorship and things like that, and we're happy to help get you set up as you need it or as your child needs it. So I do have one disclosure. Ferring Pharmaceuticals paid for me to go to South Africa to speak at their National Oncology Conference. So I'm not a prescriber, so I can't actually write anything that Ferring actually makes, but they did pay for me to go to that conference. I think you should know about that. I do see patients, not just oncology, but when I am seeing oncology patients, I'm primarily focused in adolescent and young adult oncology, which the NCI designates as ages 15 to 39. So I actually am housed within the adult institution at Northwestern. There is a separate Lurie Children's Hospital that is, you know, conjoined with us, but there is a separate navigator actually who sees patients newly diagnosed. Where patients come to me from Lurie Children's is when they want to pursue fertility preservation options. In particular, if someone is in for sperm banking, egg banking, I don't think I've yet gotten an embryo banking from Lurie Children's. I don't think I probably ever will. And then certainly in survivorship, they come to me as well. But this is just giving you some general information about where we're at with adolescent and young adult oncology as a country. We know, and what you're going to start to see is that big academic institutions are going to start to have more comprehensive adolescent and young adult oncology programs that are going to include survivorship. And for us at Northwestern, fertility is a big piece of that. So we want to make sure that everyone has this consult about fertility, understands the risks, and then also understands what options exist. This is just, you know, is published out in JAMA. But gives you sort of a breakdown of what are the most common types of cancers. It's a super busy slide, but sort of showing you, you know, as patients age, so as I see patients in 15 to 19 and then up into 30 to 39, the most common cancer types are going to change significantly. So, you know, in my 30 to 39-year-olds, I'm seeing a lot more breast cancer, a lot more colon cancer than I am certainly in my 15 to 19-year-olds. So, you know, when we do fertility preservation at an adult center, we're very familiar with a lot of different oncology types and oncology treatment plans. And, you know, we were really lucky at Northwestern that Teresa Woodruff, who's a reproductive biologist, applied to the NIH and was awarded one of their roadmap grants, which gave her many millions of dollars to create the Oncofertility Consortium. And she actually came up with the term oncofertility. And, you know, prior to this, we sometimes were offering sperm banking here and there, but we weren't always talking about the implications that treatment was going to have on fertility. And once she started the Oncofertility Consortium, once she got this group and kind of moving together, we really saw a lot of momentum around the country. And so initially we had our National Physicians Cooperative, which was this group of mostly academic medical centers around the country, kind of banding together to say, yes, we recognize fertility is a need. Yes, we want to move forward. Yes, we want to make this more accessible for our patients. That's now expanded across the globe. So now we've got centers sort of all over the globe really pushing fertility preservation. And we're certainly not the only ones, right? Almost every single massive organization as it relates to oncology or pediatrics has a statement that's essentially saying the same thing. Sperm banking, egg banking, these are standard options for fertility preservation, and we should be offering them to our patients. So we know that when we're giving certain agents to patients that there is an impact on fertility, and not all agents are going to impact fertility. So I think that's really important to know. Just because your child has had chemotherapy, it doesn't mean that they're infertile, right? There are certain agents that are more high risk for infertility. Those are particularly alkylating chemotherapy agents, someone who's gotten any pelvic radiation, or someone who's maybe had a stem cell transplant. That's more of the high risk. A lot of the endocrine therapies, immunotherapies, those are things that don't necessarily have as high risks. I'm starring some things because you guys, and I've already seen some people nodding like, yeah, my kid had all that. Thank you so much, right? In this particular population, we're using a boatload of alkylators and, we're doing radiation. And so those certainly can have some very lasting impacts on future fertility. Lilia Meacham just published in the Journal of Adolescent and Young Adult Oncology what has been now sort of our guidepost on risk of infertility associated with treatment. And so what we're doing here is we're using something called a cyclophosphamide equivalency dose. So we can look at all the alkylators and we can plug them into this formula that Dan Green out of St. Jude's Children's Hospital came up with to sort of get a rough idea of total dose of alkylators that are used. So when you see that care summary plan that comes through for your child, you can see how much of each chemotherapy was given in total dose, and you can actually plug it into this calculator, and it sort of tells you, does this fall into a minimal risk? Does this fall into a really high level of risk for infertility? We're now using this particular table to also say whether or not someone's appropriate for more experimental options for fertility preservation, like tissue banking. But we all know this, you guys all know this, probably as you're talking amongst yourselves. You're like, well, my kid had this and my kid had this. Our regimens are changing all the time. So that means our risks are changing all the time. We're constantly tweaking protocols based on individual response. So it's not a blanket statement. Not everyone that's in that high level of increased risk is infertile. So again, kind of hearkening back to, it is really important that this is a very personalized and individualized discussion with your providers. I'm going to take all of you back to 7th grade, maybe health class, right? And we're going to talk about how boys make sperm. And just to clarify, and I should have said this off the bat, I'm going to say boys and I'm going to say males, and I'm typically referring to someone who has testicles, right? And I'm going to say women and girls, and I'm typically referring to someone who has ovaries. So I'm not always using general neutral terms, and I apologize in advance for that, okay? But when we think about how sperm is made, right? The pituitary gland is releasing luteinizing hormone and follicle stimulating hormone, and it's creating this entire cascade where testosterone is made, and then the spermatogonia cells, those are the cells that make sperm, get stimulated to make sperm. If something in this pathway gets mucked with, then sperm production can be mucked with as well. And so we know that specifically those spermatogonia cells can be impacted by chemotherapy, and in particular, again, alkylating chemotherapy. We don't often see that the Leydig cells, so those are the cells that make testosterone, we don't often see that chemotherapy has impacted those cells necessarily. When we start to get into radiation, though, it's like a no-brainer, right? If we're radiating the testes, that's going to have a big impact on both those Leydig cells and those spermatogonia cells. Something we don't always think about is if we're doing high radiation to the brain, we could impact the way that that pituitary gland sends those signals. And once we've really messed with that signal, we don't have a great way to replace that yet in men. So if we have someone who's got low testosterone, for example, and they go to a clinic and they're getting testosterone replacement, that exogenous testosterone is actually further impairing sperm production. So if your child has low testosterone, have them see a reproductive urologist and not just some general person who maybe doesn't understand how exogenous testosterone is really impacting the ability to make sperm. When we think about fertility preservation options for males, the sort of gold standard, the most commonly utilized option for postpubertal patients is sperm banking, right? So they get to talk to me, a total stranger, which is super awkward, about whether or not they're masturbating at home. They get to talk to me about coming to a collection room, masturbating in that collection room into a cup, and handing that off to our lab. We're going to analyze the sperm. We're going to tell them more than they've ever wanted to know about their sperm, so their counts, the motility or how the sperm are moving, and the morphology or how it's shaped. Based on that one sample, then we're going to try and freeze into as many vials as we can. With, for my young adult patients, I want to get them 6 to 10 vials stored so that they've got that as a backup. If I have someone who can't yet masturbate but is still postpubertal, then sometimes we can actually go with a surgical procedure called a testicular sperm extraction and go directly into the testicle and get sperm from the testicle that way. If I have a prepubertal young man who is not even making sperm yet, there is a new option called testicular tissue banking. And so there's a handful of centers around the country who are offering this. Most centers are sending that tissue to one researcher in Pittsburgh named Kyle Orwig. And Kyle Orwig is really doing some amazing things with prepubertal testicular tissue. So what he's doing right now is it's a wedge resection of the testicle that's taken, typically pre-chemo. That gets frozen, it gets sent to Kyle, and then the goal is that in the future we can take that tissue and take even maybe the stem cells from that tissue and repopulate the testicle with those spermatogonia stem cells in the future. And he's actually had really good success, and there is a little monkey running around. I think the monkey's name is Gracie out in Oregon that was born utilizing this technology. So he's had success in the non-human primate model. He has just opened up studies to be able to do this and offer this in humans as well. So we've been offering testicular tissue banking for probably about the last 10 or 12 years or so. So we do have some patients who are kind of at that point where they're ready to see if this works for them. So my hope is that in the next 5-10 years, we've got some really decent outcomes data that, we'll be able to share as well. So I'm saying this to you guys have all sort of already been through a lot of this, but I think it's important if you are chatting with another family, right, and they've just been diagnosed and they're just learning all these things, maybe one of these options is something that's available to them and to their child. But for most of us, right, like I'm a survivor, right? My child's a survivor. So what do we do now? Where do we go now? And this is a really like a when you're ready now. So I put pictures up there. These are my people at Northwestern that I love beyond nothing else. So Josh Halpern, Bob Brannigan, they're both reproductive urologists. So they've been trained as urologists, but then they went on to additional fellowship to really train in male reproductive health and infertility. And essentially, when I have a survivor who calls me, we talk about, what's been their treatment plan. I actually calculate those cyclophosphamide equivalency doses so that I can share them with my providers to kind of line out high risk, moderate risk, low risk. Then they'll be seen by one of these providers. Oftentimes, a history and physical is done. Sometimes now we're doing it via telehealth. Thank you, COVID. We're going through all their medications. We're doing blood work specifically to look at follicle-stimulating hormone. We're looking at testosterone. Sometimes your survivorship clinics, if you're at that point, will already be drawing these levels at some point on your kids. And so you have sort of this serial testosterone level that's been repeated for you. And then we're going to do a semen analysis, right? Which is so not comfortable. Again, it's like, please masturbate in a cup, please hand this off to our lab. And then we're going to kind of tell you, do you have sperm or not? One bad semen analysis isn't the end all be all. And that's why it's so important to see reproductive urology. Because after that, they can sort of say, all right, well, here's, if we see no sperm right now, here's maybe a couple of other options we can pursue. Here's maybe a couple of other things we can think about to make sure that if your child, if they're interested in this, has gone through every possible scenario to see whether or not they can have biologically related children. Something they can also talk about, though, which your kids may not be sharing with you, is some sexual dysfunction, right? So if there has been an impact to testosterone production, we know that low T can cause low libido, it can cause erectile dysfunction. It certainly may not be something that your kid's like, hey, Dad, guess what? They're maybe not sharing this, but a reproductive urologist can ask the right questions, and if there are some sexual dysfunction issues, can also help address that, again, when your kid's ready. Let's talk females, okay? Because it's a different ballgame. Men are typically making about 1,200 sperm with every heartbeat, right? Not the same for women. We're born with a set amount of eggs, and as we get older, we just keep losing those eggs. For most women in the United States, if they've never had something happen to them, they're going through menopause about the age of 51 or 52, and that's when all of those eggs are pretty much gone. Most of us, though, are done having babies in our early 40s. That's because what eggs are left have been so degraded and the DNA inside of them is just not capable of producing a live birth. So when we, kind of describe female fertility to our female patients, I sort of walk them through a whole menstrual cycle, right? Because I think, number one, a lot of people don't realize that they're born with all the eggs they're ever going to have with no way to make new eggs. They just assume because they see Janet Jackson at 55 having a baby that they'll be able to have a baby at that age too. And Newsflash, that's probably not the case, and maybe she used donor eggs or had her own eggs frozen. But so we'll kind of talk about what a menstrual cycle is like, because that also helps then facilitate the discussion about what egg banking looks like. So sort of each month, again, taking you way back to like maybe the 5th grade movie that you guys all had to sit through where you like learned about how babies are made. So each month, right, in a woman, her brain is sending follicle-stimulating hormone to the ovaries, and there's this pool of follicles that's sitting there. It's called the antral follicular pool. And one of those follicles gets selected. It then ovulates out that egg. If that egg's not met with sperm, about 2 weeks later, you have a period. And then that cycle just repeats and repeats and repeats. And that'll be important as we talk about what we do for egg banking. When we think about how our treatments are impacting female fertility, we're really concerned about the number of eggs that are left after treatment. So we know, again, particularly that alkylating agents can really decrease the number of follicles that remain in someone's ovary. When it comes to abdominal radiation, it's like a no-brainer that yes, it's going to impact that number of follicles, but another thing that abdominal radiation can do is really impact the uterine cavity itself. So when we've had women who've been exposed to pelvic radiation, what we see are higher rates of miscarriage. We see higher rates of intrauterine growth restriction. We see the blood vessels maybe not able to feed the placenta like it needs to during a pregnancy. So anytime we've had someone exposed to chemotherapy, radiation therapy, these are all big reasons that we would want them to be seen by reproductive endocrinology, and then when ready to have a baby, potentially even someone like a maternal fetal medicine to like really make sure that this pregnancy would be safe to carry out. This was a study, and it's funny because I presented this to the survivors, and I was like, it's kind of a newer study, and I was like, oh no, it's 2006. Some of these kids weren't even born yet in 2006, but for me, we were excited when this study came out because it was one of the first, and it looked at, young adult patients, but it was one of the first to take these time points of hormones and to see when someone's getting chemotherapy, which is that black line, that thick line down at the bottom, to see what acutely happens to those hormones. So in particular, AMH, or anti-mullerian hormone, it's a blood test that we can do on women, and that hormone is secreted by all these growing follicles in the ovary. And what you can see here is that AMH starts, around 1, and by that 3rd month of chemotherapy, it's already like completely dropped down. And then you see it takes a long time for it to come back. And for my patients who've been acutely exposed to chemotherapy, I'm typically telling them I don't want to see them for an AMH test until they're at least 1 year out of their last chemotherapy dose. Because if I take it at time point 6 months, post their last chemotherapy, it's still going to probably be very bottomed out and not give us a real number. We definitely do see some increase in it once we get to the 12-month, 18-month, even sometimes that 24-month mark. And this is a graph that I often use when I'm in the room with a patient kind of describing fertility. Again, showing this finite amount of follicles, how those follicles and those eggs inside decrease. And then again, because I'm seeing mostly adults, I'll have like a 20-year-old. And so we'll talk about if it's a patient who's not getting a lot of alkylating chemotherapy, still getting some, but not much. We'll talk about maybe that chemotherapy not having a huge impact on fertility. Yes, it may change the trajectory of when she goes through menopause. Maybe it makes it a year or 2 earlier, but the timing to which she'd have to get pregnant likely won't be significantly impacted. And I think it's important. I think it's important to still talk about fertility in those cases, but I think it's important to provide patients with the information that we think that they're going to be fine. If I have that same patient, though, and she needs to get some alkylators but doesn't put her in that high risk, what we talk about then is sort of this decreased time to which she'd have to get pregnant. So again, not making her infertile after treatment, but making it so that maybe she goes through menopause at 41 instead of 51. And that's just because she's lost sort of this cohort of eggs. And I certainly have patients that I see who are getting ready for a stem cell transplant, for example, who are going to get total body irradiation, really high dose alkylators. And in those cases, that treatment's going to put them into menopause directly. And so those are our very high-risk cases that we want to make sure that we can discuss fertility preservation so that patients have options if available. I also sort of gray this out because I can line up 2,100-year-olds and I can measure all of their ovarian reserves, and it's a bell curve. So obviously I'm going to have a lot that are right in sort of the normal range, but I'm going to have some who already have subfertility. who already, for a variety of other reasons, have lower fertility than we would have expected them to based on their age. And so when we think about fertility preservation options that we offer to our patients, egg and embryo freezing is probably what's most often done for our adolescent and young adult patients. The youngest patient that we have frozen eggs on was 10 and a half. And it's a lot to go through. It's a 2-week process. We'll get a little bit more into that. And it's not something that's for everyone. In some cases, when someone's getting pelvic radiation, we can do what's called an oophoropexy. So I just like to say that word. It's kind of fun. It kind of rolls off your tongue. But it's essentially where we take the ovaries and we tack them up outside of the pelvic radiation window so that we can kind of protect those ovaries. And then, potentially those ovaries still are going to produce some hormones too for that patient. We do this a lot in a lot of our gynecological malignancy patients where we're going to do some pretty hefty pelvic radiation. We can move those ovaries up and out and then potentially save them a little bit from that radiation. Ovarian shielding is something where they can put sort of a lead shield just where the ovaries are and maybe help protect a little bit from some of that pelvic radiation. When I actually did grand rounds for my radiation oncologist, they were like, no one does this. So I keep it on there because everyone talks about it, but they said in practicality, if you need pelvic radiation, you probably shouldn't be shielding anything in there. So it may be an option, but I think it's something to ask about. We also, and I don't know if any of you guys experienced this if your kids were old enough at the time, but in some cases we'll put patients on a medication called Lupron. It's a gonadotropin-releasing hormone agonist, and essentially what Lupron does is it just shuts the ovaries down. It's putting someone into a medical menopause. The theory being that if the ovaries are so quiescent and quiet, then maybe the chemotherapy won't do as much damage. And I say maybe because the data are very, very mixed on whether or not it actually works. So it's something that gets offered, but something that's offered with sort of this, we're unsure of how well that works. And then we're going to talk a lot about ovarian tissue freezing and kind of where the science is at with that. So egg freezing. Egg freezing from start to finish takes us about 2 weeks to do. We are using stimulation medications. So remember back to that slide about follicle stimulating hormone growing that one follicle. When we're using stimulation medications, it's just extra FSH so that we're telling instead of that one follicle to grow, that whole pool of follicles to grow. We sort of block ovulation midway through that cycle, and then we give a trigger to get those eggs inside the follicle ready for retrieval. And that's what you're seeing here. So this is what a retrieval looks like. It involves a transvaginal ultrasound, and using that transvaginal ultrasound, we can visualize the ovaries on the other side of the vaginal wall, and that's what you see in that sort of little picture that's in there. You can see that sort of black and white picture. That's an actual ultrasound of an ovary, and you can see this very white line going into a follicle. The follicles look like these black balloons. So when someone's under conscious sedation, so they do not feel anything, they do not remember anything, we use a needle, we go inside each follicle, we turn on suction, and we aspirate each follicle, pulling out the follicular fluid and the egg inside. Then we know that same day how many eggs we got. Those eggs get frozen. If someone has a sperm charming that they want to use, then we can fertilize those eggs, make an embryo, and those embryos are typically grown out to day 5 or 6, and then they're frozen at that stage. And something we talked about in the survivorship group was, at that day 5 or 6 stage, they can also do genetic testing. So you can get a lot of information back about these embryos if you want. So if there's a known genetic mutation, so if someone is a carrier of a BRCA mutation, a genetics company can create an assay and actually run each embryo against that assay, and then they give you a report back about embryos 1 and 2 are affected with this mutation, embryos 2 and 4 are not. They can also give you information about the number of chromosomes present in each embryo. And again, it just gives you kind of more information about which embryos you want to put back, which ones you don't, and what's going to make the most sense for you and your family. Egg freezing is a lot, right? So it's 2 weeks to do. Not everyone has that time before treatment starts. A patient has to be post-pubertal to be able to undergo this. We cannot make an ovary grow eggs without someone have already gone through puberty for the most part. It does involve transvaginal ultrasounds, which even as an adult are not that comfortable. So for young kids, it can be quite a bit to do that. Sometimes we can do transabdominal where we're looking through the abdominal wall, but it doesn't always provide the same results. And, the patient needs to be healthy enough to wait those 2 weeks and then to be able to undergo an egg retrieval, which just isn't always the case. One sort of caveat with this, and something that I run up against all the time, is people are like, oh, well, we have to wait for someone's period to start to be able to do this, right? The answer to that's no. We can actually start a stimulation cycle at any point in a menstrual cycle when we're doing it for these purposes. It's not a 100% guarantee if we've frozen eggs or embryos that that's going to result in a pregnancy either. So I think that's important to consider. You can see success rates. This is from our Society of Assisted Reproductive Technology. We sort of all pool our data together into this website, and it spits back, what are pregnancy success rates. But you can see those success rates, and this is with frozen embryos. Even in patients who are under the age of 35, only about 55% of the time are getting pregnant, and you can see, that significantly drops as the age of the egg gets older. So if we've got, an egg from someone who's over the age of 42, there's only about a 4.5% chance that they're going to get pregnant with that frozen embryo. Eggs are a little bit different. Egg freezing is a little bit newer of a technology. It was experimental until 2012. So I utilize this kind of graph when I'm talking to patients about success rates and kind of thinking about how many eggs do we want to shoot for. And I find this especially helpful in my survivors, right? So if I have patients who've already been exposed to chemotherapy, they know they have diminished ovarian reserve or not as many follicles left, but they want to freeze eggs after treatment once they're in their late teens, early 20s, then we kind of use this graph to help guide us about how many eggs do we want to try and get for you, right? And maybe that means more than one cycle. And so you can see here, if I've got 10 eggs in a 32-year-old, that's going to give her a chance of success for a pregnancy of about 50 to 60%. But if that patient's 41 and I get 10 eggs, that chance of having one live birth is about 20%. So that egg age makes a huge difference. Let's talk tissue freezing. So we have been freezing ovarian tissue in patients for about the past 14, 15 years or so. Essentially what happens is before treatment, we remove an entire ovary, we isolate the outer edge of that ovary, and we slice it into these cortical strips, which is what you see up here. These cortical strips are then frozen, and they kind of stay frozen until you're ready to use them. Historically, we've been doing transplantation with these strips. So we actually thaw the strips and we sew them back together in what looks like a quilt. And then we put that quilt back on the remaining ovary. The ovary recognizes its own tissue, starts to wake up, it gets the signal from the brain, and it starts to grow eggs on its own. And, the reports are a little bit mixed, but there are at least 130 live births from this transplantation technology worldwide. For some patients, though, we can't transplant that tissue, right? So I have patients who have leukemia, for example, and there's a chance that by taking that tissue out and then putting it back in them, we could reseed them with their cancer. So in certain patients, doing a transplant like this is contraindicated. So what we're working on, and a lot of different groups around the world are working on, is something called in vitro follicle maturation. So what we initially started with was encapsulating a follicle that we pulled out of ovarian tissue into a gel system. And then we send hormones through that gel system to coax that follicle and to coax that egg inside the follicle to grow. And we've had some success with getting mature eggs from that technology. It's super inefficient. So we had 44 patients that donated tissue for this. 65 follicles were isolated from that tissue, and we only got 4 mature eggs from that. But it was a start, right? And we all kind of have to start somewhere. So this was published in 2015. There's now been another group that worked on this in 2017. Another group just published it on 2021. So the hope is that, for my patients who right now are doing tissue freezing and need this technology in the next 15, 20 years, we've hopefully got this figured out. We're also looking at it in a new way. So we've been looking at 3D printers to help us create an artificial ovary. So what we've worked with initially was bovine ovaries, so ovaries from cows, because they're actually somewhat very similar to human ovaries. We've decellularized these bovine ovaries, and then we crushed that and made a powder. We then turned that powder into an ink, and we've been 3D printing a scaffold, so that we can create this ovary almost that we could then put follicles into so that we could coax lots of them to grow. So I think our hope here is that maybe we could even find ways to help with, getting someone through puberty with their own ovarian tissue. Maybe help with a little bit of hormone replacement. This is very, very, very new technology. We did start this in 2015, but we're still definitely working on it. I can't even guess how soon this would be ready, but I just want you to know that there's just this like crazy constant science going on, really all around the world. And that just because we made an ovary paper. So that's just showing you that we could like crumple it up, and it was like a very pliable paper that we made out of this ovarian ink. For a lot of you and for a lot of your kids, it's like, thanks so much for all this information. I'll sure to pass this on, but my kid's already gone through all this treatment. And so like, what do I do now? Where do I go from here? And, I'm big on reproductive endocrinology. So these are OBGYNs who did a special training and fellowship, particularly in reproductive endocrinology. And so as your child gets ready for this and starts to ask questions about, fertility or family building or things like that, these are really good people to seek out. And what they're going to do is just, like most doctors, a full history and physical. They're going to go through all those medications. Same thing for our REIs is that I send them the cyclophosphamide equivalency dosing. I tell them kind of where we're at risk factor-wise. We'll look at any surgeries that happened in the pelvic region. And then we're going to start with labs. So labs are something that can be drawn in Survivorship clinic as well. At Lurie, at the Survivorship clinic I work with, they actually get these labs for me so that patients have this information coming into us. But we're going to look at ovarian reserve, primarily do this through anti-Müllerian hormone. If someone's cycling and not on birth control pills, we can look at estrogen, follicle-stimulating hormone, luteinizing hormone. They can basically pull a whole full hormone panel, and that starts to give us an idea of current ovarian reserve or kind of how many numbers of follicles are in there. We can also do a pelvic ultrasound. Again, not for everyone, but sometimes we can see the ovaries abdominally to kind of get an idea of how many follicles we see. And if someone is partnered and ready to build their family, we are definitely going to also do a partner evaluation, right? This is not just all about women fertility. Even if someone's been exposed to chemotherapy, I've had plenty of patients come in as survivors with their partner, and they're like, we've been trying and trying, and we don't know why we can't get pregnant. And I'm like, it's because your partner has no sperm, right? So that's a huge part of this too. This is my go-to team at Northwestern. So Kara Goldman, Mary Ellen, Emily, these are all reproductive endocrinologists. These are like the people who, are going to do that initial intake. But I also then have a lot of patients that come to me who are already in menopause or who we know are going to be in menopause because of the treatments that they had. And I now am referring them out to my Center for Sexual Health and Menopause. So Tracy Kurtzer is a general OBGYN, but this is what she does, is just hormone replacement, making sure that everyone's on the right dose of estrogen that they need to be on to make sure we protect their bone health and their sexual functioning and their cardiovascular health. So I feel really lucky that I've got this team. We're all on the same floor. But I think, for you, if you're at a spot where, your kid is ready to start learning about this stuff, or your young adult is ready to start learning about this stuff, I would encourage you to find a reproductive endocrinologist or a reproductive urologist who can sort of start to help you guys walk through what things look like now. And I heard you guys at the previous talk, like, how can we be involved? How can we do more? Like, you guys already, you are here with like these amazing providers who are doing all this work. You guys are boots on the ground making things happen. We, throughout the country have been working really hard to get fertility preservation as a covered law, meaning that if someone's been diagnosed with cancer and they're going to get treatment that's going to impair their fertility, this should be a covered service. This shouldn't be something that people have to pay out of pocket for. It shouldn't be a decision that my patient has to look at their bank account to decide whether or not they can afford to do this. This should be a covered service. And so what you see here in the green are all the states that have passed legislation around medical fertility preservation. States in blue are working on legislation. States that are in that weird beigey yellow color had legislation that then dropped off, and then states that are in white have nothing going on. So if you're in one of those states and you want to get something going, the Alliance for Fertility Preservation, which is listed at the bottom of this, has been going state by state doing hand-to-hand combat with legislators to get this moving forward. And so when we did it here in Illinois, we went down to Springfield, which is way downstate. We talked with legislators. No one wanted to talk to me. No one wanted to talk to any of the doctors. They wanted to talk to parents, and they wanted to talk to survivors. And we had amazing parents that went down multiple times to educate these legislators about fertility preservation, multiple patients that went down multiple times. So that's how this stuff gets through. It is not from doctors and people like me. So if you're in a state that doesn't have law and you'd like to get involved, you can literally Google Alliance for Fertility Preservation. It'll pull you right into their website. Joyce Reinecke is who runs it. She's their executive director, and she is fabulous. She can help hook you up with the people in the state who are doing what needs to be done. So thank you. I'm the last talk of the day. I kind of joke that everyone should have had a glass of wine for this talk, maybe a couple, me included. But this is my name, this is my email address, this is my phone number. This website now takes you to Michigan State, which is now where Teresa Woodruff is president, but you'll still see my face up there. It's just a Michigan State website. But feel free, please, to reach out, or if you've got questions after this and you want to chat, I'm more than happy to chat.
Thank you. Anyone have any questions? Okay. Yeah, we'll have.
Hi.
Hi.
My daughter was diagnosed at 4.
Yep.
And after she just had chemotherapy at the age of 4, and then she went in remission, and she started to start to bud like normal kids do, having the she said woman business. That's what she called it.
I love it.
And then she relapsed at 8, and then we had to have chemo and proton radiation, and it's just like it just drew back in all the budding, everything. It just went away, and now they have her on the estrogen patch because she has like no type of cycles or anything. They never talked to me about preserving anything, or the big issues that say, hey, your kid may never have any kids. And she actually said she wanted a farm full of kids. Yeah. And so now she's like, she does not want to talk about those things. She kind of shut down when we go to the endocrinologist and stuff like that. So why don't the doctors tell us when we're about to do the chemo and radiation, like, hey, your kid's eggs are going to be fried. Let's see what we can do first to help these kids out, to say, hey, maybe you might want to have kids in the long run, so that would give them a chance, or the parents a chance, to figure out maybe there's something else we can do to prevent this when they get to become teenagers and think about it. They get depressed about those things, not being able to have kids and carry on their legacy. So why isn't this one of the things that's like high on the list to talk about?
Yeah, and I think you're going to find that by institution it's very different, right? So you're going to have certain institutions where they've got fertility champions, and this is top of mind, and they do discuss it. Sometimes they send me referrals, and I'm like, you guys, enough. Like, I'm good. No, this patient doesn't need to see me. But I think a lot of it is institution specific. I think a lot of it too is that, you guys all know this. Holy shit when a diagnosis hits, right? And then when a relapse hits. And then you've got all these other things that are going on, and everyone's trying to get you through all these things. And you're becoming an oncology expert in the midst of a complete existential crisis. And maybe it gets mentioned, but doesn't even filter through. I think what you'll find, and what we've definitely seen with pediatric oncology, is they are really pushing hard to make this standard, to make it so that in our electronic medical records, a questionnaire stops them from being able to move forward to give chemotherapy, to say, did you talk about fertility yet? I think you'll find that they are really figuring out ways to make this better, because you're right, this sucks when it happens and you don't know about it, and then your kid's dealing with infertility at the age of 16, and then dealing with hormone replacement and having to go through all these things that none of their peers are going through. They've already lost a lot because of this diagnosis, but to have that additional loss of family building the way they envisioned it really sucks. And I think what's happened is that you've seen survivors come back to their oncologist to say, what the heck? Why didn't you talk about it with me? And, you know, I can tell you around the Chicagoland area, I have been amazed at how well the oncologists do approach it and how often they're talking about it. And it's not just the first visit, but it's the second visit, and it's before chemo, and it's in survivorship. And I think as a whole, the group is really working hard to make this better because it shouldn't happen.
Okay. Any other questions? We got one here. Go ahead.
Jacqueline from Oregon. So like, what are the most common issues that you see in patients who are very young, like underneath a year, who went through chemotherapy for at least a year, and like what to watch for in them as they're getting older for like infertility?
Yeah, so I think, you know, I'm such a huge proponent of survivorship clinics, and I think survivorship clinics do such an awesome job at catching these things that you would want to start to look out for. So, you know, going through puberty is kind of this first piece of things, right? Like, does my child go through puberty on their own, and what does that trajectory look like? And the endocrinologists at pediatric institutions are so brilliant usually at like helping you walk through that. So if someone's gotten through puberty on their own, then I think it starts to get into what do menstrual cycles look like? And not all menstrual cycles are going to be regular. That doesn't necessarily mean infertility, especially in adolescence. But then it's starting to track those menstrual cycles, you know, starting to, if you're noticing any signs of menopause, and they're going to be the same as they are for us in our 50s. So hot flashes, night sweats, insomnia, mood changes. If they're going to tell you about vaginal dryness, I know, all these things suck. So if those are some of the symptoms that someone is having, then I do think it's probably time to have a conversation about what does my kid's fertility look like at this point, and then kind of seeking out, if you've got a great OBGYN or maybe a pediatric adolescent and gynecologist who can kind of help do some of that initial testing and then even further refer you to an REI, that would be the sort of the path that I would recommend.
Okay, someone else?
Kind of went along with my question. So you talked about this AMH test and how it should be 1 year post chemo. Is that age specific? Because I too have an infant that went through chemotherapy under age 1. So is that something that we should be monitoring now? She's only age 2.
Yeah, it's
or
not going to help
until
now.
Survivorship, because I know we're not going to enter survivorship till she's about age 5.
Yeah, I would even wait actually until she starts to get, if she goes through puberty, into puberty. Because it's really like, we don't even have norms for AMH until women are through puberty. And one of the biggest publications has like 17,000 enrollees in it, and it didn't even start till age 24 to give us like age norm AMH levels. There are groups with the Oncofertility Consortium we have, it's called the Pediatric Initiative Network, that have been trying to do some AMH studies specifically in pediatric patients so that we can have some of this information, but we don't have those sort of normalized numbers yet for that population. AMH becomes really more helpful as people get a little bit older, as they get through puberty and then kind of continue, but it's also not the end all be all, right? So it is one level. And this is what I tell all my patients, it's one level at one time point, right? And so it is something we'd recommend to be looked at. It also doesn't say whether or not someone can get pregnant. So we know women with exceedingly low AMH levels can still get pregnant. So having a very, very low AMH does not mean infertility necessarily. It just is more of like a, should we think about egg freezing at this point versus later? Yeah.
Okay. All right, we have you, and then we'll go to you second.
All right. My name is Peggy. I'm from New Jersey. You spoke of a calculator earlier.
Mm-hmm.
Is that a calculator that we can have access to, or we come through Northwestern for that calculator?
Oh, no. So it's published in the Journal of Adolescent and Young Adult Oncology, which is it's JAYAO, but it's like one of the medical journals that we, a lot of us in adolescent and young adult oncology kind of publish some of our works, but that's sort of where that calculator sits. Honestly, too, within your survivorship clinic, they should be able to do that for you and kind of pull it for you. It initiated out of a paper from St. Jude's from Dan Green, so that's kind of where they actually break down all the calculations and everything like that. Mm-hmm.
Okay, one back there.
Hopefully this will be a quick one. In the slide with the ovarian tissue cryopreservation, you had mentioned that BRCA2 would be kind of eliminate the patient from qualification for that. If the patient does not have that gene, but their tumor does, would that disqualify them?
Oh, this is one I've never gotten in 13 years. So the tumor itself had the BRCA2 mutation, but the patient doesn't. That would be a little bit more of a complicated case where I would 100% loop in my genetic counselor, who could help then delineate what risk of that. So the reason that we talk about it being contraindicated in someone with a sort of germline BRCA2 mutation is because those people are typically at risk for having ovarian cancers, right? And so we remove the ovaries prophylactically before that happens. And so the thought is, why would we then put that tissue back into them to maybe have that happen? Whew, if it's just in the tumor, I don't know. I don't know. Yep. I'm sad to leave it on a I don't know spot, but.
Okay.
But thank you guys so much
Anyone else?
for all your attention.
Oh, one
Yeah.
more question.
Yep, I'm sorry.
Yeah, we have one more here, or two more.
The legislation is really exciting, so thank you for that. Is that before or after treatment to get approved for something like that? And also, is there any benefit to doing the egg freezing after puberty? A child has had treatment early on, they hit puberty, doing that versus waiting for them to turn 20 and try to get pregnant naturally? Like, is there benefit to?
Sometimes.
Okay.
Sometimes, which is kind of a shit answer, I know, but it really is so dependent on that person's individual fertility and sort of their family building goals. And so, you know, I even see this like in some of like my med students, right, that are, you know, at Northwestern, and they're med students, they know they won't have a family for the next 10 or 15 years, and they're freezing their eggs up front because they know by the time they hit their 40s, their fertility will be subfertile. So, you know, I definitely, when we work hand in hand with Survivorship, it is all about very open counseling, right? And very much so, let's check these levels. Let's see where they're at. Let's talk about egg freezing. Is it feasible at this time point? Is it affordable at this time point? Will insurance cover it? These are all big factors into whether or not someone pursues this. And, you know, all that we want for these patients is to be able to make an educated decision about what's best for them at that time. And so I think in some cases where we're seeing AMH levels go down, 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 and we're starting to see someone go into menopause early, if we have that window that we can get some eggs, yeah, let's do it. But again, you know, it's not a guarantee that pregnancy will result from those eggs, but it's kind of the best of what we've got right now.
Okay, one more question then?
With the testicular tissue bank, is it possible to do it after treatment? Are they open to that, or are they? Okay.
Yeah, so Kyle, who, you know, runs most of the protocols across the country, he is pretty lenient on inclusion-exclusion criteria in terms of how much chemotherapy someone has had. He does still have some exclusion criteria that I don't know off the top of my head, but he has definitely enrolled patients in tissue freezing after they've had some cycles of chemotherapy.
Okay, and I assume emailing
Yeah.
him be the best?
He's amazing. Like, super on top of it. He's like really, really smart and also very, very normal, and you could have a beer with him, which is a rarity sometimes with some of our like basic scientists. He's fabulous, and his website gives a lot of really good information. He's got great coordinators. Yeah.
We've tried getting him 2 years in a row.
Yes.
So.
He's a busy man.
Yeah, so
Yes.
hopefully next year we can.
Yeah.
Okay, one more question.
When should parents, in terms of age of their child receiving treatment or being diagnosed, should be talking to someone like you?
I think that totally depends on where, you know, the parents are at a trajectory and the kids at too. You know, I think, you know, I have kids, like I had a 10-and-a-half-year-old who came to me and wanted to freeze eggs, and they knew that that's what they wanted to do. And we had a lot of ethics consults, but that's not every 10-and-a-half-year-old, right? I have some patients who are 20 and are like, I absolutely cannot do this right now. So I think it's so individualized, and I rely really heavily on our survivorship team to kind of initiate that conversation with families and sort of gauge interest there, and then based on that interest, you know, they kind of refer out to us.
Obviously, it would be best that they be talking to someone like you before any kind of chemo exposure.
1000%. That is always our goal, is pre-chemo, we can intervene if
is there, again, an age limit for at least some kind of counseling to give the parents some kind of idea what they might be, how to plan or deal with this if as chemo's coming?
Yeah, no age limit. So both testicular tissue and ovarian tissue go down to age 0.
Okay.
Yeah.
Then one last question, or please repeat it because I sometimes forget. You had on the map a bunch of facilities. Are they at the same capability as let's just say you are at Northwestern in terms of competence?
I mean, yeah, no, but totally. I mean,
yes. Is this? I mean, you know,
there are some just bang up fertility clinics out there that do really, really, really great work. But there are, you know, we're getting ready actually for our Oncofertility Consortium conference, and so there are definitely REIs who do a lot more cancer than others. You know, there's going to be some private clinics who, like, if you walked in there and you're like, my child had neuroblastoma, you'd see the REI like Googling what's neuroblastoma.
Right.
So, I mean, there are definitely some clinics, and they're typically going to be found at like large academic medical institutions, often where you see them in conjunction with cancer centers. Those are kind of the places to seek out.
About 15 years ago, my daughter was being exposed to chemo. And I want to thank Dr. Marcellian for setting it up. She was kind of a cutting edge on getting our daughter to see someone like you way before anyone was really even talking about it.
See what I'm saying? Pediatric oncology. Yes.
And one last question.
I was having this topic with another neuroblastoma parent in the past, and they made a comment that I've never really forgotten. They said, well, maybe kids with this diagnosis shouldn't be having kids in the future. And I don't remember if the context was like because of the diagnosis or because of the treatment. I don't recall that component of it, but I was wondering if there's some sort of data or how you would react to that.
I mean, did you see my face? I about threw up in my mouth a little bit. My reaction to that is that people are dumb sometimes. I mean, there are lots of different genetic mutations, lots of different things that go on, but I don't think any of that precludes someone from being able to explore biological family building. And I think, what a shitty statement, right? Like, yeah. There has been, to actually give some data, but Dan Green, again from St. Jude's, has done some studies on adult survivors of childhood cancer who were exposed to chemotherapy, and they did what's called a sibling study, where they followed both the patient and a sibling, and then they looked at offspring from both, so using the same genetic pool, and they did not see any increased risk of, offspring with genetic mutations or single gene mutations, specifically because someone had been exposed to chemotherapy or radiation therapy. So, I mean, that is pretty good data that's out there, and I think maybe, I'm sorry that you even had to hear that. Yeah.
Okay. Anyone? Okay.
I'm sorry I cussed a lot too. I'm realizing that is, yeah. So classy.
Okay.
Yes.
Mm-hmm. Thank you, Kristen.
Yeah, thank you, guys.
Thank you, everybody. I love your language. It's awesome. This concludes for today. We do have dinner, DJ, dancing, like I said, next door. They're setting everything up, and that'll be at 6:30. So if you feel like being, a part of it, you can go outside too, but it's free food. Come and enjoy it and have a good time. Thank you.